and the Patriot of Tamil Nadu IoT Channel shall put their hands together and on stage with the
Good morning, welcome you all to this meeting of IBD. I'd like to thank faculty
This is the image and the switch camera. The image which switch audio check audio check அவரோட சவுண்ட் அவங்க ரெண்டு பேரும் சவுண்ட்
Thank you, Lord. My close to the thank you, sir. I'm happy with each and every one of you. Very interesting discussion. Actually, mostly case-based discussion. So, this is the current position. I thank everyone and Swami for showing this area. And
It's now time for our first session. It is about the recent advances in IBD management. And for that, I request Dr. K.R. Palanikwami, HOD Dean for the gastroenterology for Apollo Main Hospital. Sir, I request you to kindly come and take your audible speech on the stage. And of course, our very special guest over here, Dr. P.K. Reddy, the Senior Consultant for Surgical Gastroenterology, Apollo Main Hospital. So, you to please join Mr. Palanikwami on the stage. Thank you.
First presentation.
The first session, we have two lectures that is delivered online. Delivered by Dr. Udit and Dr. Boshet. I think we are all both of them. Dr. Udit from from them. And we published and he was instrumental for the surgical community. Now, his problems and approach. Dr. Bhushan also has been our faculty in 2017 for the National IBD meeting. And recently, Dr. Bhushan was in Delhi for the IBD meeting organized by our meet also. And Dr. Bhushan is well known for his endoscopic influence. So, it's just like to have our Dr. Bhushan, Professor to say a few words.
Welcome to all our colleagues from our and really it is a very interesting topic what lots of
Switch one.
avenues because the development of
Level one.
treatment has completely
Change one,
revolutionized. And then the surgical treatment has completely come down, both the elective as well as the emergency treatment. What I used to do that has dramatically come down. And then we will see how the development of medicine, particularly the advent of
Change my dots.
things have totally changed.
Yes, just on the percentage.
Health Institute. It's a real pleasure to talk today to our audience on refractory. Before I proceed, I want to thank Dr. Paul Strong for the invitation to present. These are disclosures to our presentation. And our promise that includes by resolution and all that's present today are complete. So we do talk about medical options for different options. Currently, the easy. Steroids, they go beyond that. They still consider at least like modulators, IPOs, and methotrexate. And if you talk about biologic therapies, recently talked about small molecules which are so how do you want to define refractory? You want to define refractory because you try a patient on one treatment space and they will not respond in the surgical station. And then you try steroids and respond very steroid. Again, in Crohn's disease, you want to talk about dietary treatment. There is no role for 5-ASA in Crohn's disease, so you want to talk about steroids. And either they are steroid responsive, but they're steroid dependent, or they're steroid refractory, along with antibiotics. Then we talk about these patients have refractory disease. So if you have refractory disease, as I mentioned earlier, you talk about treatment options. And as I mentioned, ulcerative colitis includes 5-ASA and steroids, and Crohn's is mainly steroids, either steroid dependent or steroid failure. Then you talk about refractory IBD. And a lot of different options you can use for these patients for treatment. The first one we always talk about is immunomodulators. Of course, these are advantageous because they're inexpensive. They've been in the market for a long time. And these are 3 immunomodulators we use in our clinical practice, including azathioprine, 6-MP, 6-mercaptopurine, and methotrexate. And if you look at the first drug, which is azathioprine, it's been traditionally used in transplant patients, and it has been used in IBD for almost 50 years now. And the 6-MP is actually a metabolite from azathioprine. And the active metabolite, which actually works for IBD, is the 6-thioguanine. So before we start any patient on azathioprine or 6-MP, we always measure the TPMT enzyme levels, because some patients have abnormal phenotype of this enzyme, which leads to high metabolism of azathioprine or 6-MP to 6-thioguanine, causing systemic toxicity. So the major things we worry about is leukopenia, which happens if they have a TPMT enzyme defect, which shunts all of the azathioprine towards this pathway, causing very high thioguanine levels, causing leukopenia. So it's a very effective option for maintenance. Again, it's not used for induction of Crohn's disease and ulcerative colitis. We always do a TPMT enzyme activity assessment, and if the levels are appropriate, start them on a low dose and monitor them very carefully. As I mentioned to you, leukopenia is a major side effect. Even with close monitoring and something we need to follow up very, very closely. That is an idiosyncratic side effect of pancreatitis, which happens in 3% of the patients, and also hepatotoxicity, which happens later in 1% related to the high 6-MMP levels. And so all these should be kept in mind when you start seeing patients with this disease. Methotrexate is another option, which is used for both for induction and maintenance only in Crohn's disease patients, and has been shown to be superior to placebo in this randomized controlled trial published in the New England Journal of Medicine. Again, in our clinical practice, we use methotrexate predominantly in combination therapy with biologics. Again, you should be careful in patients with liver disease and usually use in combination with a biologic treatment. And we prefer sub-Q rather than oral just because it is more tolerable, more easy to take for patients. We go to the next step, which is a biologic, which is usually the standard of care for refractory IBD patients in our practice. There are different biologic options available for treatment, starting with earliest options anti-TNF, which is approved for both IBD, ulcerative colitis, and Crohn's disease. And anti-integrins, which is vedolizumab and adalimumab, anti-cytokines, which is ustekinumab and risankizumab, and the 2 oral medications available for treatment of ulcerative colitis, including JAK inhibitors and S1P receptor modulators. They also use for other indications enlisted here. So if you have a combination of a patient with IBD with other autoimmune diseases, you can choose wisely based on other alternative options available to treat the patient. So we want to choose induction therapy wisely because you want to start an appropriate patient for a patient with severe disease. And also, induction requires intensive therapy compared to maintenance treatment. Always do not forget surgery is a great option also in patients, particularly with ileocolonic disease, with restricting disease. You should always think about surgery as a first an option or an upfront option. Again, these biologics are complex protein molecules, which means that they can have clearance issues and the levels will change. So patients' weight gain, presence of inflammation, low albumin can also change the levels of the drug. And always try to use a focused selective therapy compared to a systemic therapy. Also look at the comorbid illnesses before you start the treatment. So this schematic shows the mechanism of how IBD activates inflammatory markers. If you look at it, whatever triggers the damage here in the colon of the small intestinal mucosa activates the T cells. The Th1 and Th17 are predominantly inflammatory cells which cause damage, and they produce TNF-alpha as an cytokine. This cytokine is implicated in the major damage you see in IBD patients, and that's the reason anti-TNFs are used currently in the treatment of IBD. These are different anti-TNFs currently available for treatment, including infliximab, in the first one here, adalimumab, golimumab, again the Fab fragment alone, which is certolizumab. All these drugs are equally effective in the treatment of ulcerative colitis and Crohn's disease, and they've been proven to be useful for management. So we have a lot of data on anti-TNFs because the earliest drugs available for treatment of IBD. We know that they are very effective treatment options for both ulcerative colitis and Crohn's disease, but all of them are proteins, which means they're immunogenic, which means that they can create antibody formation. To be most effective, you want to use a high dose of induction treatment and a regular maintenance treatment along with immunomodulators to reduce immunogenicity. You always want to use combination therapy, and it's been shown again and again that combination therapy is more efficacious than monotherapy. And loss of response can happen either because of immunogenicity or pharmacological changes, such as either because of low albumin or mechanistic escape because the mechanism of inflammation changes from anti-TNF based to some other inflammation. Of course, the risk of infections there, including risk of infections and neoplasia, particularly if used along with steroids and thiopurines. So how do you want to maximize the response to any biologic, including anti-TNFs? you always want to treat them very, very early before the complications happen. You always want to show a complete response, which is treat to target, which I emphasize in the subsequent slides. You always want to use combination therapy if possible, understand the PK and the pharmacodynamics of the drug you use so that you can proactively monitor the therapeutic drug monitoring and make changes in the drug to appropriately manage the levels. Studies have clearly shown, as I mentioned, biology doesn't matter. The remission numbers are much higher compared to later in the disease course. So always the most important teaching home message is start them early on treatment so that the patients may have a huge improvement in symptoms. Also, the phenotypic features make a difference because if you look at it, when Crohn starts, it's predominantly inflammation. If we don't treat during this inflammation, it goes to a stricturing disease. And the response is always better if you treat them in inflammation rather than when they reach stricturing, because the response to stricturing disease is unlikely from inflammation, and they most likely will need endoscopic or surgical techniques to manage their stricturing. And recently, we have embraced the concept of treat to target for patients with IBD, where you identify a target, benchmark the target based on initial examination, initial basal evaluation, and then try to reach that target with the current treatment options. And we always want to pair clinical parameters like symptom response, like patient-reported outcomes like bleeding, diarrhea, abdominal pain, and pair them with more objective markers, for example, either clinical biomarkers like CRP and calprotectin, or more definitive endoscopic markers of remission, either the Mayo endoscopic score or the SCD score for Crohn's disease. In the future, we are transitioning more towards radiological healing for Crohn's disease and histologic healing for ulcerative colitis, but again, it is too early. So these guidelines have been recommended by the STRIDE 2 guidelines, where we use this routinely in our practice to follow patients and make objective decisions. So just to go back to anti-TNFs, again, they're very advantageous because they work very fast. They work very well for extraintestinal manifestations as well. And they have very long and very well-studied pregnancy safety data. The limitations are obviously the risk of infections, the reactivation of tuberculosis, the need for combination therapy, at least for the first year of treatment. Obviously, if you have a demyelinating disease like MS, they are contraindicated. Or patients have a history of lymphoactive malignancy, they are relatively contraindicated. So those are the drawbacks of this drug. But overall, if we use them early and appropriately, these drugs make a huge difference in how they do. The next drug I'm going to talk about for refractory IBD is anti-integrins. So the T cells which home the gut have alpha-4 beta-7 integrin on the surface of the membrane. So they bind to MAdCAM1 on the endothelium, and they transition out through the endothelium down into the gut to cause damage. So what does anti-integrins do? Particularly what we study right now is vedolizumab, because vedolizumab is almost absolute in the treatment of IBD in the US at the time. So the MAdCAM1 alpha-4 beta-7 integrin is altered by the presence of this drug. So vedolizumab binds to alpha-4 beta-7 integrin and prevents the T cells to migrate across the lymphocytes and produce inflammation. We have one data in making a decision to choose what drug for ulcerative colitis, whether you can choose vedolizumab or adalimumab for active UC, something called varsity trial. And patients were randomized to either of these two options, and patients did much better, either both clinical endoscopic remission with vedolizumab compared to adalimumab. Again, one of the major caveats of the study was there's previous anti-TNF exposure in equal number of patients, which could have biased results towards vedolizumab as well. And also, there's no dose escalation allowed, no drug levels are monitored. And so it's not a drawback of the study, but even with that data, with this data, we predominantly use vedolizumab as first line for moderate to severe UC patients in our practice. It's also a good choice for patients who are older, immunosuppressed, post-transplant, or who have underlying conditions like lymphoma, melanoma, where the use of anti-TNFs would be high risk for recurrence. The other treatment target I'm talking about is going to be anti-interleukins. The interleukin 12 and 23 are predominant cytokines which activate the Th1 and Th17 pro-inflammatory cells and cause more damage. So if you block this pathway, maybe the down cytokines will be implicated and we decrease, and they can actually control inflammation. That's the concept of how these drugs came into vogue. So we have two drugs now currently available in the US FDA approved IL-12/23 blocker, which binds to the P40 subunit of both IL-12/23 and causes inflammation to improve, an IL-23 blocker, which binds to the P19 subunit of IL-23 alone, specific for it, and decreases inflammation, which is risankizumab. Again, ustekinumab was shown to be in clinical trials to be more effective than placebo for both Crohn's and ulcerative colitis. So to answer the question, how do you choose the first treatment option? That was a randomized controlled trial comparing ustekinumab and adalimumab in patients with Crohn's disease who are bio-naive. And the hypothesis was ustekinumab was superior to adalimumab in achieving the response. But surprisingly, in clinical trial, they both did exactly the same in terms of efficacy and safety. And the only advantage of ustekinumab was the tolerability was better, and patients were able to stay on it longer compared to adalimumab. So, but the important take-home message from this trial is the clinical remission numbers is so significantly higher. And these patients were started very early on within the first 3 years of disease. So just taking home the concept of treating the disease very, very early before there is significant damage is very, very important for these patients. Again, endoscopic remission, exactly the same, no significant difference between these two groups. Ustekinumab is also been very effective in perianal disease as well, although most data is active infliximab. In the largest trials we have, both CVU and Stardust patients, almost 50% of patients achieved healing with ustekinumab, showing that it's a very good option for fistulizing Crohn's in addition to infliximab in the patients. Other huge advantages of ustekinumab, the IL-12/23 is a great safety data we have with no increased risk of serious infections compared to other biologics like anti-TNFs. Risankizumab is a more recently approved IL-23 blocker, and the studies have shown to be superior to placebo in the advanced motivated induction studies and the 45 as a maintenance study. And always come up with questions of what drug to choose, because the more the options, the confusion is more. So in terms of clinical trials for Crohn's, if you have a patient who is bio-naive, in this set of meta-analysis of clinical trials, infliximab and adalimumab highest ranked in achieving clinical remission endoscopic improvement who are bio-naive patients. Then where do you position risankizumab? Of course, in this clinical trial, risankizumab was not tried because it's not approved at that point when this meta-analysis was done. But in my opinion, it can be used for moderate to severe Crohn's disease. You can use it after prior biologic use or even before anti-TNF use. We have some data from psoriasis and psoriatic arthritis literature where risankizumab was compared to ustekinumab and is shown to be superior to ustekinumab, achieving remission in symptomatic improvement and remission. The same is compared to adalimumab and also so superior to this. So IL-23 mechanism appears to be very selective and very effective for treatment, that I could consider this as a first-line treatment for moderate to severe Crohn's disease at this point of time. When they go into small molecules, which more recently studied, small molecules are a huge asset to us because they are not complex molecules like the biologic. They are small molecules, which means that they can be delivered orally compared to an oral or a sub-Q formulation needed for a biologic. They have predictable PK. They do not have an immunogenicity issue, so you can start the medicine, stop it, and start it again with no trouble. They have a fast on-off switch. It means the on-off action is shorter, quicker, and off is very quick as well. And it is a great option for combination therapy or intermittent treatments or instead of steroids for induction treatment as well. Again, they're approved only for ulcerative colitis at this point of time. We have two classes, including JAK inhibitors, which is TOFA and OPA, and S1P receptor modulators, which are again ozanimod. Ozanimod basically is a very unique mechanism of action. Basically, is an S1P receptor modulator, which actually is on the surface of T lymphocytes, which home the gut from the lymph nodes. What this drug does is basically traps the lymph node T lymphocyte within the lymph nodes. So the lymphocytes which home the gut from the lymphocytes cannot travel to the to the gut to cause damage. So basically, they're trapped within the lymph nodes. That's why this drug works. Think about scenarios. We know that S1P receptor modulators can be used in bio-naive patients. If patients failed ASA treatment, you can consider as a first-line option. While the JAK inhibitors can be only used in patients who have failed anti-TNFs. The reason for this came from a study from RA literature, where older patients with atherosclerosis above 50 with cardiovascular conditions actually had a higher cardiovascular mortality with the use of JAK inhibitors, which led to the FDA to say that you have to use and fail anti-TNFs before you go to this class of drugs. Again, these drugs are very effective with the low albumin levels, which advantages for severe UC patients. Again, if you have concomitant multiple sclerosis, you can think of ozanimod as an option because it's approved for both indications. If you have significant extraintestinal manifestations, the JAK inhibitors work really well at that point. If you have acute severe UC, TOFA has been studied, and I believe UPA has the same effect as well for acute severe UC. Again, if you have heart disease issue, as I mentioned, atherosclerotic heart disease, it's preferable to be careful. Doesn't mean you should not use it. You should be careful in the use of JAK inhibitors. SNP receptor modulators should be careful with a history of type 2 heart blocks. It can be used with type 1 heart blocks, but cannot be used type 2. So if you have a patient with a type 2 heart block, you should be careful about not using a SNP receptor modulator, because a similar drug, like a SNP receptor modulator, has been shown to cause a bradycardia, although none with ozanimod at this point of time. If you have eye disease, specifically uveitis or history of diabetes, diabetic retinopathy, it's always recommended to get an eye exam before you start ozanimod. But these are the scenarios to consider before you start any treatment at this point of time. Again, for UC, in the clinical trials, again, infliximab ranked the highest to achieve remission. And if you look at patients who failed infliximab, both TOFA and ustekinumab was able to achieve clinical remission endoscopy improvement. Again, OPA and ozanimod is not included in the clinical trials when it is done. So we'll have more data as time comes by with more data coming up. So how to manage severe refractory IBD? You always want to make sure that the refractory IBD is because of active inflammation. You always want to confirm that the bowel is inflamed and not from irritable bowel syndrome symptom, and rather actually active inflammation. If there is active inflammation, always make sure there's no infection, because infection can trigger flares. You want to identify it. In India, probably tuberculosis is a big issue. Infectious diarrhea is a big issue. You always check for, infectious workup. C. diff is a big issue we see all the time. Campylobacter infections, things like that can also happen. So always look for infection cause. And then a third thing is, where is the drug? Either the patient has a low level of drug, like the figure here, where you can actually improve the dose of the drug and that patient can achieve remission. On the other hand, patient may have good level of the drug and they still flare up, which means that the mechanism of the drug is not helping anymore. So the patient has a mechanistic escape, which is causing the symptoms to come back. So you should think carefully and find the reason why they are refractory IBD before you start treatment at that point of time. So to conclude, summarize, you always want to treat them early before you get to a stage of fibrosis and scar tissue. Always think about comorbid indications when you think about starting treatment, because you could use one drug which can help multiple indications at the same time, particularly for the IBD patients who have multiple autoimmune disorders at the same time. Again, in moderate to severe UC, at least in our practice, we think of vedolizumab or ozanimod as first-line choice for refractory patients. And in Crohn's, without perennial disease, I think IL-23 or IL-12-23 is a good choice, reasonably. We have perennial disease, we always prefer infliximab predominantly, combined with immunomodulators, although adalimumab is equally effective. If you have failed anti-TNFs, we always consider ustekinumab or risankizumab as first line for Crohn's. If you have failed anti-TNFs, you always think about JAK inhibitors or ustekinumab as first line rather than vedolizumab after that. You always consider combination therapy as an option as well for patients. Do not forget the option of surgery in selected patients, because it can be a curative option at that time, and then you can do post-operative medications after that. Again, we have an annual IBD meeting, which is coming up in April of this year. I invite everyone to come and attend the meeting. It's a one-day meeting exclusively dedicated for IBD teaching. And again, I thank you very much for all the kind attention, and thank you again for the kind opportunity.
Dr. Uday Kumar, it was a wonderful talk, and thank you very much for enlightening the whole treatment for the refractory IBD. We started our practice with mesalazine and steroids, and then to methotrexate. I always remember for the refractory IBDs, we used to either to escalate, or after that we taper it down, the steroids. Once they fail at that stage, then those are the days when we used to do the surgery straight away. I remember Professor Golliger used to tell, That's the time you should do when the patient is in a good general condition, the recovery is good. What is to say. However, you very nicely covered all the biologics, and the days have changed and the new modalities have come in the treatment structure. We'll have the question hour after the second talk. The second talk is by Dr. Boshen.
Greetings. This is a topic I would like to thank Dr. Plan Swami and meeting organizer for the kind invitation for this lecture. My today's topic is endoscopic intervention in IBD. Last 3 decades, we are rapid involvement the progression of the endoscopic management of the inflammatory bowel disease, starting with the low adaptation of the structure to EMR, ESG of the colitis associated neoplasia, stenting, structurotomy, structuroplasty, sinusotomy, and fistulotomy for versus IBD surgery complications. And then clipping of the surgical leads. This area has also evolved beyond IBD in other areas of the inflammatory disease. This is slide a summary of the current indication of the intervention of IBD. I categorize into the 5 major items. Number 1 is a structure, which usually with the balloon dilatation, structurotomy, structuroplasty, and sometimes it's the stenting. Fistula and abscesses, and we were treating with a stenting, fistulotomy, incision, and drainage. Number 3, intraluminal lesions or foreign body FMT fecal microbiome transplantation. And number 4 is IBD surgery associated complication, mainly anesthetic leak, bleeding, and the structure. The treatment modality including bleeding control, clipping, and structurotomy and fistulotomy. The last category is colitis associated neoplasia. As anybody familiar with polytechnic, EMR, structure therapy. IBD associated structure can be classified into the various categories based on the location, degree, etc. I think the most important is the length of the structure. If the structure is shorter than 4 to 5 centimeters, we consider it a short structure. That most of them are amenable for the endoscopic therapy with the balloon dilatation structurotomy. The other things we need to have measure the degree of the structure. Roughly, based on the resistance to the passage of this pediatric colonoscope or EGD scope, we roughly categorize into mild, moderate to severe structure. The definition of the structure based on radiology versus endoscopy is different. Radiologist diagnosis of the structure is needed with pre-stenotic dilatation on imaging. In our endoscopy field, we believe it is simple and amenable, applicable. Just use resistance to when you pass the scope. If any resistance when you passage of the pediatric colonoscope or colonoscope or EGD scope, we say it's a structure. Therefore, radiographic and endoscopic definition of the structure in the literature and in the clinical practice may be different. This is a slide that shows the 2 definitions. The radiographic definition, you need a structure as well as a pre-stenotic dilatation. When we say it is an endoscopic structure, that means if you have a scope placed in the distal to the area, if you cannot go through the structure area or pass the scope through the structure area with the resistance we call is structure. So definition is different. So in the endoscopic definition of the stricture, we just classify it is applicable when we measure the outcome. One of the major outcome to measure the success of the endoscopic facility with technical success or short-term outcome, it is the passage of the scope after the endoscopic facility, i.e., if you are taken before the endoscopic facility, if you have a stricture not traversable to the scope, and after your therapy, and you can pass the scope through the stricture without the distance, we call technical success. If the stricture is mild or moderate, and when you before the stricture therapy, you still can pass the scope through it, but with the distance, then technical success is measured by the passage of the scope without resistance after the endoscopic therapy. How to differentiate inflammatory versus fibrotic stricture? It is very important in my practice. When you have inflammatory stricture, normally I use a balloon dilatation. And when you have a fibrotic stricture, I use a needle knife or IT knife for structurotomy. Now, there's a radiographic distinction. Use MRI, ultrasound, and the CT scan. I believe it is as an endoscopy, and the endoscopy description, characterization is important too. Basically, when you have a sinus stricture that is friable, we believe the inflammatory stricture is very hard to push, and with a lot of scar there, we call it as a fibrotic stricture. This is a slide to show the balloon dilatation of an endoclonic and asthmatic stricture. You can see that we will pass this scope in the area, and then pass the balloon. Ideally, use the wire-guided balloon, and then the target of the balloon size is 18, 19, 20, and you achieve the target size with several sessions. This slide shows the needle knife structurotomy, and we use an early machine in the setting of the ERCPI or ERCPQ, and we use electrical incision to open the structure. This slide showed endoscopic structuroplasty. By definition, it is a consistent of two components: endoscopic incision or endoscopic structurotomy plus placement of the spacer. In this case, we use the endoclips. So you incise the structure with a needle knife or IT knife, and put the clip there at the spacer to keep the structure, treat the structure open. In addition to prevent the perforation bleeding, I came up with a new classification of the stricture. Basically, classify the luminal structure, classify the bowel stricture into three major categories: interluminal, intramural, and extraluminal. Interluminal structure that including visual, inflammatory polyps, prolapse. Intramural, that means the narrowing of the process is the top in the bowel wall, fibrosis, muscular hypertrophy, and neuronal hypertrophy. And all of this can be treated endoscopically. And the last category, it is extraluminal stricture or constrictive stricture, caused by the compression from the fat, adhesion, mass, and the twist. In most of these cases, the treatment should be surgical. In rare occasions, we may use endoscopic balloon dilatation, such as twisting the bowel or the mesh, pinch the bowel. This is my computer drawing of the three different primary structure. Inflammatory polyps in the lumen, we call interluminal stricture. Intramural, the fibrosis here would be called intramural stricture. And extraluminal, that is compressed by the fat, lymph nodes. These are the three categories of the bowel stricture. Sometimes we will use this kind of the strictures, and they said narrow the bowel, even that happened in the ulcerative colitis, and more often in the Crohn's disease. And then you can see the narrow the bowel with And the suspected causes will be long-term use of the biologic agents, constrictive structure, intramural fibrosis, or neuronal hyperplasia. Those type of the structure is vulnerable for perforation from the bone dilatation. I normally treat this type of structure with the needle-knife or IT-knife structurotomy. About the stenting. The stenting is a very commonly used in malignant structure in the bowel, but hardly used in the inflammatory bowel disease. In rare occasion, we may use it, such as this one with the axial stent for the short ileochronic and osmotic structure, or use covered stent for the long structure in the atrial limb of the bowel in the patient with the ileal pouches. These are the hardly ever used, and they only used in rare occasion to explore the applicability of the stent placement for the treatment of the chronic disease. Next is a fistula and abscesses. Sometimes you can see this type of fistula in the ileochronic fistula very short. It's a main result resulted from the tight ileocecal valve structure. Now we have two conditions here. One is the ileocecal valve structure, other one is the ileochronic or ileocecal fistula. In that case, you can perform the fistulotomy as well as the structurotomy in one session. Basically, over the guide wire, you use a knife to cut and to place the endoclips as a spacer. This example here is a fistula here, and the ileocecal valve, and with the structure here and the fistula here. And you can do the over the least guide wire, you can put the fistula as well as the structure. Then you place the clips to keep the space open. Here another example, the fistula, ileocecal fistula. This is a narrowed ileocecal valve, and the fistula is from here to here, and you can use a needle knife, fistulotomy, or IT knife, fistulotomy, along with the structure. Here's when we routinely use a needle knife for the treatment of the perineal fistula. And you can see there's the fistula here with the small abscesses, and then you can treat with the needle knife under local anesthetic, and then with the betadine of the skin cleaning. Here's when we can up to the C-tongue, so the endoscopy. Here's the abscess here, and underneath of the abscess, there's a fistula. You can use a needle knife to treat the abscess with incision which you wish, and then use a guide wire to protect the fistula tract, and over the guide wire, and you can call the string C-tongue, and you can take a knot there. This example, fistula here is on inside, this outside detected with a guide wire. Over the guide wire, we introduce the C-tongue. The next one is intraluminal lesions, including foreign body, basal, etc. So here is the classic. Some of the patient had a caps endoscopy, for the caps endoscopy, an endoscope that tract. You can use a rock mat to take it out. And here is a structure above the structure in the lumen and the multiple fecal basal. You can treat the structure with the structurotomy of the lung dilatation, and then take the basal out with a loss. And here is anasmosis, very often in IBD, there is a ischemic type of the anasmosis bleeding, and then bleeding one with the contributing factor is dislodged staples. And then when I see the staple in anasmosis, if the surgery is beyond the 6 months, I remove all dislodged staples. This staple, I believe, is a contributing factor not only for bleeding, but also for anasmotic structure. Now, inflammatory part is sometimes this type inflammatory part is sometimes related to inflammation, sometimes related to the prolapse. It can cause symptoms, including bowel blockage and bleeding. You can you can remove it endoscopically. There's concern remove the inflammatory part along the risk of the bleeding. Typically, when you have the bleeding occur, I spray the 50% of the glucose the area. Now, so this we can deliver the fecal transplant. Fecal transplant here is the catheter of the instilled the stored material. Next one is IBD surgery associated with complications. So when you have the bleeding from anesmosis, try to avoid the cauterization of epinephrine. Most of the time it's bleeding from ischemia. The main tool we use is that we spray the glucose, or use a mechanical force, use a lot of the drips. And then here's a slide to show the different triangle leak. In all of these, this patient had either thermometer section, this patient has streptoplasty, this patient has the stoma. The common location of the leak is anesmosis. This is the leak at the transverse staple line, and the leak is actually the sutured area, and then this is the leak at the anesmosis or the stoma side, mainly at the facial level. So how do we treat? So this is a surgery for ulcerative colitis. Pouch surgery is a classic ileal pouch surgery. When you're at the ileal pouch, you have different triangular leaks. The main leaks, as shown the two here, we call the tip of the J leak, and this presacral leak is sometimes in the middle of the vertical staple line leak, and the anterior leak can cause pouch vaginal fistula. Now, if the fresh leak, if there's a small leak, you can use the clips. Large leak, you can use over the scope of the clips. It's a tiny chronic leak. Chronic leak is tiny, in this case, a small vaginal fistula, you can put it over the scope of the clip. Now, here is the tip of the J leak. It's a small, you can put the small, the through the scope of the clip. If the leak is big, you can put it over. Now, this is a presacral sinus, a very common happens in people with the ileal pouches. Around 3 to 5% of the patient with ileal pouch anal anesmosis for ulcerative colitis or familial adenomatous polyposis. So the treatment we developed endoscopic sinusotomy. Basically, you use a knife to treat the wall between the sinus cavity and the pouch body, and you cut the wall, and then you put the clip there. You convert the sinus into the larger diverticulum, basically incorporating the sinus into the part of the bowel. Now, this is a short example. The sinus here is at 11 o'clock. It's a sinusotomy, and then we'll do the clip there. And then next slide shows the healing of this sinus. Now, last the item we're talking about colitis associated with neuralgia. We have the polypectomy, endoscopic mucosal resection, or EM endoscopic submucosal dissection. So, because of the depth of the treatment, normally we at the mucosal level, we would the EM, we make closer to the superficial submucosa, and ESD, we have the deep submucosa, and then you can have the endoscopic full thickness of resection with the clip. Or there's a surgical side we call the transanal microinvasive surgery. So not all the inflammatory polyps are benign. Sometimes the inflammatory polyp look like this. Actually, more than 1 centimeter, you should remove it. This is a case, I removed it, and then it turned out to be the tubular adenoma. So that not all the inflammatory polyps appearance endoscopy is a totally benign. And then in my practice, any inflammatory polyp more than 1 centimeter big, small or big, are removed for the two purpose: to remove the risk of the dysplasia. Number 2 is a help to control bleeding, and sometimes the causes of the bowel blockage caused by those polyps. Now, this is the EMR of the sporadic neoplasia. It's a very easy to remove, which is the submucosal injection. It's a bit sad, but you have to take it out. This is a sporadic colorectal neoplasia. Versus when you have the colitis associated neoplasia, there are more challenges because of some fibrosis. In this patient, they have a flat region. I tried to the EMR, and actually I can't remove in the end block fashion. I have to remove in a piecemeal fashion. In retrospect, I would have to design the EST of this patient. Even the EST of this patient still run the risk of the submucosal fibrosis. Now, this patient has a residual polypoid lesions and related to sporadic rectal neoplasia. So then we do the clean EST very easy to perform. And this next patient had a larger area of the certain region in the rectum, is a colitis associated neoplasia, and then due to submucosal fibrosis, there's no way I can remove it in the block session. I have to remove it in a piecemeal session, and the patient went well. It will take a longer time to perform, and technically it is quite challenging. So now how about the thickness of the resection? And this is small lesions in the endoscopic full thickness resection with eclipse, and then the still have the recurrence. In this patient, even had the surgery. After 6 months of surgery, still showed the cancer in the osmosis or marginal cancer. So that's why the colon cancer, the disease process and the progression sometimes is harder to predict. Why? So the one of the factors is the submucosal fibrosis, extensive submucosal fibrosis in UC. The other thing is some people they want to the top down and bottom up the way of the cancer progression. For sporadic adenoma, typically the most severe dysplasia on the surface. So polypectomy is easy to take out. But for people with colitis associated with neoplasia, is a bottom up. Most severe dysplasia, high-grade dysplasia may be from the bottom of the bottom. And on the surface, it may be a little bit mild. And you can see the dysplasia and the superficial area, it is low-grade dysplasia. But the result can be more challenging. Here's the example. So there is a patient who has a stricture with an overly normal mucosa. We need to the biopsy has a low-grade dysplasia here, and we decided to have the surgical resection. After the resection, you can see that underneath it is already adenocarcinoma. This is the IBD associated with cancer. So that these sometimes when you perform an EMR, EST for IBD associated with dysplasia, you should be very careful and then run the risk and the benefit with the patients. And after the EMR, EST is still the closest survey of this patient. So this is the last slides, and over the last 3 decades, the progression of the intervention IBD. I talked about more gastroenterologists, endoscopists, and IBD specialists, as well as the correct surgeon interested in that area. We explore the nature of the structure, anorectal structure of the fistula, artificial intelligence, new stent, and the deep scope, direct elution stent, and the stent and the drone, and the cell therapy, stem cell therapy, optimization of the EMR and the EST, damage control, and also talking about the certification, training, and insurance reimbursement. Thank you again, and I'll see you on the link tomorrow. And,
Thank you, Dr. Bhushan. Thank you for the excellent lecture on interventional IBD. And since we overshot the time, we'll restrict the discussion to 5 minutes. Can I invite questions from the audience? They're online. Santosh, online. Dr. Bhushan and Uday, we are happy to interact with you.
Yes. Good morning, everyone. Good morning.
Can I invite questions from the audience? Yes, Dr. Vinit Ahuja.
Yeah, Dr. Bhushan, excellent lecture. As usual, like you raise the bar so much. So I wanted to ask you in between two things. One,
And hear it well.
Dr. Boshan, are you able to hear now?
Yeah.
Okay. So first of all, congratulations for an excellent talk, and you raised the bar. It's a pleasure seeing you doing procedures, and at what I would say, what surgeons were doing, you're gradually taking it away from them. So there were two things which I thought that you said. One was that you said that even in an inflammatory stricture, you would do a balloon dilatation. So the general teaching has been that for an inflammatory stricture, one may avoid balloon dilatation. So would you like to talk about it, one? And second is that you showed stricturoplasty endoscopically. Stricturoplasty has been the domain of the surgeons. So if you could also give us a little bit, some few details about it.
Yes, in general, actually, inflammatory. Thank you again, Vinette, and it's great to see you and online. So in general, both inflammatory stricture and fibrotic stricture all can be treated endoscopically, and sometimes we call it mixed stricture. That means it has an inflammatory component and fibrotic component. But there is it's all related to the definition of the stricture. So in our guideline, any stricture, which is regardless of inflammation or not, if you prevent the traversable to the to the scope or push the scope with the resistance, if you can do the gentle dilatation. But the gentle dilatation, if the inflammatory stricture is a lot of inflammation, but the scope still had a difficult to go through it, you can use a smaller size balloons such as 13, 14, 15. But it's like if the mixed stricture, you can do a little bit of larger balloon. But there's an important concept that is here. We are saying is according to the consensus of the guideline, if the inflammatory stricture have ulcer, especially those with the deep ulcer, we should avoid a balloon dilatation. But those patients would be benefited for structurotomy, because the structurotomy, you can select an area without ulcer and cut. The concept of this endoscopic structuroplasty, the same thing as a surgical concept. Surgical concept, especially this Holtz-Michelozzi the HM structuroplasty. Basically, what they do, they cut the structure in the horizontal section and stitch in the vertical section, vertical orientation. Now, the endoscopic structuroplasty, same concept. You open the structure, put the clip as a spacer to keep the lumen open. So this is the official term. And as a matter of fact, is not all the structure in even fibrotic structure can be done for the structuroplasty. Only those structures shorter than 2 centimeters, especially the side-to-side anastomosis at the ileocolonic anastomosis structure. This will be the patient at the benefit at the most. Then, for example, anorectal ring structure, you cannot do the endoscopic structuroplasty.
Okay, thank you.
Dr. Uday, what is the usage of small molecules from your side? How often use and
We use it. Thank you again, Dr. Palniswamy. Good to see you again virtually. We use it routinely in patients. For example, ozanimod is pretty much our first line in patients who fail ASA. So you try mesalamines for ulcerative colitis, they do not respond. Then we think about ozanimod as first line for those patients before they go to biologic treatment. In patients who have failed one anti-TNF, for example, they have tried infliximab or adalimumab for treatment of ulcerative colitis and they have failed that. Usually, JAK inhibitors, either upadacitinib or tofa is the first line for our treatment. So in our practice, if we look at the percentage of use, I would say 30% of patients are on small molecules in our practice. Very common, 1/3 of patients pretty much. So the growth is going to increase even more in the future, in my feeling.
Thank you. The last question from our surgeon, and probably we'll close the session. I would like to thank both Dr. Bhushan and Uday for the excellent lecture and the interaction. I just hand over to the mic to the co-chair. He's a surgeon. Probably the last question, maybe the question from Dr. Professor R.P. Shanmugam, the senior surgical gastroenterologist and transplant surgeon.
Thank you very much. I would like to ask Mr. Shen. You said there is a fistula treatment, ileocecal fistula. Ileocecal fistula, as I think it is a natural way of going through the same passage. Why should you treat it at all? If it is another organ, then you'll have to treat, but it's the same. Why should you treat?
Actually, it is the great question. In our experience, used to be, this is like if the ileocecal fistula, you leave it alone. And our experience found out it's that when you treat the ileocecal structure, so we have a criteria. The structure the fistula should not be the 2 centimeters thick, and the 3 centimeters should be shorter than 3 centimeters. Then the action would be you basically cut the structure, the ileocecal valve. They're basically widening that area by doing the structurotomy as well as the fistulotomy. Then our experience suggests after the treatment, the small bowel inflammation above that, so the terminal ileal disease inflammation, multiple patients, terminal ileal disease inflammation disappear. So that's if the patient, I can tell you in the future, if the patient had limited terminal ileal disease, only one dominant structure, ileocecal valve, with like a 20 centimeter disease, and then they have the fistula there. Great news for the patients. So you can treat the fistulotomy combined with the structurotomy, and then basically you can cure that patient. In Crohn's disease wise. But if you talk about that, if the fistula from the small bowel to like the sigmoid, then endoscopic therapy doesn't work. Don't even try to use a clip. Regardless of what kind of the clip, suture device doesn't work. It only worked for the perianal fistula with the fistulotomy and the ileocecal fistula. And then also prevent in the future that area can get abscess formation and a branch of the fistula.
Thank you very much, sir. Dr. Uday Kumar, thank you very much for enlightening all the gathering here with the management of refractory IBD. And Dr. Bhushan, you have practically covered what all the surgeons do it. So I thank you very much and for enlightening such a complicated endoscopic procedures.
Thanks both of you. I'm looking forward to see you physically for the future meeting. Thank you.
Okay, perfect. Take care. Bye-bye. Yeah.
Thank you very much for the very informative session on the recent advances in IBD management. Earlier, the treatment, symptom response, targeted synthetic small molecules, and indications based on the endoscopic interventions, as told by Dr. Uday Kumar and Dr. Bhushan, was very, very useful. Now we go to the next session, which will be about the initial evaluation of IBD. And for this, I would be requesting two eminent personalities to come and join us to chair this session. Before we go, we have one small information to share with you. The phones, of course, to be on silent mode so that we can really fully get involved in the session. And another important thing is the lead talk, which will be done by 2 of our delegates, will be 15-minute session to kindly maintain that to make sure we finish the session on time and have more time for the discussion. Yes, having said that, now I will introduce the chairpersons, Dr. G. Loganathan. Sir, can we have you on the stage? He's the HOD Department of Gastroenterology for Apollo Specialty Hospital, Vanagar. And of course, we have another very prominent personality who will be coming in. He'll be Dr. P. Padmanabhan. Sir, can we have you on stage? He's the HOD for Department of Gastroenterology, Meenakshi Medical College. Thank you.
Good morning to all of you. We are already 15 minutes late, and may I request Dr. Stuart to start up his lecture right now. Thank you.
Mr. Chairman. Good morning, ladies and gentlemen. I'm truly staggered. I started my gastroenterology career maybe 40 years ago, and the evolution of changes, the endoscopic and the therapeutic changes in inflammatory bowel disease over that time are truly mind-boggling. I'm going to take you back to basics. We're going to talk about the initial evaluation of inflammatory bowel disease and the role of endoscopy. As you know, endoscopy is central to the management of patients with inflammatory bowel disease. It provides crucial information for diagnosis, for the assessment of treatment, for the management of complications, the detection of dysplasia, and the prevention of colorectal cancer. But we're going to focus here on initial evaluation. So before we start, I think it's useful to consider what should we expect from our initial endoscopy when faced with a patient with suspected inflammatory bowel disease? Well, clearly, it should be diagnostic. It should confirm the presence of macroscopic inflammation and exclude any other pathologies. It's worthwhile remembering that the symptoms of patients when they present with suspected inflammatory bowel disease are quite non-specific. Change in bowel habit, rectal bleeding may be due to functional bowel disorder with a minor perianal abnormality, or may be due to an advanced colorectal cancer. So the primary function of our endoscopy should always be diagnostic. It's also important to document the distribution and severity of the inflammation and to look for potential clues as to cause of colitis. One of our primary functions, though, is always to try to distinguish between ulcerative colitis and Crohn's disease and identify any disease-related complications. And finally, of course, to facilitate tissue sampling for either histological examination, PCR, or culture. Which examination should we use? Well, of course, colonoscopy with ileal examination is the preferred method. And most patients will actually tolerate oral lavage solutions. I would recommend a PEG-based preparation because some of the non-PEG-based solutions can cause minor inflammatory change in the colonic mucosa and can cause some confusion. Obviously, if the patient has severe colitis, we should avoid colonoscopy and full prep, and an unprepared flexible sigmoidoscopy should be requested in order to prevent the occurrence of toxic megacolon. When we find inflammation, it's important to consider other conditions other than ulcerative colitis and Crohn's disease. Now, some of these, and this is not an extensive list that I'm showing you, but some of them are very much suggested by the clinical setting. So if the patient's been had radiotherapy, then radiation colitis may be a cause. Certain drugs are known to cause inflammatory colitis. Patients with vasculitis, the colon can be infected. So there are a wide range of conditions where the clinical setting can suggest a possible underlying cause rather than idiopathic inflammatory bowel disease. But in many of these conditions, you have to look for other ancillary tests to confirm the diagnosis. One of the problems, of course, with a colon is that it has a very limited phenotypic response to inflammation. So what may happen? It may lose its vascular pattern. So the normal reticular network of vessels may be obscured with erythema. It may become granular due to minor mucosal irregularity. It may become swollen. Various degrees of bleeding may occur either intra the mucosa or into the lumen, and ulceration may occur in different forms, either aphthous, as is shown here, or deeper, more discrete ulcers. And of course, with transmural inflammation, complications such as stricturing and fistula formation may occur. And combinations of these features may lead to characteristic cobblestoning appearances, where swelling, erythema, ulceration lead to a typical pattern of inflammation. Sometimes when we do colonoscopy in patients with suspected inflammatory bowel disease, we see features that suggest a specific cause. And this is unusual, but it does occur. So top left here, we see the typical appearance of pseudomembranous enterocolitis. The second one along is a little bit more unusual. It's amoebic colitis. It's a typical flask-shaped ulcer that sometimes is seen here. If I were to tell you the third one along was someone who presented with obstructed defecation, then this wouldn't surprise you that this was mucosal prolapse syndrome. Again, features which may look initially like Crohn's disease. The fourth one along is a patient, an elderly patient with extensive vascular disease, and these abnormalities occurred around the splenic flexure, a watershed area. This is ischemic colitis. If we come onto the bottom row here, we see an example of diverticular colitis, where the inflammatory change occurs in a diverticular segment and tends to affect the top of the tips of the folds that occur in the sigmoid colon. The next one along is in an immunosuppressed patient, and this is CMV colitis, and the characteristic ring-like pattern that we get. Non-specific, but certainly would raise a suspicion of CMV. And the final one, of course, is in a patient who'd had radiotherapy, and this is a radiation colitis. So all these are clues as to the underlying cause of the inflammation in the bowel. But usually, where particularly in areas where TB is present, if we see inflammatory change, we're looking to see if there are features that suggest either TB or Crohn's disease. Now, although none of these findings are specific, they are suggestive of TB or Crohn's disease. This study by Bay, performed from South Korea in 2017, looked at 40 patients who had Crohn's disease and 40 patients who subsequently were proved to have intestinal TB. And they looked at the endoscopic features that favored one or the other. And as you can see, fewer than 4 segments involved, transverse ulcers, patulous ileocecal valve scarring and polyps favored TB, whereas anorectal disease, longitudinal ulcers, cobblestoning, and proximal small bowel involvement favored Crohn's disease. Now, the problem with all of these is none of these endoscopic signs are either sensitive or specific enough to exclude TB and therefore allow immunosuppressive therapy if Crohn's disease is suspected. So other tests have to be undertaken to corroborate the diagnosis. What about the distinction between ulcerative colitis and Crohn's disease? Well, this is what we teach medical students. It's the distribution of the disease that helps us in this respect. So if we consider ulcerative colitis, the inflammation is continuous and circumferential. It starts in the rectum and extends proximally. And there's often an abrupt transition to normal mucosa in subtotal colitis. Whereas in Crohn's disease, we get skip lesions, aphthous or deep ulceration, and cobblestoning. And the presence of a normal rectal appearance or terminal ileal involvement obviously suggests Crohn's disease, but is not specific. So it's well worth bearing in mind that in patients with ulcerative colitis, the inflammation can be patchy, particularly if the patient has had treatment. And also the presence of a cecal patch or backwash ileitis can cause confusion. And it's worthwhile remembering that in 10% of cases, it's impossible to classify the patient with either ulcerative colitis or Crohn's disease on the initial examination. This is a typical appearance of a cecal patch. It is increasingly recognized. It has a fairly characteristic appearance. You see this island of inflammation surrounding the appendix with normal mucosa around it. It has the typical histological features of ulcerative colitis. And interestingly, it may predate the presentation of ulcerative colitis and may be also associated with anti-inflammatory drugs. Backwash ileitis is an interesting phenomenon. Its mechanism is unclear, although it's termed backwash ileitis and was thought to be due to the reflux of ileal content, reflux of cecal contents into the ileum. That mechanism has never been proven. If you look histologically in patients who have well-established ulcerative colitis coming to surgery, then 17% of them will have changes in the ileum. Endoscopically, the appearances are typically diffuse. It's usually associated, but not always, with a pancolitis, and severity tends to match the degree of colonic inflammation. There is an association with primary sclerosing cholangitis, and these patients often seem to have a higher risk of colorectal cancer. But interestingly, the presence of the backwash ileitis doesn't influence outcome of following ileoanal pouch formation. One of the important things that we need to do at the time of the initial examination is to grade the severity of the inflammation. So why do we do this? Well, largely because there is a very poor correlation between symptoms and the endoscopic appearance. You can see from this graph, it's quite an old study going back into the 1990s. They looked for a correlation between the Crohn's disease activity index, which is primarily clinical, and the endoscopic appearance, which is on the horizontal axis. And you can see there's no correlation. So we cannot judge the degree of inflammation in the patient's intestine by symptoms alone. And these scores that are widely available, and many have been developed, were introduced largely to facilitate clinical trials in order to assess the response to treatment. But one of the things that has emerged over the last decade or so is that the degree of endoscopic and also histological inflammation is a very useful prognostic marker for the patients, such that those who have residual inflammation, either endoscopic or histological, tend to fare worse in the long term. And therefore, it's become important to be able to objectively assess inflammation and its response to treatment. These scales are not without their problems, I would say. There is a degree of inter-observer variability. They're not consistently used. I think that's largely sometimes because of a lack of familiarity with them. But also the Crohn's disease ones particularly are somewhat complex and a little cumbersome to use. So two scales are widely used for the grading of ulcerative colitis, the Mayo and the ulcerative colitis endoscopic index of severity. The Mayo score, which is shown on the left-hand side, was developed by Ken Schroeder in the 80s and is a composite score, giving you a sort of 0 to 3, 0 normal and 3 more severe endoscopic appearance. The Travers score, Simon Travers developed this scale about 10 years ago, and it is somewhat more objective. It has been better validated, and I would recommend this one to you. And it looks at 3 individual parameters: vascular pattern, bleeding, and erosion or ulcers, and then gives you a composite score. One of the things that I think is particularly helpful is to have images in your endoscopy room so you can quickly check what your patient appearance is, and grade them accordingly. Crohn's disease is more difficult to grade, and that's largely because Crohn's disease, of course, affects different segments of the gut, and therefore has to be graded on a regional basis. We grade in the rectum, in the sigmoid left colon, transverse right colon, and then also in the ileum, and also has different phenotypic expressions as well. So it can be ulceration, it can be stenose, there may be complications. And again, these are rather cumbersome, rather complex, and I think often imperfectly used. Tissue sampling is obviously one of the primary functions of our initial endoscopy. And it's important to consider what biopsies we should take. Recommendations from a number of gastroenterological and pathology societies have suggested that normal and abnormal mucosa should be biopsies, and that 2 biopsies should be taken from each of the rectum, 4 colonic sites, and ileum, and also labeled in such a way that they can be identified, so that the site from the biopsy can be identified. And I think this is, again, something that we as endoscopists don't always do. And in specific situations, we need to take additional biopsies. If we were looking for TB, for example, you'd want to take multiple biopsies. It's quite good evidence that if you take 8 biopsies rather than 4 biopsies, your positivity, your pickup rate is greater. And also to consider whether we need to do PCR in individual patients. I'm no pathologist, but there are obviously certain histological features that favor one cause of colitis over another. They are listed on the right-hand side, but given the constraints of time, I think I will move on. Just a brief word about wireless capsule endoscopy. Clearly, this has revolutionized the endoscopic visualization of the small intestine over the last couple of decades. It is not a primary investigation that we use in patients with suspected inflammatory bowel disease, but it is helpful, obviously, when the symptoms suggest Crohn's disease, but the colonoscopy is normal, or alternatively, when there is indeterminate colitis and we're trying to distinguish ulcerative colitis from Crohn's disease. It is undoubtedly the best test for looking at the small intestine. It has a high yield and a much greater sensitivity than cross-sectional imaging. It also, recently, studies have suggested that it has prognostic implications as well. So knowing about if asymptomatic jejunal disease may be helpful in determining the prognosis and therefore guiding treatment. Capsule retention is a problem, of course, even in those with only suspected Crohn's disease. One of the issues that we sometimes struggle with as endoscopists is how we should document findings. Let's bear in mind that patients with inflammatory bowel disease have a lifelong condition. Our approach to management is often multidisciplinary, and therefore good communication between endoscopists, gastroenterologists, and surgeon is absolutely critical to the optimal management of these patients. And that's often done through good reporting of endoscopic imaging. This is a recent study that was published under the auspices of the European Society. And they, as often they do, they did a literature review and a Delphi process and proposed 32 key quality indicators that should be present on is that time? It is. I will round up very quickly. So 32 indicators. Now, I would not recommend that you necessarily document all 32, but endoscopic activity of each segment with photos in a standardized manner, grading activity using the scales that we've discussed, and taking appropriate biopsies and labeling the location is absolutely critical. And if there are lesions, we describe them in terms of the 5 S's. So the size, the shape, their site, their surface, and the surrounding mucosa. I will summarize by saying endoscopy is a fundamental component of the initial assessment. Keep an open mind about the causes of any inflammation you see. We need to clearly document distribution and severity, follow a biopsy protocol, particularly one that's been agreed with your pathologist. And also, finally, remember the patient experience. Patients with inflammatory bowel disease often have to have multiple endoscopies. It needs to be a good experience to ensure that they're compliant and adhere to follow-up arrangements. Thank you for your attention.
Yeah, I do appreciate the excellent talk with clarity. We will move on to the next speaker and
we invite Professor B.S. Ramakrishnan, HOD, Department of Gastroenterology, SIMS Institute of Gastroenterology, Hepatobiliary Science and Transplantation to deliver his lecture.
The next is pointer. Good morning, everyone. And thank you to Dr. Pandasamy and Dr. Basamani for this kind invitation to speak here. Now, we started this morning off on a high note, talking about the state of the art in terms of medical and endoscopic treatment of IBD. Now we're going back a bit, as the previous speaker, Professor Riley, said, we are going back to basics here. And mine is the second in this session, the talk on basics. So what should I include in this talk on IBD evaluation? And so before the audience gets restless, please let me remind you that we are talking about initial evaluation, that it should be pragmatic, it should be cost effective, and I'm not obviously going to touch on endoscopy and biopsy. So typically this is what I would do. So we have blood tests. Okay. So complete blood counts, ESR, CRP, albumin globulin ratio. I'm talking about basics. I'm talking about the gastroenterologist who occasionally encounters a patient with IBD. Albumin globulin ratio, iron and total iron binding capacity. These are my favorites. Stool test, stool routine analysis, fecal occult blood is extremely important from my point of view. Calprotectin I use sparingly. We'll talk about that a little more. And again, we are talking about initial evaluation. I'm not talking about follow-up here. And finally, imaging. All right. So this is the list of tests which I normally do when I see somebody who I think might have IBD. And I want to make sure that this person does not have IBS. I want to get a little more characterization of the disease. The two tests which I have shaded a little, which appear a little less dull on the slide, which is the ASCA and the calprotectin, are tests that I use less frequently. They are actually kind of second line. So what are the goals of initial evaluation? What we need to do is to diagnose IBD in a patient with chronic GI symptoms. We need to distinguish IBD from other inflammatory diseases of the gut. We would like to distinguish ulcerative colitis from Crohn's disease. We want to know what is the pre-treatment disease activity. And if possible, we'd like to predict response to treatment. We heard from Dr. Uday Kumar that now they are using small molecules in nearly 30% of their patients with IBD. Certainly in India, we have not transitioned to this level, but it doesn't look to be far in coming. What about complete blood counts? For me, hemoglobin and the red blood cells indices are very important, because if I find microcytic anemia, microcytic hypochromic anemia, to me it indicates that this person is losing blood from his GI tract. If there's macrocytic anemia, I might believe that there is small bowel bacterial overgrowth or that there is terminal ileal involvement. The white cell count is important. Platelet count is particularly important. A lot of our patients with Crohn's disease, for instance, will have a high platelet count, 450,000 or more. And when you compare it with interstitial tuberculosis, of course, we've not really done formal studies. With tuberculosis, the degree of thrombocytosis that you get is not this much.
There is a bit of work done on the neutrophil lymphocyte ratio. It is something that I don't use, but there's a systematic scoping review done, which was published last year, where one of the things they talk about is to distinguish IBD from non-IBD and clinical outcome prediction. So the conclusions of that systematic review were that this very simple test, which is the NLR, differentiates IBD from non-IBD controls. It's useful in assessing disease activity. It may predict risk of complications, and it can guide therapeutic decision-making, specifically the lack of response to infliximab. Now, I'd just like to remind you that there is much experimental evidence which says that inflammatory markers correlate with activity, with disease activity seen on leukocyte scans. In the bar on the left, we have patients who are inflammatory marker positive, which is a white cell count greater than 10,000 or a CRP greater than 7. And those with the inflammatory markers which are positive have a much higher positive scan. And when they are IM inflammatory markers are negative, the leukocyte scans tend to be negative. What about the utility of ASCA and ANCA? Because these are kind of widely available, on a kind of outsourced based in most hospitals. They are widely used, right? I sometimes think they are widely misused. Essentially, the serological biomarkers can evaluate an aggressive disease phenotype. They might predict prognosis. And the initial way that they were introduced was that they distinguish Crohn's disease from ulcerative colitis. But if you look at this review, which was in 2016, the conclusion of that, and that was a systematic review, said that serological markers have limited value in making an initial diagnosis of inflammatory bowel disease. So initial evaluation, serological markers, generally no. Fecal calprotectin is another measure that we use. It's increasingly used, and actually it's very heartening that the costs have come down dramatically, maybe within the last year or so. So it's a sensitive and a non-invasive tool distinguishing IBD from IBS. So when you take all patients with chronic diarrhea, and if you use a fecal calprotectin, it distinguishes organic from non-organic almost 100%. In a meta-analysis, which is what I've referred to here, when you screen for suspected IBD, the sensitivity and specificity is like 93% or 96%. And in another meta-analysis, if the fecal calprotectin was less than 40 micrograms per gram, the chance of IBD was less than 1%. So this is an AGA technical review which was published 3 years ago, basically showing that ESR, the sensitivity and specificity of these non-invasive tests, ESR, CRP, and fecal calprotectin scored highest here, but all of them have their value. So this is a much more recent review, which was systematic review again, published last year. So if you look at hemoglobin, it is not very sensitive. So 37% sensitive, but quite specific, 90% specific. Platelets, a little more sensitive, not equally specific, and so on with ESR and CRP. Albumin, which is one of the things that I talked about, also has a role here. ASCA, although it's reasonably specific, in our setting, I don't think this has been looked at in India because we know that a lot of inflammatory diseases in India, including tuberculosis, can have a positive ASCA. Calprotectin in children in particular is very sensitive, and in adults also it is reasonably sensitive. Distinguishing CD from, so we talked about the initial evaluation. One is to differentiate IBS from IBD. The second is to distinguish Crohn's from ulcerative colitis. And here, the ASCA and ANCA may be useful. So if you use a combination of a positive ASCA and negative p-ANCA, it distinguishes ulcerative colitis from Crohn's in most patients. The question of, how rigorously one wants to distinguish ulcerative colitis from Crohn's disease is, of course, a different issue altogether, because in practice, probably it doesn't really make all that much of a difference. When you see the first patient for the first time, you want to know, is this person going to respond or not? And here's what the information is. You have a high baseline CRP. It predicts that this person will respond poorly to treatment if he's got ulcerative colitis. If the person has Crohn's disease and high baseline CRP, it predicts a non-response to infliximab. A p-ANCA positive Crohn's disease also responds less well to infliximab. And in pediatric Crohn's disease, a positive ANCA predicts a good response to biologics. So this is the kind of information that we have. So moving on to imaging, which is the next pillar of the non-endoscopic initial evaluation. What typically we have tended to do in my hospital is to use CT enterography for adult patients at first presentation. And essentially, this is because we feel that the resolution is much higher. We pick up smaller lesions there. And to the trained radiologist's eye, the CT enterograph often provides as much information as MRI. I'm going to contradict this statement a little later, but bear with me. In children, we prefer MR enterography as the first evaluation, and as part of the ISG task force, we have actually talked about guidelines about how to do this. Now, before we go on to CT enterograph, okay, here are CT enterographs. What I would like to remind people, and knowing that many of you are not specialist IBD physicians, sorry, going back to the CT enterography, what a lot of patients who come to see me would come with contrast CT scans which use positive oral contrast, and that should be avoided in CT enterography. They should, basically what you're looking at is enhancement. Okay. So here the CT enterography, here basically what it shows you here are typical findings of Crohn's disease, which is the mesenteric border ulceration, the anti-mesenteric sacculation. The combination of this is called the omega loop. And here you see the typical comb sign, the increased vascularity. MR enterography is really much more effective. Here is a kind of collage where this here is a CT enterograph, and in the same patient. So here you see this loop which looks apparently structured. And here again in the MR, you see in the T2 weighted image, you see that this area is dark. In the diffusion weighted imaging, you see the area is bright, suggesting that the structure is largely inflammatory in nature. So MR enterography has really revolutionized the way we look at inflammatory bowel disease. And again, this is a further example of that. The only additional thing which I wish to point out here is that here in this MR enterograph, although these loops look normal, when you look at the diffusion weighted imaging, you see these bright areas which tell you that there is actual inflammation going on there. And this is very useful in the evaluation of small bowel disease, where you don't have colonic disease, your endoscopy is normal, your biopsies are normal. And before you do the capsule enteroscopy, when you do this, you see that there is active small bowel disease in these patients. And with that, I will stop. Thank you.
Thank you very much, sir, for your clear-cut information.
I think we'll have, do we want the question for this two now, or do you want to have it later? Okay, then we proceed on to the next one. May I request Dr. Ubal Das, Senior Consultant, GE Apollo Main Hospital, and Secretary, Tamil Nadu ISC Chapter of ISC Chapter.
Thank you very much, Dr. Stuart Riley and Dr. B.S. Ramakrishna for the very informative detailing you have given. And now it's time for our panelists, Dr. Stuart Riley, Dr. B.S. Ramakrishna, Dr. V. Jayanthi, Dr. M. Hariharan, Dr. SNK Senduran to kindly be present on the stage, please. I request all of you to kindly come on, take your honorable seats on the stage. And a very warm welcome to Dr. Ubal Das. Very nice to see you, sir, again. With more than 25 years of experience, we have him as the moderator to come onto the stage. Thank you.
Good afternoon, everyone. May I have first slide? So we all had a discussion about the endoscopy as well as the initial evaluation. My case presentation is going to be very simple. I see a lot of people as taking photographs of the slides. This PowerPoint doesn't have any literature, basically. So Dr. Megha Sharma is our first PG, but she's not supposed to join because his father is an acute cholecystitis. She's busy. She's not able to join us. In fact, she studied a lot and she had a bunch of PowerPoint presentation about 400 slides. If I put that it will consume the entire day. Most of the care meetings, you have to stick on time. Otherwise, the speaker will go to the basement, straight go to the car park. So I will stick to the time. We have a nice panelist and we always go with a passion of cricket. So we have an overseas all-rounder, Dr. Stuart Riley, and two classical clinicians and scientists who got awards in recent Jaipur, Dr. B.S. Ramakrishna and Jayanti. And we have very top T20 players like Dr. Hariharan, and I think he must be one of the maximum number of colonoscopy performers in India as an individual. And Dr. Chanduran, another upcoming T20 player. Most of the youngsters, I feel they are very fond of going fast. He's another. These are my panelists, and I'll go to the case. Because basically what Dr. Basamani is a third umpire, he can correct me or stop me, or if I deviate, he can correct me at any time. So this is a simple case, 35-year-old lady who had a pain abdomen constipation for 1 year. I think this clinical presentation, nothing very important for the subsequent presentation. The pain was gradual onset, lower abdomen, moderate intensity, chronic non-radiating, relieved by defecation and stools. And there is no blood mucus in the stool, there is no weight loss, and physical examination is non-contributory. And before I go further, I release the questions to the panelists because they are also the first time seeing the questions. I request to please reduce the AC because Madam feels, most of the panelists feels cold. Not because of my questions, I think. So the patient are, as usual, typically present as an IBS, multiple laxatives and various antispasmodics. He had an upper GI endoscopy, which is normal, essentially. And Indian origin patient, he was shifted to Melbourne 4 years ago. So when I saw this slide and what are the questions which came to mind, I'll ask the panelists. The question one to our overseas panelist. Suppose if you see any Indian patient who is visiting you with this kind of bowel symptoms, do you suspect any specific disease or etiology? Other panels may pitch in after a short release.
On the basis of the presentation, I would be thinking primarily of functional bowel disorder. I don't have much familiarity with the role of ethnicity in this condition. I would certainly be looking at her diet. I think that would be particularly important. And I would want to do some preliminary investigations before thinking about further investigations. Some preliminary blood tests.
Being Indian origin, do you think of in terms of tuberculosis or intestinal tuberculosis?
Well, initially, I would want some more investigations before I actually considered that. Yes.
Madam, you want to add anything?
Yeah, no, not with this presentation, no. This presentation.
Not this presentation, generally I'm asking.
Yeah, with this presentation, there would be no difference as far as ethnicity, environment, or genetics would be concerned.
Sure. Suppose if any other presentation you do suspect anything, so suppose Indian origin settling abroad.
No, it all depends, no, whether the person has got diarrhea or inflammatory bowel disease like pattern. But with this clinical scenario, I think there would not be much of a difference.
So BSW, you want to add anything?
No, I think it's very clear. The symptoms are consistent with IBS, could be IBD. The issue of Indian origin, I think the reason you're raising this is because Dr. Jayanti is here, and many years ago she showed that Indian origin people that migrated and settled in England had a much higher chance of having IBD. In the first generation migrants, the prevalence of IBD increased, and there's the second generation that was born there, it was even higher than in the Caucasians.
That's exactly what I wanted to comment. Yeah. That the ethnicity doesn't really matter, but once the generations, they are there for the subsequent generations, their incidence goes up much more than the local people.
That point is very important. That the incidence of IBD is becoming higher, and when they move to a different environment. And the question next is, what will you do next? Because this patient keep on complaining the same thing, and will you do, what is your next mode of investigations?
It's the same patient with constipation, right?
Yes, yes.
So I think the work would be towards doing a transit study and doing the other types of study just to ensure. Colonoscopy, the duration is quite long. So I think colonoscopy at this stage may not be really important. Maybe I'll just do a short length, left-sided, and then proceed with the transit study.
I would go with the basics. Start with complete blood counts, erythrocyte sedimentation rate, C-reactive protein, liver function test, or albumin globulin ratio, and perhaps a fecal calprotectin if I was sufficiently persuaded.
Audience can interact. Any different of opinion, he can please raise. But unfortunately, this patient underwent a colonoscopy, and which shows a multiple terminal ulcers of varying sizes. Biopsy was done, and colonic mucous and vascular pattern is normal. So, question 3 is: how many of you will advise on a ileoscopy during a routine colonoscopy?
I think for completion's sake, one would always resort to an ileoscopy completion. And of course, if there are ulcers in this manner, I think biopsy is recommended.
No, it is always ideal. Try and do a ileal intubation as much as possible. And I think you should try to approach at least 60% of your colonoscopy should have an ileal intubation. In where you really need, you should go. But if you're just doing a colonoscopy, it is always best that you should undergo and try and do an ileal intubation if you can.
I would add that when you're doing a colonoscopy, it's also very important to always try to get into the terminal ileum. Getting into the terminal ileum can be technically really quite challenging. And if you look at standards that are set around the world, often 80% is the suggested ileal intubation rate. And that is quite difficult to achieve. So I would suggest when you're doing a routine colonoscopy, always try. And then when you need to get in, it becomes that much easier.
So again, that is a very important point. When you learn colonoscopy, always try to enter the ileum, because most of the teaching will stop at the level of reaching the cecum is the ultimate aim. And yes, sir.
For investigation, you get a family important.
Family history of IBD, is that?
Family history of IBS or IBD?
Yes, yes, sure. So
that may give us some clue. Motion examination has to be done. You cannot bypass that.
Sure. So what I am thinking, telling is ileal intubation is very mandatory if you learn colonoscopy, and because almost 1/3 of the patients you have some ileal findings that may or may not be significant, but try to learn how to intubate ileum and do a ileocolonoscopy. That is make it as a mandatory. And this kind of ileal also this patient had. And question 4 is, so when you see these ulcers, so what do you think of? The colonic mucosa is normal, ileum shows these ulcers.
It definitely indicates probably a chronic ileitis too. Because now in our practice, we see to that mostly we intubate the ileum. And sometimes it's surprising, if the patient is not very symptomatic with loose stools or even constipation. When we go in, we see these kind of more of small F-third ulcers. So, but if the cecum is normal, then when we take, we always think of inflammatory bowel disease. That's the thing which we first. But having said that, certain even chronic infections can also, you can see this kind of long-standing infections can also have this kind of picture. So I think I would go with the biopsy.
So I think if I were to see this in the UK, I'd be thinking, yes, that's a small aphthous ulcer. There is a degree of surrounding low-grade ileitis. Could it be Crohn's disease? Could it be TB, eosinophilic esophagitis? I'd also want to check the patient's drug history as well. I know you told us about antispasmodics, but specifically, are they taking anti-inflammatory drugs, aspirin, ibuprofen, and the like? Because that's quite a common cause. There is also quite a number of patients who have non-specific ileal ulcers, which can come and go. People have done studies to repeatedly endoscope these patients, and they are something that comes, I think, something akin to the oral aphthous ulcers that we often suffer from.
Sir, you want to add anything?
The follow-up on these ileal ulcers, their studies have been done on isolated ileal ulcers. Follow-up have been done where they have interfered and where they have just followed up, and did find that some of them, like 30 to 40% of them, don't have any pathology. Just on a subsequent ileocolonoscopy, they just don't find those ulcers there. They just come, they disappear. We don't have any treatment for that. They just disappear.
So isolated aphthous ulcers in the ileum in somebody with typical IBS-like symptoms, I guess we always have to treat it with caution. We might keep a kind of threshold level where you'd say that this person has IBD, but very often we end up treating these, if in the absence of other evidence for inflammatory bowel disease, if the biopsies are normal, the stool calprotectin, for instance, is normal, and if enterography did not show disease which was slightly more advanced than what we see here, we might just treat this patient for IBS and observe.
No, this patient is already undergoing treatment for IBS and these kind of ulcers. But why I'm asking is because if the kind of ulcers, if you, what I thought was 15 years ago, I prematurely did these kind of ulcers. We routinely did a cecal culture, thinking I'm going to find out one more H. pylori like diurnal ulcer, and so you think that any kind of infections, any cross contamination from cecal flora into the ileum, which can make these kind of ulcers, particularly in the Indian settings and in some.
So we've had actually patients with Campylobacter enteritis, that I can remember at least 2 patients with chronic Campylobacter enteritis that I've seen, who eventually we treated that, and then the entire symptoms resolved.
I think in this patient who has constipation and incidental ulcers, I would take a biopsy because there are aphthous ulcers and keep the patient on follow-up. But I would not label the patient as IBD or
biopsy.
That is well taken, because most of these ileal ulcers, whatever the Indian literature says, is turned out to be a non-specific. Sometimes 1/3 will turn out to be a Crohn's disease, or 1/3 will be various other etiologies. So whenever you see an ileal ulcer, you have a doubt that this must be something more serious or something innocuous, but you cannot ignore that. Something we don't know doesn't mean that there is no disease exist. we may not know, we may find it in the future. So this is the ileal histology. Again, this is role of GI histopathology is very important in this kind of ulcers, particularly diagnosing IBD. I think Professor BSR is a better person, being a pathologist. This is a ileal histology which shows a grip distortion and chronic lymphoplasmacytic infiltrations. How important for a pathologist to interpret ileal histology?
So ileal histology is very important. One, I mean, obviously you need to know the kind of inflammation. You look for inflammation in the lamina propria. But what is more important is that there should be evidence of neutrophilic infiltration of the epithelium and of the crypts. So that would be cryptitis. And there might be crypt abscesses, which is collections of neutrophils within the crypts. In addition to that, what you might see is when there is chronic damage, you get what is called Fannett cell metaplasia and you get pseudopyloric metaplasia. So all of these are indications that there is chronic ulceration going on, which you may eventually lump it as Crohn's disease, because Crohn's disease is inflammation of unknown origin.
I don't think I have much to add. I mean, the crypt distortion that you're telling us about suggests a degree of chronicity, and the plasmacytic infiltrate may tend towards inflammatory bowel disease, Crohn's disease, but it's very non-specific, as is your patient's symptoms. Yes, it could well be just a coincidental finding, but one has to keep an open mind and arrange some sort of follow-up.
The only thing I will be looking at is that if I'm able to find any granular mass, if I'm not, then it's going to be difficult for anybody in this world to clearly differentiate whether are we dealing with something non-specific or are we dealing with something specific. The only thing is that helps me is that if I'm going to find something like an infective this thing or granular mass, that's the only thing I'm looking at. Otherwise, then I go back and then reinvestigate or wait for further evolution of the disease.
So question to the other panelists is, do you stop investigating at this moment or you want to investigate further? Having seen that ileal ulcers, you want to investigate further the small bowel or not?
No, I'll keep the patient on follow-up. There is crypt distortion, so I'll keep the patient follow-up and get the periodic ESR, CRP done, follow up with the patient's symptoms. If there's a fall in hemoglobin, ESR is on the rise, and keeping constipation aside, and she develops some new onset symptoms, then I will push forward for further investigation.
So basically, see, there is two different set of scenarios. When you clinically suspect an IBD, you may investigate further. But if you don't suspect clinically IBD, the incidental ileal ulcers, you wait and watch. These are the two clinical scenarios. Suppose the same patients, if your clinical diagnosis is IBD, maybe I think you should investigate further. So this patient had an ASCA, IgA and IgG is negative, CRP is 15, CBCs and LFTs are normal, stool routine is normal. And I think ASCA, Dr. Ramkisar spoke about. Any words about ASCA, role of ASCA in this patient?
ASCA is negative. I generally don't lay much faith in ASCA, but I know that there are contexts where it might be useful.
Will you do, sir, at any?
I don't do ASCA.
You don't do ASCA. No. Anybody in the audience do regularly ASCA?
None of us recommend.
So this patient is started on mesalamine and is advised for follow-up colonoscopy after 6 months.
What are the symptoms? What is the symptom?
So the mesalamine.
No, the basic symptom is still constipation, or there's some change in the presentation.
No. The patient presentation initially is a constipation only. Yeah. For the ulcers, they started on Pentasa.
Based on the ulcers.
Based on the histology.
Are we justified in starting the treatment with mesalamine?
I would not. I would probably just arrange clinical follow-up rather than starting mesalazine. Yes, I mean it's a fairly low risk medication, but recognized side effects to all medications, of course.
The other problem is that for anything like mesalamine for terminal ileal disease is not an ideal drug, and it doesn't work. So the best thing is that if you want to have started, it should have been something else apart from mesalamine. So I wouldn't have started on mesalamine. I would have kept the patient on follow-up. If I strongly suspect IBD, no, starting on mesalamine means somebody has suspected IBD, in which case they should have investigated further, proved it one way or the other before starting, rather than starting on mesalamine, because that itself could have caused all these problems now. Now the patient start having loose stools, abdominal pain, weight loss. Weight loss could be incidental because the patient having other symptoms. These could have been because of the mesalamine.
Okay. Sir, can you go back to the previous slide, sir? This can be better stated as a patient is empirically started on mesalamine.
Sure, sure.
This discussion can be avoided.
No, this is whatever the case was.
See, why this was started, that is a discussion.
Yeah.
If you put empirically, nobody will have to use the question.
Okay. No.
See, one word will clear all the doubts. It has been empirically started. He himself has stated. That will be better.
Sure. So the symptoms persisted. The patient started having loose stools, abdominal pain, and weight loss. So now what will you do next?
We'll reassess the colon, reassess the entire GI tract, because there is abdominal pain. Hopefully it's periumbilical pain. There is weight loss. So expect some small bowel involvement. So I think workup has to be improvised.
We should go back again, like, before. No, now that this has been started, at least now we should go back. If you strongly suspect, now that there is diarrhea, there is weight loss, at least now I should start working on the small intestine. I would want imaging, plus if at all, I will go, I have to investigate the small bowel for excluding Crohn's.
What is the choice of small bowel investigation?
No, I would probably start up with first small bowel enterography and follow it up with a capsule endoscopy, if there is any findings.
Initial CT and then CT enterography.
So BSR, sir. But you said you prefer a CT rather than MR enterography. Any specific reason for that?
A baseline CT enterography and then follow up with MR enterography.
No, BSR sir said he prefers a CT enterography rather than a MR enterography. Because generally the literature says MR enterography is more ideal for IBD. More because of the less radiation, you need a more frequent testings.
So this is actually areas in transition or evolution. So we, as I said earlier, we said adults first should be CT enterography. We are now transitioning to a phase where, along with CT, we are doing 10-minute MR sequences, which are focused on looking at the inflammation. So it's a kind of combo with the two.
The difference between CT and MR is that I feel is that the initial investigation should always be a CT, because that's very well studied. But MR in IBD is just still evolving. Maybe once we know where the problem is, where the pathology is, we know where exactly the problem is, then for subsequent follow-ups, every regular follow-up, then you can probably use an MR enterography much better than a CT. But for an initial first thing, I would always prefer a CT.
That's what most of the practice. Sir, Vinith sir, any idea about CT plus MR enterography? Because most of the this part of the country, I think people prefer a CT enterography.
Exactly the same reason that CT, it is easy to get the roadmap for the radiologist as well as for the gastroenterologist. The CT is the easier roadmap, and subsequently you can do it.
This patient had an MR enterography, which is normal, and had a capsule endoscopy, which showed multiple off-site ulcers in the entire small bowel, predominantly in the ileum. And she was started on budesonide 9 mg per day, which was tapered over 12 weeks.
Sir, if you suspect Crohn's, normally we follow in our hospital, we do an upper GI endoscopy. If the duodenum shows abscess ulcers and granuloma, diagnosis is more better than going in for a higher second line of investigation.
Sure. Yeah, that is a valid point, because we always do an upper GI endoscopy and take a biopsy. And as well as basically for the roadmap, you need an entire small bowel to be imaged.
Can I ask, was the colon re-examined at the same time?
This time, no, sir.
Okay, so this obviously is capsule endoscopy imaging that we're seeing. Were there any new developments on colonoscopy? Was the colonoscopy repeated?
Colonoscopy repeated subsequently after starting the steroids.
Okay, fine, thank you.
So she was started on budesonide 9 mg per day, which was tapered over 12 weeks. Again, the question is, what is the choice of steroids? Whether it is indicated at this moment, or Because this patient started having symptoms and weight loss. And so basically, my question is how you define that the patient is going for an aggressive course? At what point of time you think that patient is going for an aggressive IBD? Is there any parameters clinically or biochemically you can predict? BSS.
So this patient to me looks like I think, is having mucosal disease. It's not transmural disease because the MR enterography was normal. And there were multiple aphthoid ulcers. The capsule did not get stuck in the small bowel. To me, a major differential diagnosis, considering the kind of patients we are seeing now, will really be eosinophilic enteritis. Because I think we see a lot of mucosal disease with that, which causes this small aphthoid ulceration. But the treatment would remain the same. I mean, I would have given budesonide if I was sufficiently persuaded that there were multiple ulcers.
Any difference of opinion about the steroids? Everybody is okay with the budesonide.
Dr. Vineet, any comments? Steroid, that's the first line.
Ma'am, in the sense that out here, if hemoglobin is normal, serum albumin is normal, a patient is having daytime diarrhea, fecal calprotectin is also normal, then again you're in a limbo in the sense that whether, obviously the treatment you would like to start is budesonide, but whether you would like to start it or wait for some time. Let's say all your parameters are normal, the only symptom you're having is diarrhea. Is it daytime diarrhea or is it pathological diarrhea? Is it just functional diarrhea or is it organic diarrhea? Because all your parameters have not shown up anything else till now. Have you excluded NSAIDs also, which you would have obviously, right? So again, how troublesome diarrhea is, that would decide. If diarrhea is really troublesome and he's showing a decrease in hemoglobin, she's showing a decrease in hemoglobin or albumin, then budesonide would be the first therapy of choice. So
One-
can also
one-
follow
one
up with
question.
single calprotectin.
This happened, this budesonide, when was it started? Which year was this?
This is, I think, 2018 and 19.
At that time, we didn't have that budesonide 9 milligrams, which has the intestinal release. This is a budesonide which has just got a ileal and right colonic release. So this budesonide may not be the ideal budesonide we are talking about. I do not know, but you mentioned about using 9 milligrams and this thing. So 2018, we didn't have the 9 milligram release, which was the intestinal release budesonide, which is currently available.
No,
Comments, Dr. Vinay?
we have the controlled release budesonide, which gets released in the mid-intestine or the distal ileum right from many years. The budesonide, which has been released in 2019 or 2020, is a MMX preparation, which gets released in the colon. So for ulcerative colitis, we'll have the 9 milligram budesonide MMX, which you'll give. And for any small intestinal disease, you will give the controlled release.
The Buddhas are supposed to be released in the mind.
Even though we are considering ileitis as a common pathology, and we are talking about steroids.
Any specifically you look for tuberculosis?
Occult B as well as CME and other things. Sometimes we have been seeing many patients, even after starting steroid, having flare up of multiple other coexisting infections, which we are most of the time will be missing out in a common clinical practice. How far, what are the basic infection protocol we are supposed to guide before the patient to be considered on steroids?
Is there any criteria for between immunosuppressant and steroids? So that is the question, no?
Yes, sir.
Between immunosuppressant and steroids, is there any specific reason to look for to rule out infection before starting a steroids?
So I think many years ago, it was a practice to give antituberculous treatment before treating Crohn's disease. I would have said maybe 40 years ago. I don't think that for many years now, we are reasonably sure in 85% of our patients that we can distinguish TB from Crohn's. We don't worry about starting immunosuppressants right away. We do the regular things, including sending cultures for MJET and expert MTB. But beyond that, I don't think we do much more.
Which one? You meant spondylosis, yeah.
And you give the neurology, ELISA, the action, all the other tape points. Reasonably, I think, what is not steroids, I think you should exclude spondylitis.
How will you exclude, sir?
So I'll fully agree with you, sir. I fully agree with you. Recently, we had a CPC, although there the ulcers were much deeper and all, and on biopsy, but again, the thing was picked up on biopsies. So once you've done a biopsy, you are very right that strongyloiditis should be excluded, but those are case reports of chronic strongyloiditis. Otherwise, if you have done a basic stool examination and all initially, here we are talking of a chronic case spread over 6 months. As Dr. Ramakrishnan told you, Campylobacter yersinia, they would CPC material and all, and should be excluded. But once you have done a good biopsy, you hope that on the basis of biopsies, you have been able to rule out those things.
The reason why I said this was I had a recent case of strongyloidiasis and looked at the literature. And you want to detect strongyloidiasis, you must do 7 stool tests, 48 hours apart. Now, that's a pretty difficult. And then there's a Barman method of looking at it. It's not just the stool test. It's not the formal lethal concentration method. There's a specific method by which you detect it. It's pretty complicated. We are looking at serology now, P1, P4 proteins that are so specific strongyloidiasis that does not go cross-react with the other intestinal parasites because strongyloiditis is so difficult to detect.
So before going further, I think.
Sir, strongyloids are usually gut friendly. They don't do that much mischief, either in children or adults. If they are hyperpopulated, when are they getting hyperpopulated? When there is immune deficiency only, you get this. So in all immune deficiency, you need to screen for immunostatus. That will give you an answer first. The screening test for strongyloids is only immunoglobulin profile. Otherwise, they don't do. Even giardia. Giardia is gut friendly. They don't produce malabsorption.
I think we'll just
If
move
you do an upper GI endoscopy, you can demonstrate in the tissue strongyloids larva. We have demonstrated, we have presented in the last conference.
Sure. So that is accepted. I think we are in the era of T20, sir. I think nobody is doing a 7 stool test, even 3 stool test. I don't think.
We just move on. We just move on to the next topic.
So,
So for strongyloids, I think journal biopsy is ideal.
Before moving to final things, anybody do this stool panel for the infections?
Would you do that? No, I would also not do it.
So this patient had a colonoscopy which showed a normal colon, again terminal ileum, which is ulcers still persist. She also underwent a duodenal biopsy, which showed inflammation and granulomas. So she also developed in September 2020 painful nodules on the shins. Biopsy which showed erythema nodosum. She started losing weight and his lowest weight is 34 kgs. And whenever you see the extraintestinal manifestation, what is your thing in terms of whether you expect the disease will be severe or what are the manifestations which goes with the severity and which is unrelated to the severity?
You want to comment on that?
And the extra intestinal manifestation, some of them like the pyoderma gangrenosum or erythema, sometimes erythema nodosum can happen with acute disease, but something like pyoderma gangrenosum may not be correlated with the activity of the disease. It can just completely be independent of the disease. So you just cannot match up both and decide that this is going to be a severely active disease. Whereas the disease in the GI tract may be completely quiescent, but then the patient can have an extraintestinal manifestation. You have to treat them both independently.
Yes. So before going further, and at what point of time you think that this patient require endoscopic or histologic remissions, or how will you decide about that? Having confirmed that this is possibly an IBD, how often you do a colonoscopy or a histology to think that this patient is into remission?
That is after confirmation and patient is on treatment. The follow-up
yes,
would
follow.
Since there's not much of a correlation, follow up with the CRP or a stool calprotectin, but not only when the patient is symptomatic. Otherwise, I would not do it routinely. If the patient is doing well on treatment and patient is in remission, then I would just hold on and maybe just a CRP, a stool calprotectin.
Ramki sir?
So typically, I would not use endoscopy for follow-up if the patient is stable and is doing well.
If there are flares, yes, particularly to exclude the conditions like cytomegalovirus and superinfection. If we are heading towards remission, and then I want to consider stopping medication, yes, definitely.
So the general practice is if any clinical or a biochemical response, usually we don't do a endoscopic and histology confirmation. Sir, Ahuja, you're okay with that? Yes.
I think the problem is you have a lady who's deteriorating. You have a lady who's lost a lot of weight. In order for me,
No, what I'm asking is before that, when you started treatment for IBD, will you do routinely for establishing an endoscopic or a histological remission?
No, that's right. Now, I was concerned that this lady clearly is deteriorating. She needs follow-up, yes.
So once you develop an extraintestinal manifestation, is there any plan of change of treatment? The question of this patient is on Pentasa and on a course of steroids, and so whether you start, she started losing weight and her symptoms persist, and whether the possibility of thinking in terms of immunomodulators or biologicals, or since she's losing weight, nutritional therapy. So questions to Dr. BSS. What is your choice? Basically, we are discussing what is your practically what you do. So,
in practice, my choice would be steroids and immunomodulators. And if the person could afford it, we'll have a discussion about biologics.
The second question is, will you, once you decided about starting steroids, you add immunomodulator at the first instance or during the relapse?
Typically, I will add it straight off.
Straight off.
Yeah, just that this lady is quite sick now, isn't she? She's lost a lot of weight, and it's clear that she's not responding. So I think an earlier aggressive approach is much more appropriate.
So you feel biologicals or
biologicals will be considered?
Particularly for the immunomodulators, if it is Crohn's, generally I would like to start the immunomodulators along with the steroids, because that's the first line of treatment. Steroids are the first line and not the mesalamine. But unless in ulcerative colitis, that's a little different. And if I suspect that it's going to be very aggressive course, I do counsel about biologics, about biologics in our part of the place. So, if the patient is willing, we can go for it. If not, then immunomodulators would be the choice.
In this patient, should we call it as an early disease, or do we take it as a disease which is already chronic, like Dr. Navanidham had discussed? Start with biologicals versus steroid and azathioprine. Dr. GC, Dr. Vineet, any comments on this? Should we push in for biologicals, or?
I think what doctor said, in our part of the country, the main problem is affordability. So, there's no doubt that the condition is going down. She needs aggressive therapy. So it has to either be steroids now, as Rama said, or biologicals. Ideal would be biologicals, but if we have constraints, then at least a full dose of steroids and then get her out. The last blood reports which you showed, I think were a long time ago, because I've hardly ever seen a person with extraintestinal manifestations whose CRP has not been raised and whose hemoglobin has not dropped. So I think that much has moved over a period of time. And I think what the panelists were referring to is that now it's a different kettle of fish altogether. So we have to be a little aggressive with one of the two.
So what is your choice? Immunomodulator?
If she can afford, because she's in Melbourne, so I'm sure she can afford it. See, that's clinical medicine. You don't always have to ask questions. There are many things you can infer. So if she is willing, I would certainly use biologicals, because, given her age and all that, she will do remarkably well. If suppose she doesn't, then, obviously the full dose steroids and then tape. I would give a 3-month trial of azathioprine before moving on to biologics, and also 3 months of azathioprine, and see if it works. And some of these patients really do well, and they are also able to get away from the side effects of biologics, apart from the cost. And would also do a chest imaging or a repeat imaging in between, because it has been 1.5 years since the last time.
What is your concern about biologicals in this country, in the Indian subcontext?
Because if this patient is going to do well on azathioprine or methotrexate, then there's no need for biologics.
In the sense that I have not been able to get, if the patient has intestinal failure in the form of anemia, hypoproteinemia, diarrhea, which is aggressive, high CRP, then obviously you would move on towards biologics. But here we have seen just aphthous ulcers till now. I have not seen anemia. I have not seen hypoproteinemia. The patient is having diarrhea, yes, fine. But it has not manifested in form of any biochemical changes as yet. So I would prefer to give a trial of azathioprine, but also image in between, do a chest X-ray also or a chest imaging.
So, but in presence of extraintestinal manifestation,
But
should we
that-
step up or hold
ma'am-
on to azathioprine?
Ma'am, in the sense that there is an extraintestinal manifestation, if it responds to azathioprine, fine, steroids plus azathioprine, fine, otherwise we will move on to biologics.
With
It's
the
just that I do not want to bypass the step of azathioprine in our country. Melbourne is perfectly fine, as sir said.
with the
My
way.
concerns are two. One is that, if a person is deteriorating, my experience has been that immunomodulators take a little bit of time to act. So they're generally good when you want to have them for a steroid sparing effect for follow-up. So you might start right in the beginning, but by themselves, I have not seen them work too dramatically. So if you really want to make a turnaround, corticosteroids full dose, yes, obviously, plus azathioprine would be a good choice, or I would go to biologicals with azathioprine. I mean, that would be my preference.
It was the weight loss that concerned me. I mean, I'm not sure in this clinical scenario, you have a long time to wait for the azathioprine to kick in. That would be my concern.
So there is a 50-50 between the biologicals and immunosuppression. I think this is Vinith Ahuja's patient. This patient started on azathioprine, and but he developed a maculopapular rash, and which is again reappeared on reintroduction. So switched over to methotrexate. So question to BSR, sir, what is your first choice of immunosuppressant? When do you switch over? Or
For me, it's always azathioprine because that's the one with which I have the most experience, and I can, in fact, modulate the dose at long range without the patient ever having to visit. As Dr. Gurdas said, it takes 3 to 6 months for the full effects of azathioprine to set in. Methotrexate is an alternative in patients with Crohn's disease. We have used 6-mercaptopurine on occasion, but not regularly.
Harry, you want to add anything?
The thing is that regarding the choice of immunomodulators, I still would like to use azathioprine as much as possible. But in some patients who have extreme GI side effects, particularly nausea, I have tried 6-MP and seem to have got over with some patients in whom had severe nausea. But then again, the choice of tests that we have to, the only thing I want to highlight is that recently I burnt my fingers regarding the test that we normally do in our place regarding the TPMT. The TPMT isn't working. I had 2 cases and one went into severe bone marrow suppression, but I found out later that she was NUTT 15 problem. So just want to highlight the fact that more than TPMT, please do NUTT 15 in our place.
Okay, this patient, we have a short of time. This patient had an increased markers and low hemoglobin, and CT scan showed a persistent disease in the ileum and the persistent ileal ulcers, and the patient was started on injection adalimumab. The question to the panelists: what is the choice of the biologicals in an Indian setting? How will you start? What is the precaution? And how will you monitor? How often is do? Not the textbook. I feel that individual, whatever their choice, how do they treat? In a Indian set of patients where there is no insurance cover, patients can afford only 2-3 doses. And
so if a patient can only afford 2-3 doses, do not start on biologics would be my advice. That's what I tell the patient. They have to be prepared to continue it lifelong. I mean, we would hope that after 2 or 3 years that we can de-escalate it. Our practical experience and Vinith's published experience certainly points that towards the fact that you can de-escalate. So I would generally prefer infliximab. The problem is that infliximab requires a visit to the hospital, and it needs to be given intravenously. So for many patients, we just give the choice. And so they would then use the adalimumab biosimilars because they can be self-administered. And now we have pens also where that's.
Do you have any difference of opinion about biosimilars? Because
I've used all the ones which are available in the market, and I don't think that there's a major issue.
Your choice.
Adalimumab for patient convenience primarily.
My question to you is that, for infliximab, we do find out when there is loss of response, anything like that, we can find out about antibodies. What about adalimumab? Do you have any thing to check about antibodies to adalimumab? Because there are people who are on adalimumab and find that they are losing response. But I can't find a lab which does antibodies to adalimumab. I did try doing it, but ended up in a big flop. I couldn't even interpret the report.
In India, it's not available. Rest of the places, US and all, it is available.
I tried doing in Lalpat, sir. Once I did, but then they gave some vague reports. I couldn't really interpret it, what it is.
But another thing is, in this case, in any case, you'll have to give azathioprine or methotrexate because you'll have to add an immunomodulator to the biological. So that is the place where it is that you would have to start azathioprine and then start biological in addition concomitantly or after some time. But that is also required. No, budesonide would have been stopped by now. It was. I think as Dr. Jayanti said that initially when the disease is aggressive, you would start prednisolone. If the disease was mild initially as thought to be aphthous, then you can start budesonide. And once the patient is not responding, you switch over to immunomodulators or biologicals depending upon how sick the patient is. As Dr. Chaudhary said that if a patient is very sick, you don't have so much time, then you start biologics. However, the patient is a little stable, then you may give a trial of azathioprine, and obviously you'll have to continue azathioprine once you're giving biologics. Adalimumab also right now data shows you should give for 6
Ubal, you can summarize and conclude.
Yeah.
You can summarize and conclude the session.
I think what we understood by this case discussion is the role of environment and ethnicity and ileal intubation and DD for ileal ulcers, and how important is the role of GI pathologist, how to step up and step down, and choice of steroids, and how to follow up, do we do endoscopy and histological remissions, look for extraindustrial manifestation for disease severity, and but I think we skip the role of nutrition and the choice of immunomodulator and biologicals in Indian settings. Thank you to all the panelists, and
I think you should give a big round of applause to Nala. This is one of the fantastic panel discussion I've seen. Thank you, Bal. That was very extremely illustrating panelist, and of course started a floor discussion. I think it was one of the best sessions I've enjoyed. Now, Professor P.K. Reddy wants to facilitate his long-term friend, Professor K.R. Panswamy, sir.
Dr. P.K. Reddy, the senior consultant, surgical gastroenterologist, Apollo Main Hospital. Sir, can I request you to please go on to the stage, please? Thank you very much. It is always amazing to get an award, a recognition. And when it's the son of the soil, it gives us more pride. And when you're recognized by India, very lovely. When you're recognized by the global, even more fabulous. And we have someone, the pride of Tamil Nadu. We have a great personality and an eminent doctor who has done us great honor in winning this. And this has been given by the World Gastroenterology Organization. The Masters of the WGO Award is not just given to anyone, but to the most prominent people who have done outstanding dedication to the mission of WGO. Either they have distinction in the field of WGO they should have done, or scholarly research, teaching, and to community at large. Okay, this is the moment of happiness which we want to share with all of you, as Dr. P.K. Reddy is going to honor the gentleman, the doctor, and it's none other than our KRP. Palaniswamy doctor, can we have you on the stage? He has won the 2022 Masters of the WGO Award, and none other than the place where they had it in Dubai, United Arab Emirates on 12th of December. We really need to cheer. Can we put our hands together and cheer for this moment?
Madam, what all I wanted to tell you already told us. Just a few words. We both are neighbors in the hospital, in our offices, and for the last 3.5 decades. And so I always joke, when Dr. Palaniswamy wants to see me, he can see me with his endoscope. When I want to see him, I can see with the laparoscope. And I will not, we felt really that, in fact, myself, I felt really that I got the award when the World Gastroenterology awarded Dr. Palaniswamy. He's a very good friend of mine from the beginning. And he's a very good human being. And I will not talk much about the medical part because already everybody knows about him. Ever since I returned from UK, I know Dr. Palaniswamy. He has been involved always in social service, and which unfortunately I could not do that. And even now, he spends time in doing social service, traveling from Chennai to outside. Even Chennai itself, we have a Ramakrishna mission here. He's been doing the charity work from a long time. And then he also goes to his native place where he does the endoscopy camps and gastroenterology camps. Plus also he goes to Andaman. There also he does the charity work there. That's the greatness of him to think of. And he's a very soft-spoken person. And when I requested recently for a help, he did it completely, even though he was away. Yes, practically he took care of it as if he was in Chennai itself, actually. So I'm very much grateful to him for all the help he did in the recent period. And our association goes a long way. And I tell Dr. Palaniswamy all the best in his life.
I would like to thank Professor P.K. Reddy and everybody for their good wishes and the affection and love. Thank you very much.
Thank you very much. It is indeed a great honor to recognize your award, sir. And Dr. Prasanna Kumar Reddy, who is not only proficient in English, but also in Tamil, Hindi, and Telugu, sir. You nailed it and said a very beautiful words. Having said that, we are running short of time. So we have arranged for coffee tea in the next hall, but I request none of you to leave because we're going for the next session. So you can have your coffee and tea and you can even bring it in. But I request all of you to please remain seated and you can take turns in going off. The next session will start now. This session is about IBD therapy, and the chairpersons, Dr. Usha Srinivas and Dr. Sarojini Parameshwaran. I request both of you to please come onto the stage, please. She is a senior consultant for Department of Gastroenterology, Apollo Main Hospital, Dr. Usha Srinivas. Ma'am, can we have you on stage? And Dr. Sarojini, she is also the senior consultant for Department of Gastroenterology for Apollo Main Hospital. I request that all of you don't leave together. Maybe we can take turns so that we still have the audience over here. Thank you very much. I hand over to the chairpersons to carry forward this. Thank you. Yes, please. You can proceed. Yes. Thank you.
Good morning. We go to the next session. Hope all of you come back soon to join us for this lead talk, prerequisites before treatment, vaccination and counseling by Dr. Matthew Philip. Can I call Dr. Matthew Philip?
Recently elected.
Congratulations, sir. You are the recently elected Secretary General of ISG. Please come over to for your talk. Okay, shall we? You can join us here, sir. Can we? We'll start in 5 minutes because we hope people will have their coffee soon and come back.
I think everyone has gone to just bring the coffee and tea and we're going to come back. So
We should have
yes, so
served it
we will
here.
start in another 5 minutes. Yes. Thank you.
So tomorrow the bidding will come out and watch for Chennai. Your mail. Punjab and Varanasi, 3 are not 24. North Indian people will opt for Varanasi because of because of the new boat service and all. No? There is a ship and all coming there. It's okay. Some break should be there, no? We have to have some break. Actually, number of talks will reduce and time should be even more. In Delhi, IBD meeting, it was like that. My case discussion was 1 hour. They will load it. I went out and no. I went out and said, me and Palnisami went together. It is pretty cold here, no? That's why actually. From Jaipur, I got a respiratory infection. It's continuing almost 2 weeks now. And
Brought everybody inside. Can we? Okay. Yes, sir, please go on.
first of all, I would like to thank the organizers for giving me this opportunity. And this is actually a topic which I had never spoken. And what I'm going to tell is from my experience, except for the vaccination, you won't see any reference in this. So there are 3 areas are asked to be discussed. One is prerequisites of management, vaccination, and counseling. We know that while managing any chronic diseases, there are certain aspects we need to look into. I think one of the most important is actually the pre-treatment evaluation. Then comes the rest of it. So in IBD, when you consider prerequisites for treatment, it could be the disease-related and the therapy-related. And they are interrelated as well. When you look at the disease-related aspects, the most important thing is that after making a proper diagnosis of IBD, you need to assess the risk and how that will help you to find out the way forward for managing. Then the phenotypic classification, mainly to find out the extent of the disease and type of the disease. And that also will tell us what type of therapy you need to choose. And also the disease severity by any type of criteria, where your institution feels low. and presence of external manifestations in certain cases that decides which drug to be chosen. Then definitely nutritional aspects of the patient, previous therapy, surgery, etc. And therapy related is basically when you start certain drugs like immunosuppressants or biologics, you need to roll out latent infection like tuberculosis, etc. And then there are certain drug-specific laboratory tests. Beside that, there are certain factors which need to be looked at. Is the cost factors that affordability, adherence to a therapy, whether you have to look into it, whether if you start a therapy, is it likely that the patient will continue on that? And of course, the vaccination come into it. Many times we start them on steroids, and as such, this disease has got some evidence of malabsorption. So we need to look at the vitamin D, bone density, presence of smoking habits, though in India it is not that commonly associated with the Crohn's disease. Then, of course, age, comorbidities, and preference of the patient or relatives or to choose the drug. Coming to the risk assessment, actually the risk assessment will tell us how to choose therapy for this patient. I think I took this slide from Dr. Vinit Ahuja. And when there is a low risk for ulcerative colitis, your modalities of treatment actually varies. Similarly, when you consider a patient for a high risk disease, your patient has got a high risk factors, your modalities of treatment is different. So risk stratification is quite important. I am not going into the details of it because there are talks on that. Similarly, on Crohn's disease also, you need to identify those who are at low risk, those who are at high risk. And a person with a low risk criteria, then he can be managed in a little different way when compared to a person with a high risk stratification. Those who are at high risk, they need to be aggressively managed early enough rather than trial with different types of medications. Similarly, your treatment also varies depending upon the patient with a low risk and a high risk. A patient with a low risk, you can go with a step-up management, and with a high risk, probably you have to come with a step-down therapy. You have to actually start with a higher molecule or higher therapy better initially, and then come down once the patient is better. Phenotypic classification is quite important in choosing your therapy, as well as to knowing the extent and stage of the disease as well. So this is also quite important. And we know that having a fistulizing disease management is different from that of an inflammatory disease. And a young person is differently managed when compared to that of an elderly person. And a structuring disease is managed with a non-structuring disease. All these are quite important. So what are the investigations before planning a therapy? And these are the parameters, and these are role for that. And some of it is already Professor Ramushan has told. I think imaging becomes very important. All lab parameters are already discussed. And I think CT chest is a quite important one. Investigations for tuberculosis are quite important. And you need to routine laboratory test and also viral markers. And serology, I don't routinely do it, but many times I've seen people doing it, but I don't routinely do ASCA or ANGA now. And the other most important biomarkers which we do is actually the CRP and fecal calprotectin. When you look at the drug-related parameters or factors you need to do, Ms. Lemson, you know that you should know a baseline renal function, and always we should know. Otherwise, when you start giving it and later if the patient develops a renal disease, we are not sure that basically to start with he had a renal dysfunction or not. Corticosteroids, definitely you look for blood sugar, bone density, as well as always have an ophthalmology consultation, whether to know whether the patient has got a cataract or early cataract as well. Thiopurines, TPMD is the classical one which is being done, but we know the Asian patients is not that good. NUDT is not freely available, and that is more sensitive for our patients, but it is not freely available except in certain institutions. But of course, we monitor pre-evaluation itself. You do a blood count, liver function, etc. Methotrexate, again, you do a blood count, renal function, as well as a liver function. Biologics, the most important thing is actually look for latent infections or associated infections like tuberculosis, etc. Except probably in vedolizumab, where the risk is not that high. And also always look for other infections, and vaccinations are quite important, especially in when you are planning for tofacitinib, and you should make sure that the patient is vaccinated for herpes zoster. But it is not available in our country. That is what I think. So when you consider to choose a biologic, an immunosuppressive or immunomodulatory therapy, you have to look at certain aspects or criteria by which you choose your therapy. One is that the route of administration, the ease of giving. We know that there are oral preparations, there can be subcutaneous preparation or a intravenous preparation, but we prefer that if the patient can avoid hospitalization or coming to the hospital frequently, that should be given priority. Then speed of, depending upon the severity of illness, we need to know that how fast the drug is going to act. For example, a person with acute severe ulcerative colitis, you need to, if you are using a biologic, you need to use a biologic with a rapid onset of action like infliximab, etc. Then also look at the potential immunogenicity and need for a combination therapy in these patients, looking at the risk stratification, you can do that. Side effects including cancer risk, these need to be discussed with the patient, as well as we should know also about all these details on this, and persistence. Actually, the most important thing is that you treat a patient and initially the response is there and the patient does not adhere to therapy. That is also important. So this needs to be discussed with the patient. And availability of infusion facilities in the nearby places, or the patient has to travel long distance your own. And rarely in certain situations where you want to do a TDM, therapeutic monitoring facilities, that should be available. And I think the most important thing in our country is the overall cost of therapy. So, excuse me. For in nutshell, in prerequisites of IBD therapy, one is the proper diagnosis. I think that is the most important thing. In our country, we should not misdiagnose tuberculosis as Crohn's disease or vice versa. Then you identify the risk stratification, then phenotypic classification, disease activity assessment, setting treatment targets for you, patient, assessment of nutritional status and optimization of nutrition before starting therapy. And I think serum albumin is very important, especially if you are planning for giving infliximab, because you know that the response becomes inadequate. And presence of external manifestation, which I already told you. Then therapy-related testing, vaccinations, patient and relatives education, awareness of the disease, and of course, financial consideration. This is just to show you a case. And this patient, this is the colonoscopy patient, came with the feature suggestive of Crohn's disease, and there was no fever. This is the colonoscopy ileocecal area ulceration. And to me, it was actually, I thought it's a tuberculosis, and biopsy actually showed it is more in favor of Crohn's disease. And this is a CT angiography, ileocecal disease. And when I did a CT scan of the chest, you see there is evidence of tuberculosis. So I think it is always a must that you do in the initial evaluation of Crohn's disease, you always do a chest CT scan. And also in your department, you can have IBD checklist like this for initial evaluation as well as for monitoring. Then coming to the next, that is the vaccination. Why you declare vaccinations? You should look at vaccination in different titles. One is the need, is a need for vaccination in patients with IBD. What is the prevailing vaccination practice in IBD patients? Levels of immunosuppression, assessment of vaccination, etc., etc. So what is the need for vaccination of patients with IBD? There is an increased rate of infection in the IBD because they are immunosuppressed. The disease process itself actually produces certain defective immune mechanisms. And also they have got many associated comorbid conditions which actually make them vulnerable to diseases. And in other words, IBD patients are at a higher risk for vaccine preventable diseases. And also it is found that IBD patients, the vaccination rates are low in these patients, at least in our country. There is an obvious need to vaccinate these type of patients. And it's also studies have shown that during therapy, those who are exposed with the higher the quantities of medicine or higher the grade of medicines like infliximab and then a combination of immunomodulators, they are slightly at a higher risk of developing infections. And what is the prevailing practice in IBD patients? This actually varies from country to country, but one study has shown that comparing with 20 years back, now the awareness of gastroenteritis is much superior in vaccination. And I am sure that in our country also, it happens the same. So how do you define an immunosuppressed state in level of drug therapy? High level of immunosuppression means, systemic corticosteroids, more than 20 milligram for more than 14 days and within 3 months of that stopping. And immunomodulators, methotrexate, 0.4 milligram per kilo per week, azathioprine more than 3 milligram per kg, and 6-MB for 1.5. But we don't actually use 6-MB except Professor Ramakrishna has told. I'm sorry. Then all biologics except vedolizumab. That too within 3 months of stopping as well. What is low level of immunosuppression? That's actually systemic steroids less than 20 milligram if you take more than 14 days and within 3 months. But there are some suggestions that probably 1 month is sufficient for that. Sorry. And if you use a lower dose of azathioprine or methotrexate, again, it is considered low immunosuppression. Vedolizumab is considered to be a low immunosuppressed state. So there are other factors also which should be considered when you say about immunosuppression. It's not only the drug, but also many other factors, co-infections or comorbidities that can affect the immune status of patient. And you need to do certain evaluation, especially for serological tests to find out whether they have got already infections or vaccinated. And there are 2 types of vaccination. We know I'm not going to details of the live vaccine, inactivated vaccine. And these are the recommendations of, this is the latest publication which came in Korean population, and they've recommended that you should have an influenza vaccination, preferably inactivated influenza vaccination, pneumococcal vaccination, ideally 2 doses, and hepatitis B virus in all patients. Check the immune status, anti-HBs, and also look for hepatitis B. Hepatitis A virus infection, many of the countries, they practice it. Then human papillomavirus, not widely commonly used in India, but it is still recommended there. Then tetanus, diphtheria, pertussis. I don't think that in Indian adult patients, anybody who takes it, but you need to do that, whether they have already not done in the past, they should be done it. Meningococcal vaccine, then measles, varicella. I think varicella zoster is very important, but unfortunately, the live vaccine is only available. But now there is a new recombinant vaccine available, and it is not available in India. Probably it will come soon to India. And herpes zoster. So again, recombinant vaccine is available in the West, and it's not available here. COVID vaccination is a routinely you do what you do in routine cases. That they are actually the efficacy is same, but with the antibody titers when you use infliximab, it may be slightly less. What are the key messages on vaccination? Vaccination do not induce exacerbation of the disease. There are no specific contraindications for vaccination with inactivated or live vaccines in IBD patients. Vaccine status of patients should be determined at time of diagnosis, and recommended vaccination is administered. Vaccination should be administered during remission of the disease, having higher efficacy. I'll go to next. And all general recommendations recommended by the society for IBD should be used, for vaccination should be used in IBD patients. And also, another thing is, in addition to checking the patient's vaccine status, the vaccine status of the household members also is important, and close contact should be also be checked and vaccinated. So coming to the last aspect of mine, that is the counseling. In the IBD clinic, you have physician, surgeon, IBD coordinator, psychologist, or counselor, and nutritionist. If you ask me who is the best, most important, I think it's the IBD nurse or IBD coordinator who has got more relation with the patient. And when you come to the major task of an IBD center, there are patient care, patient outreach, and system management. I think the most important thing would be the patient care. And what is meant by counseling? Counseling is a collaborative interaction between the patient, psychologist, and the psychologist that focus on enhancing psychological well-being as well as self-understanding. This can be started on the assessment period itself, or you can plan later. Last few slides, I finished. And what is the role of counseling in IBD? It has shown that if you start counseling in IBD patient, it really makes, and even if it is not by the doctor, it's by the IBD coordinator, that's actually there is a considerable impact and emotional well-being in this patient. And it's always helpful to talk to the counselor, at least around one person. That can be, this counseling can be in different areas, which I have narrated here. And when should you take up patients for counseling? It's actually on patient demand or by your observation. And it can be a constant exhaustion by the patient, or the patient has multiple symptoms and the patient said, I'm not able to move away with my community, move away with my friends. And patient feels that I have a feeling that I am worthless. All these are quite important. So what are things can be done? And it depends upon which clinic you work, which hospital they go. There are different types of therapies, but generally it is a cognitive behavioral therapy, person-centered therapy, and psychodynamic therapy, mindful therapy, etc. So coming to my last slide, counseling in IBD, it improves the quality of life. living with IBD, you had to do emotional and physical attitude and changes be done on that. And fatigue in a patient IBD, that means it need not be alone with the disease alone. It could be a psychological problem or emotional problem. And you should need counseling for taking medicines and adherence to it, and managing bowel incontinence and perianal disease, especially sexual relations and IBD, premarital counseling to couples, diet in IBD, perioperative counseling, living with a stoma. All these are bigger topics to talk about. Talking to the child and the husband or relatives of the IBD patient, by the patient, how she should communicate. This all becomes very important. And of course, in countries like India, we need patient support program, at least in certain patient to treat. Thank you so much for your kind listening.
Questions after the next talk?
Dr. Palniswamy wanted to tell me something. I'll just tell you. Now, first of all, I have to thank all of you for electing me as the IST secretary. And I never wanted to become a gastroenterologist. My passion was endocrinology, or I wanted to continue in medicine. So accidentally, I became a gastroenterologist. And after becoming a gastroenterologist, I wanted to settle down in a medical college and teach students, and that is my wish. But I happened to become a governing council member in INSL. This was actually the pressure by Professor Sarin. That was in 1997. And later, I decided to move to SGI. Then I became the president of it. And finally, the secretary general of IST. And I think, I have taken up this post with trusting all of you. I will walk behind you, and you should actually lead me and the society to a higher level. And I believe that we can do it if we work together. Another thing is that from tomorrow onwards, the onwards the IST con bidding starts. And I think all of you should look into it and elect your venue of choice. And I'm sure that since Chennai has also applied, everybody will be behind Chennai. So we are all happy to see Chennai again. Thank you so much.
Thank you, Dr. Philip. We move on to the next talk. I think all of us will agree that starting treatment is easy, but it's very difficult to decide when to stop, discontinue, change or switch over or taper drugs. And there's no better person for this than Dr. Vinita Ahuja, who's done a lot of work on IBD.
Thank you so much, ma'am. And first of all, I'm grateful to Dr. Palniswamy for inviting me out here. Pleasure to be in Chennai. Basically, my talk would be more about, there's a new concept which has come up, deep healing, like mucosal healing. The question is, should we run for it or not? And essentially, if you look at it, we think that it is really, whether it's a great revolution in the field of IBD or not. If you look at disruptive science, I put up a slide out here which has got nothing to do with IBD. It's a beautiful infographic from Nature, which shows that when did the disruptive science papers come up over last 50, 70 years? We somehow feel that most of the disruptive science has occurred in the last 2-3 decades. That's when the web came up. That is when so many things, scientific revolutions occurred. However, if you look at this infographic, you realize that the least disruptive science has occurred in the last 2 or 3 decades. Most of the disruptive science occurred initially in 1950s, 1960s, 1970s, and we are reaping the benefit of that. So coming back to IBD now, this is the kind of, you would say, descriptive, oblique, incremental science which has taken place. That is, the goalpost has been changing. The goalpost, which was initially, okay, let's just improve the symptoms. The patient should do well. Patient should be feeling well, has changed to, okay, steroid-free remission. Let's not give steroids. Steroids cause a lot of damage, to having not only clinical improvement and clinical remission, but also endoscopic improvement, which is known as mucosal healing. And it has been loosely coined as, the word has been coined as deep remission. This deep remission, what does it all encompass of, has gone a little bit changed over the last 4 or 5 years. Essentially today, I would say deep remission means clinical remission, biochemical remission, and endoscopic remission. And the philosophy is that deep remission is associated with better long-term outcomes. So aggressive escalation of medical therapy in terms of chasing this deep remission is probably the way we should treat IBD. And that is, let's discuss whether that is right or not. obviously it appears intuitively to be right, because Crohn's disease is such a progressive illness. Over a period of 5 to 7 years, it moves from B1 to B2 disease and thereafter to B3 disease. A patient presents to you with inflammation. You had that case study where the patient initially presented with just mild aphthous ulcers, and thereafter, within a period of 1 year, rapidly there was progression. So obviously, if you act early, you might be able to stop the progression. What about ulcerative colitis? Does the similar kind of progression takes place? There is a progression which takes place, but that is only in the extent of the disease. It may become from proctitis to left colitis or pancolitis, something like that. Not drastically different as occurs in Crohn's disease, where it moves from an inflammatory phenotype to a structuring of fistulizing phenotype, where the patient may have intestinal failure. So mark this fine difference between ulcerative colitis and Crohn's disease. So deep remission essentially is endoscopic and clinical remission, and this is the kind of mucosa which every IBD treating physician would want now, because that is being, in a way, it is being propelled or propagated that should be done. And obviously, if you look at the cohorts behind it, the initial cohorts were observational cohorts or retrospective data. The retrospective data showed, yes, there is benefit. If patients who had mucosal healing, they were followed up, they had less chances of surgery, they had less chances of hospitalization. This was seen both in patients with ulcerative colitis and Crohn's disease. But this is a circular argument. It's quite possible these were the patients who had a benign course. So obviously they had a lesser chances of hospitalization and surgery. And that is why you need prospective data actually to look at it. Secondly, if a patient has deep healing, deep remission, does the patient necessarily do well in real life? Well, it doesn't seem to be. As like this was a group of around 97 patients who were followed up. You had clinical remission, endoscopic remission, and also histological remission, the best possible kind of remission. These were patients with ulcerative colitis. When followed up for a period of year, it was seen that still, despite that, 18% relapsed within a year, despite all of them being on treatment, suggesting that, yes, remission is good, but remission doesn't mean the patient is going to have a hunky-dory course all along subsequently. So right now, I would say this is one of the most cited studies over last 2-3 years. This is Dan Turner's consensus study, which came up in gastroenterology, famously known as the STRIDE-2 consensus. The STRIDE-2 consensus essentially says what are the treatment target today. And if you look at it carefully, you'll find that there is an immediate, initially symptomatic response. Symptomatic response is immediate. You're not looking after it at 6 months or 1 year. That is your immediate gain. The second is the intermediate, which is normalization of CRP, normalization of fecal calprotectin. And subsequently is the long-term gains is endoscopic remission and quality of life. So step by step, you want to achieve that. And if you're not able to achieve that, then you need to upgrade your therapy. Further, what you would say, work in progress is to look at histological healing in ulcerative colitis and transmural healing in Crohn's disease. So this is STRIDE-2 consensus or the treat to target philosophy. So these are certain terms. There's a target. There's a term known as tight control. How to monitor, when to monitor, are the targets different? So we have initial treatment. You assess the target is, as I told you, the target is endoscopic remission. Target is biochemical remission like fecal calprotectin normalization and all. And if you periodically monitor the patient and if you find the patient is not doing well, you need to upgrade your treatment. Consciously. It's a conscious decision that if a patient is, let's say, on azathioprine and the patient isn't doing well, but at the same time endoscopically not in remission, would you upgrade the treatment? And that is what this philosophy says, you should upgrade the treatment. The contenders for being a target obviously are endoscopic healing. Fecal calprotectin we all know is an excellent target. Histological healing is something which is a target for the future. So what is the evidence? Obviously, the best evidence is in form of RCTs. Till now, we have had cohort studies. Cohort studies fall into the ambit of circular argument. So what is the randomized control data which is available for ulcerative colitis and Crohn's disease? The famous study, the CALM study, which came a few years back, which looked at patients with Crohn's disease. They were randomized into 2 arms. In one arm, they were given adalimumab, and subsequently adalimumab dose was stepped up if the patients were not achieving biochemical remission or endoscopic remission, whereas in the other arm, the regular standard therapy, that is adalimumab, was continued every 2 weekly and all. And there was a significantly higher rate of mucosal healing, which was seen in patients who had a tight control as compared to patients who had clinical management. But what is the fine print out here? This trial was only for 48 weeks. So this was data only for 1 year showing mucosal healing is superior. But what do we actually want? We want to know whether this really translates into a low rate of progression of the disease or not, in terms of not getting converted from B1 to B2 or B3, or less chances of hospitalization or surgery. Comes a follow-up of the CALM study, which was a retrospective analysis, 3-year data analysis of all that came up, which showed that for 3 years, when the patients who were in endoscopic remission or deep healing, both arms, patients who had tight control and patients who were given standard therapy, both of them had a decreased risk of disease progression. So this was encouraging. Yes, for 3 years, there seems to be some very good information. So this data says that if there's early institution of biologics within 2 years in Crohn's disease, and if they achieve mucosal healing, the effect is seen till 3 years for sure. A recent abstract in UEGW 2022 further worked on it in terms of it is known as a REACT-2 study. But again, this study could not successfully find that the primary objective was whether if you have a treat to target approach, patients are going to get into remission and have a lower rates of hospitalization surgery. It could not achieve that primary objective. All it showed was if patients had high-grade degree of ulcers or if they had high CRP, probably that would be a subgroup analysis set whereby you can go in for this kind of approach. What about ulcerative colitis? We actually do not have any randomized controlled data which is available for this endoscopic remission or treat to target strategy for patients with ulcerative colitis as of yet. So let's approach this question the other way. If you want to start biologics early in the course of disease, is it going to change the course of disease or not? So we have 2 or 3 good reviews on that in terms of systematic reviews as well as cohort reviews, which have shown that for Crohn's disease, if you start anti-TNF therapy early in the course of diseases within 2 years of diagnosis, it leads to lower healthcare utilization in the subsequent 5 years. Whereas in ulcerative colitis, the same effect was not seen. Similarly, another study showing that if you give vedolizumab also provides a similar kind of benefit, but only to patients with Crohn's disease, not to patients with ulcerative colitis. If you combine both of them overall, it shows that in patients with Crohn's disease, if you start biologics early in the course of disease, probably it helps. Whereas in cases of ulcerative colitis, the same kind of benefit is not seen. So let's put into a practice. I put across most of the literature which is out there. So now if you go into clinics, how are you going to do it? You have to, the philosophy is you have to target clinically silent inflammation. In other words, patient is doing well, but you do an endoscopy or you do a fecal calprotectin, it is raised. What are you going to do? Are you going to escalate the therapy, which is known as treat to target? And obviously the monitoring has to be time bound every 3 to 6 months, which is known as tight control. What are the criteria? For Crohn's disease, clinical would be CDI less than 150. If you do an endoscopy, the endoscopy score should be, there should be no presence of no ulcers and all. And fecal calprotectin or CRP should be low, that is below the normal, in the normal limits. For ulcerative colitis, the targets again simple: clinical remission, Mayo 0 or endoscopic remission, and fecal calprotectin less than 100. How do you evaluate it? You can Crohn's disease, you can do a FCP or endoscopy every 6 months. In case the patient has a small bowel stricturing disease, you may have to do a imaging. There is no time period for that, but one may do a imaging after 1 year or something like that. In ulcerative colitis, it's easy to monitor, so you do a FCP or endoscopy every 6 months, and on the basis of you can decide what to do. So mucosal healing is a relevant endpoint in clinical trials, but in clinical practice, it still remains a desirable goal. Why? Because on one side, we are talking about mucosal healing. On the other side, we are not talking about the number of drugs which we are escalating. We are not talking about the issues related with the escalation of the drugs. The issues could be, one is obviously the acceptability of the patient. You would realize that some of the patients, in fact, they don't want to take any drugs at all. They're very happy with the minimum possible drugs. Secondly, is things like frequent visits and tests. if you're going to do a tight monitoring every 3 months, the patient may have to come to the hospital, may have to undergo endoscopy or colonoscopy, that is after every 6 months. Fecal calprotectin is also not that cheap. There are resource-driven factors which are out there. Besides that, the moment we move on to small molecules, biologicals, many of them are associated with side effects. We have seen that with anti-TNF when the risk of tuberculosis was very high. It was activation was very high in our country. Secondly, the data which is there in terms of progression, stopping progression of diseases for 3 years. Crohn's disease, if it has to progress, it would progress somewhere beyond 3 years, at 5 years or 10 years of duration. It would not in the first 3 years. Most of the Crohn's may not progress so much. We really do not have data for that kind of follow-up till now. So in the OPD, if a patient comes to you, Crohn's on azathioprine with minimal symptoms, and you just did a MR, and on MR you find frank inflammation which is lying out there. So the question is, what are you going to do? The patient is just on azathioprine. Are you going to upgrade the treatment or not? Let's look at whatever evidence we have got till now. Observational cohort data suggests yes. RCT, one RCT, but that suggests yes. Long-term follow-up, that RCT for 3 years suggests yes. Early institution of biologics, do they change the disease course in Crohn's disease? Yes. So are you going to push for mucosal healing in this case? Probably yes. How? You're going to review every 6 months, do a FCP, colonoscopy. Transmural healing is still a question mark, but yes, you can also check for it a year. But here you would definitely like to upgrade the treatment and move over to biologics, but be aware of drug adverse events, cost of therapy, and cost of monitoring at all. Now, similarly, so this is what is like for Crohn's disease. Now, similarly, if a case of ulcerative colitis comes to you, patient is on azathioprine, minimal symptoms, nothing. You just happen to do a sigmoidoscopy and you find these kind of ulcers out there. What are you going to do? Are you going to put the patient on biologics? Are we going to follow the treat to target policy at all or not? Let's look at the data. Again, we find that observational cohort data for ulcerative colitis supports it. RCT data, no, we do not have any RCT data. Do we have any long-term follow-up RCT data? No, we don't have that. Does early institution of biologics change the disease course for ulcerative colitis? No. We have good amount of cohort data suggesting no, it does not change. So are you going to push for mucosal healing out here? Probably not. And this is what I would say worldwide. If you ask the experts, they are wishy-washy about this kind of particular scenario and they try to avoid it. In the sense that everybody knows that, okay, strike to consensus is there, but at the same time, when it comes to ulcerative colitis, there's not enough data to back it up in terms of practical execution of treat to target policy for ulcerative colitis. So I think this is my final slide, that yes, practically, I told you about this. This is the practical thing to do. Theoretically, yes, we are moving now from treat to target to another new concept which is coming up, that is treat to clear. You're talking about not only endoscopic healing, but histological healing, which is already an endpoint in many of the clinical trials. And probably let's see whether we move further than that and go on to molecular healing. Thank you so much for your attention.
Thank you, Dr. Ahuja. Shall we go to the next lead talk and then take up the questions together? We welcome Dr. Gaurdas Chaudhary, who's going to tell us about the small molecules. Are they small or are they big? Welcome. So we will take questions for all these 3 topics at the end of this session.
Thank you, Dr. Usha and Dr. Sarojini. At the outset, could I thank Dr. Palniswamy for this kind invitation to be here amongst friends once again. The topic is a little challenging. It's somewhat of a new concept called small molecules. And the big benefit part was added by Dr. Palniswamy. I bring you greetings from Delhi. This is more or less known. I think we have repeatedly heard that we have a range of treatment options depending on the severity and the time. And we have dealt with it many a time. At this point in time, for moderate to severe inflammatory bowel disease, the major part of the therapeutic scenario is being held by biologicals. And they are increasing in number and they're probably getting better. Problem is that, they are injectables and they're expensive. We just discussed about this case from Melbourne. So a new set of therapies is emerging which is coming in very silently and creeping into the therapeutic armamentarium. I'll share this case, which would be more in tone with the overall theme of the meeting of a case discussion. This is a lady, 49 years old, who came to us in October 2019 with a problem of loose stools that has been going on. In hindsight wisdom, we took a detailed history and found that there was evidence of some chronic inflammatory disorders or diseases in the family. Now, her problems had started almost 5 years before she came to us with loose stools on and off, treated with antibiotics. Then she developed red eyes, went to an ophthalmologist, was diagnosed to have scleritis and uveitis. So the ophthalmologist told her that go back to your gastroenterologist because we think it's IBD. And then she had a colonoscopy in 2016. That's about 2 years after her initial diarrhea. And she was diagnosed to have ulcerative colitis and she was put on Pentasa. Not an uncommon scenario, all of us, we see that. 2017, she had a second colonoscopy. It was still active, so she was put on steroids. In 2017, she developed severe joint pains and was diagnosed to have sacroiliitis. So azathioprine, I think Vinith's hot favorite, so that was added. 2018, she again had a flare of ulcerative colitis while she was on immunomodulators and Pentasa. And it was again a flare of ulcerative colitis. So it went on requiring steroids, high doses, and persistent symptoms. And then in 2019, she was put on adalimumab, one of the biologicals. It's, are you feeling it's a bit reminiscent of the case we discussed a while ago? The initial reluctance to go to biologics and then, how it went up. So this was started not by us, it was by another gastroenterologist. Incidentally, this lady had been through 4 major cities because of her profession. So it's a very interesting case. So she was on adalimumab, started in Guwahati, and then 2019, she moved to Gurgaon, and this is where she was. She failed to respond to adalimumab after a while. So we did a colonoscopy and found that she had got C. diff infection. So she had active disease, CRP was 180. There was UC obviously active, but she had C. diff. So we treated her with C. diff, and it was one of those difficult cases to treat. So in spite of the therapy for quite a few days, she would relapse. So she required, I think, 2 or 3 courses of therapy in pretty high doses. Then when she improved, the C. diff went away, but the inflammatory bowel disease persisted. So we discussed the options. She had been through steroids, adalimumab, what have you. So the question came up about biologicals. And at that point in time, the only other biological in India was infliximab. So we gave her the choice. She said, yeah, she would like to go for it. And we started infliximab for a while. But after that, she had another flare. So we were at our wits' end. What else do you have? So in our the armamentarium that we have, therapeutics armamentarium, at that point, there really was nothing else. So the issue came up is that there was a global trial going on in our institute, and there was something called a small molecule going on. So we just asked her if you would like to participate. So having discussed with her family, she agreed. And then we put her on an oral therapy. And to be honest, till that time, I had not been too familiar with these so-called small molecules. I had been using it more for clinical trials. Now, after that, you see the improvement was dramatic. It was an oral tablet. Her disease came into remission. The molecule was etrasimod. I will come back to that a little bit. So there are quite a few candidate molecules now, I think about 8 of them. Her symptoms improved. And if you see from 2021, 2022 till this year, 23, she had dramatic improvement, not just in her IBD, but in her extra-intestinal inflammatory conditions as well. And this is a picture which would convince you. This was in 2020. And you see that the one which we did in 2023 during a part of our study showed beautiful colon. One can hardly make out. And she has been on this medicine. It's 2 milligrams of etrasimod from the time that she joined the study, and she has done rather well. Of course, I have some friends from England. So as the saying goes in English, that a single robin doesn't a summer make. So it's the same story. I mean, one case which was beautiful, we can't generalize, but the fact is this is here for you to see. Now, small molecules in IBD, these are the 4 major categories. The JAK inhibitors are well known to you. Tofacitinib is now being used quite frequently for UC. It has its ifs and buts. There is a FDA caution. But tofacitinib is a more non-selective JAK inhibitor. And there are now series available where people have used it. There's another one called filgotinib. And in fact, that has been one of the molecules that we have been involved in a global clinical trial. Upadacitinib, I think, was mentioned by one of my predecessors. This has also been licensed and it's available now in USA. And peficitinib. There's another group apart from JAK inhibitors called CYP modulators. And ozanimod was mentioned today in the morning talk. It's approved in US, but we used etrasimod. That's the second one. And it's interesting because whenever there's a next effort that is made to go beyond the first, it means there were limitations that you're trying to overcome. And etrasimod was thought to have less side effects compared to ozanimod, which occasionally had hypotension and drop in BP and so on and so forth. So that's what etrasimod is all about. Then there are anti-integrins. Many of them are injectable. So I'm not discussing injectables and monoclonal here, but there are 2 of them which are oral. And there is a PDE4 inhibitor, which is also in the trial phase. But the ones on top, the first 2 categories, a few candidates are now available and they have been licensed. These are the new molecules being tested in patients with IBD. So it's a busy slide, but you can see that there are quite a few candidates which are aspiring to come into the therapeutic regime. And it makes it easier for us because then the panel discussion we had would be broadened as to what are the other options we have if it is not this or that. And these are the pathways for biologics and other anti-inflammatory drugs to work in IBD. Every time I think the cartoon gets more colorful and more complicated, and I hate to show these slides because I'm basically a clinician. I would leave that to Vineet. JAK inhibitors, there are basically 4 types. And again, the non-specific or the non-selective ones had more problems. Now people are trying to have more selective JAK inhibitors, especially the JAK1. Tofacitinib, I've just mentioned. And by the way, it's in clinical practice. In India, I know several people, probably Philip also has used it. Am I right? And I had to use it once. And I tell you, the response was dramatic. The issue is that there has been a caution from the I think it's the American Heart Association and the FDA who have cautioned that long-term use could be associated with cardiac risk. So that's where we are at this point in time. Filgotinib is the second one which we used. And the first author of this study, if you see, is Brian Fegan. He's a Canadian, by the way. And he was also the first author when infliximab came into the market. He's a nice guy. He's been here. We have toured together and given talks. So that's where filgotinib is. And obviously the results are positive. That's the reason why it has undergone or it has got license from several countries, especially Europe. I think the US has turned down its request for rheumatoid arthritis, but it's very soon going to be available because it's a Gilead Galapagos sponsored thing. And there is a lot of politics also, I guess, which goes on, whatever. So filgotinib is there, and these are the mechanisms of action of both JAK and CYP1 modulators. The word which I liked is how CYP1 works is it's called lymphocyte trafficking. It works on lymphocyte trafficking. And it's an attractive concept, but lymphocytes are the ones which are the inflammatory mediators. So if you reduce them, it's anti-inflammatory in a way. But in a country like India, we have to be worried because lymphocytes are also the cells which are important for management or control of tuberculosis. So that's obviously a concern at the back of the mind. Etrasimod, definitely the response has been shown to be at least double that of other candidates. And it's good both for achieving remission and for maintaining remission. So this lady has been with us from 2019 till 2023, done extremely well. And it's both in terms of having got the induction as well as she's maintaining. And she's one of the 5 candidates who are as a part of our clinical trial. So what are the new approaches coming? The new approaches of obviously the biological market will go on expanding, but costs are a problem. I hope all of you know that Stellara has come into the Indian market, and the initial cost of the first dose would be 3 lakh rupees. So, 1 lakh per vial. So it's not something which all of us can afford, especially if we don't have an insurance. So those issues would come up. Undoubtedly, it's very good and effective from what the literature says. Small molecules are effective and oral, and possibly we will have to find our way as to whether combinations work. So this is what I would say, second last slide. Biologicals are injectable and expensive. So many patients prefer oral therapy, and there are affordability constraints, especially in India, at least among my patients. Small molecules may have the advantage. I mean, it's obviously got the advantage of oral therapy, and it would be probably more affordable. Efficacy and safety is being explored, but since many of them have been licensed and they have cleared phase 3, I presume there would be a reasonable amount or guarantee of safety, and they could be attractive alternatives to biologicals once you're in a difficult spot. So this is how the IBD treatment ladder now looks. So the biologicals are there to stay, and the rate at which new ones are coming up, you can't actually suppress that effort. I think that's kudos to the science that's going on in the lab. But small molecules are also coming up, and one has to be aware that they can play an important role, especially in resource restricted countries like India. So thank you very much for your patience.
Thank you, Dr. Gaurdas. I think the questions will be addressed in the panel discussion is what we were told. And Dr. Ravi, we invite Dr. Ravi to make an announcement.
Respected teachers, friends, students, I thank Dr. KRP, Dr. Basamani for having given me this opportunity. I stand before you to have an announcement. We are holding the annual meet of Tamil Nadu ISG annual meet at Trichy in March 25-26, Saturday and Sunday. I welcome all of you to attend the meeting. Thanks for this opportunity again. All should register and come. Thank you.
We go on to the panel discussion.
Request the moderator, Dr. P. Seshadri Venkatesh, who's got more than 25 years of experience in the gastroenterologist. So we request you to be the moderator for this and invite the panelists, Dr. Vineet Ayuja, Dr. Matthew Phillip, Dr. Somasundaram Bharat, Dr. L. Venkatakrishnan, Dr. J.K.A. Jamil to kindly go on the stage. Thank you so much. Thank you, Dr. Usha Srinivas and Dr. Sarojini for the amazing chairing of the event. Thank you.
I think we'll start off. Pre-lunch session, it's tough. People waiting for lunch. I think we had wonderful sessions till now. Dr. Ubal has created a good feel over here. Let me see if we can proceed. So we'll first talk about the therapeutic journey, ups and downs. I'll be presenting, and this Sadguna Rahu has prepared all the slides and it's taken the effort to prepare the slides. So thank you, Sadguna. He's right there. You can show yourself.
So Dr. Basmani called me and asked me to moderate the session. I said, is it me? Am I going to do it? Then I looked at the list. Who are going to be the panelists? Oh my God. Dr. Vineet Ahuja, Dr. Matthew Phillip, Dr. Venkatakrishnan Jamil, and Dr. Somodra. What am I going to do? That was my first response. But he said, no, you're not going anywhere. You're caught over here. So I thought, okay, I got to do it. Let me do it. So I think this sets the pace for the whole thing. And let me see. I think the audio is not coming up. Audio. So let's start. It's going to be the IV is generally a roller coaster ride for most of the patients. That's why I used it. So anyone knows about Vivek Express? Vivek Express. That's the longest train journey in India. It starts from Kanyakumari and goes all the way up to Dibrugarh. So the patients with IBD are having a very long journey, and it's a lot of difficulties through. Let's hope we get the and we hope we get a good journey. So the next travel time is going to be about 30 minutes probably, and it's got some live crisp discussions, and we talk here and there for 1 minute advice, and mobile your choice, and fasten your seatbelts, stay back, and hope you enjoy the journey. And let's see. It might be exciting like this. So I thought the air traffic controllers will be here to control the time, and I think they've gone back to the places. Let's see. So the beginning is we have a 37-year-old software engineer, married, has got 2 children from Chennai. He had pain in perineal region, and he was diagnosed to have perineal abscess and intrasphincteric fistula. He underwent surgery, and biopsy showed chronic non-specific inflammation. So the first 2 questions will be, what is the threshold for colonoscopy? 2 perspectives, one from Dr. Jamil as a surgeon, and one from Dr. Somasundaram Bharat as a gastroenterologist. So the first instance, you do colonoscopy or you wait for recurrences?
I mean, I would like to know what his other symptoms are.
Yeah, his basic surgery at this time was for a perineal abscess. He didn't have predominant colonic symptoms at that point. So in these patients, do you suggest a colonoscopy at this point itself, or you wait for some recurrence and then?
No, he's definitely got an acute problem in the perianal region. So I would get that sorted out first, and then.
Yeah. So, of course, surgery first, but colonoscopic evaluation just last. Maybe Dr. Bharat can add on to it. No.
Patient is 37-year-old, fits into the age group for development of IBD, has already abscess and fistula. So if it is IBD, especially Crohn's, already it's a complicated disease. We do not know as to whether there is any proximal disease. If in fact a patient has Crohn's disease, we got to know whether the disease is already existent proximally, even though a patient does not have any referable symptoms. I will definitely go ahead and do a total colonoscopy, including ileal visualization.
Right. So he didn't have a colonoscopy at that point. He had multiple recurrences of fistula after that, and it's at that point that he had a colonoscopy. So at this point, I think the idea is varied. Some you feel it might be the colonoscopy at the first instance or a little later. So this patient had colonoscopy which showed multiple after ulcers throughout the colon and also in the terminal ileum. And the biopsy showed dense lymphoplasmocytic infiltrate, chronic inflammation, crypt loss and cryptitis, both in the terminal ileum and also in the colon. He had further investigations. Calprotectin was elevated. CBC and LFT were practically normal. Viral markers were negative. No cross-sectional imaging was done at this point of time. So at this point, the revised diagnosis is ileocolonic Crohn's disease, A2L3B1, perianal fistulizing. So Dr. Venkatakrishnan, at this point, what would be your therapeutic options for the patient? Perianal fistulizing disease, colon is showing lesions.
Is the perianal fistula active at this point of time after surgery?
At this, he had multiple occurrences. That's why the colon was done. So it was.
So he's got basically an active fistulizing disease. But the colonic disease seems to be very mild inflammation because you just have only aphthoid ulcers. There's no mention about any penetrating disease or any disease involving the ileum, at least by colonoscopy.
Yes. So clinically, he did not have chronic symptoms at this point of time.
Yeah. So at this point of time, at least for the inflammation in the colon, we would present budesonide, but that may not be very active for the fistulizing disease.
Okay.
Azathioprine is a good option for a thing probably with antibiotics for fistulizing disease. At this point of time, I'm not very sure since his activity of the colon is not very, very high. I would probably keep biologicals, maybe try it a little earlier if he's not really responding to it.
Okay. So at this point, steroids and or azathioprine and
Yeah, but for probably if I could relate the fistulizing disease to the colonic disease,
okay,
probably I'll give him a trial of antibiotics for the fistulizing disease.
Oh, right.
But the antibiotic alone may not be enough. So, but azathioprine may be a good option for the
azathioprine. Right. So the patient was started on prednisolone and mesalamine, 3.6 grams per day. Prednisolone was gradually tapered over 3 months, and azathioprine 50 milligram per day was started. He felt better, fistula healed, and there were no further symptoms. But after 2 weeks of azathioprine, he started developing fever and joint pains. And at this point, the CRP was high, but other workup was all for infections was negative because he had fever. CBC was maintaining well, normal. And so again, the question back to Dr. Matthew Philip. Patient has been started on azathioprine. What would be your monitoring protocol? You mentioned in your slides partly about it, but in this patient, what will you instruct the patient, like when you do CBC and other things? And
if you permit, can I make a comment on the case as such?
Sure.
See, number one is any young person comes with a complex perianal fistula de novo. We know that that could be the initial presentation of IBD. And for all these factors, I would always think, of course, he needs to be drained if there is a collection, but I would definitely work him up for Crohn's disease at the initial stage itself. Second is when you start giving treatment for these two patients, steroids, if there is, unless you control the sepsis very well, steroid is not going to work very well for an isolated perianal Crohn's disease in the form of complex fistulas. So that is one thing, but you need to prove that he has got IBD. That is the other thing, since we have not proven, but there is some evidence of colonic ulcers. And other thing is that I would have definitely gone for a cross-sectional imaging, including a perianal, MRI for the fistulogram, as well as if at the same time I can do a MR enterography and also chest CT, whatever it is. So I would have gone like that, of course. Anyway, coming to azathioprine, when we start azathioprine for a patient, we need to counsel them a lot of things. Really serious complication can occur only rarely, but you have to tell them that these are the complications which are the most common is actually bone marrow involvement. And physical symptoms are as such not very common, but if the counts goes very low, they can have sore throat, they can have oral ulcers, they can also have other symptoms due to bone marrow depression, as well as if the patient, you should tell them that they complain about any abdominal symptoms like pancreatitis or liver manifestations, etc. Yes. So baseline, you have to do certain investigations, as I told you. You do a basic hemogram and you do a liver function test. And also, I always do one generally test possible, that is TPFT is the only one available for us. But I agree that rarely you come across any and doesn't correlate also clinically well. NUDT is not available for me. At least for legal purpose, we have to do TPFT, which I'm sure Vineet will disagree on that. So I will advise him about all these things. What I do is every week, initially I ask him to do his blood counts for 1 month. After that, 3 months. And I always tell him about his likely possibility of getting a bone marrow depression. So he had to monitor that. If he is not coming back to me, I'll be instructed that you go back to the doctor and do the testing.
Right. So it's very important to follow the counts. That's something it's missed many a times, following the counts in LFTs. So azathioprine was stopped for a week, but the fever and joint pain subsided. Again, he was restarted on a lower dose. And after a week, again, the symptoms recurred. And again, because of the recurrence of symptoms, it was thought azathioprine is not being tolerated with the patient, and it was stopped. He felt symptomatically better, but he was continued only on mesalamine, 2.4 grams per day. So I think Dr. Vineet Ahuja, is there any role for mesalamine monotherapy? Like, I think most of us give mesalamine for most of our patients in our practice. It's not any, most of the patients go with mesalamine only. So there is some difference between the guidelines and the practice, what we see. But is there any role? Does it really help? Because
So maybe we can discuss about this case and general. In this case, there is no role for mesalamine.
yeah.
Number two, in this case, there's another component which we have to address is that ceton should have been put in earlier. Because in a perianal fistulizing disease, you have to treat two things simultaneously, infection and inflammation. So infection is treated with antibiotics and ceton thread, loose ceton thread, non-cutting ceton thread should be put in any complex fistula. Along with that, when you give immunosuppressants, as Dr. Matthew Philip told you, steroids actually may not be good.
Okay.
These are the kind of cases where you start top-down therapy with biologics if patient can afford. If patient cannot afford, then obviously azathioprine would be a choice. Now coming to this particular, in general, whether 5-ASA works in Crohn's or not. Yes, if you look as per beta analysis, then 5-ASA is not supposed to be beneficial. But if you look at real world evidence, there's plenty of evidence which shows that particularly in mild Crohn's disease, inflammatory Crohn's disease, people when 5-ASA started and people seem to do well on 5-ASA, then it makes very good sense to continue with 5-ASA, regardless of what the guidelines say. And sulfasalazine, as it is, has evidence in terms for inducing remission in patients with inflammatory Crohn's disease, not for maintaining it. But again, if a patient is doing well,
can maintain it.
In fact, just recently in the recent Crohn's and colitis conference in January, which is held in USA, there was a good paper from USA itself which talked about how 20% of their patients were on 5-ASA and seemed to be doing well.
So it still has a role in practice. So the journey so far is like the patient initially had abscess in fistula, operated, then recurrent fistula, diagnosed as Crohn's disease, started on azathioprine, steroids and mesalamine, did not tolerate azathioprine, and has been on mesalamine. So some question for the audience to keep them awake. What is this? Anyone from Tirunelveli? So this is the first double-decker bridge in Asia. This was constructed in Tirunelveli way back in 1971. So just to keep you people awake. So in 2020, coming back to the patient, after 9 months of clinical remission, patient was doing well on mesalamine. He started developing perianal pain again and discharge. And this time there was marginal improvement with his local practitioner had given some oral antibiotics, ofloxacin and metronidazole, and he felt better. However, the symptoms kept recurring again and again. At this point, the first imaging was done for the patient. MR fistulogram was done, which shows a transmitted fistula opening at 10 o'clock position, and another one ending blindly in the rectal fossa. But there was no clear-cut internal opening made out. So at this point, will you be happy to intervene or just treat medically?
Yeah, I mean, it's quite important to know where the internal opening is with regards to the dentate line. I mean, I don't see that on this report, but assuming that this is below the dentate line, these kind of fistulae will have to be laid out, as it was rightly pointed out by Dr. Ahuja here. It is not just about bringing the inflammation down, but also ensuring that all infective collections are completely drained out, either by laying out or by placing a loose ceton. And that is what is going to really help in getting your biologics or whatever to exert their action and make the patient better.
Right. But for some reason, the surgeon who had seen it said no cetons at this point of time. So he also underwent a CT abdomen at this point of time, which showed the circumferential wall thickening in the upper rectum, sigmoid, and descending colon. But there was terminal ileum was reportedly normal. He underwent a repeat colonoscopy. At this point, again, the same after ulcers, but the biopsies showed some ill-formed granuloma, I think reinforcing the diagnosis of Crohn's disease. So the problem at hand is now is a patient who's having recurrent fistula, not tolerated azathioprine. Now, are we going to start thinking of biologicals? And if we think of biologicals, what will be the choice of biologicals, sir?
So for perianal fistulizing disease, the best data is available for infliximab. The only randomized controlled data is available for infliximab.
Yes.
Adalimumab seems to work as good.
Okay.
Vedolizumab probably should not be used for fistulizing Crohn's disease. In anecdotal cases, it may work. We had the enterprise study also, which recently came up, but in general, not many people would advocate for it. And ustekinumab, yes, it has emerging data which shows that it can work. But Inflixi or Adali would be the drugs.
So the choice would be infliximab or
adalimumab.
So influence of cost.
You can use a biosimilar if you want to reduce the cost, and you will have to add if patient is not able to take intolerant to azathioprine, you can get methotrexate, low dose 15 milligram to reduce the immunogenicity and drain the abscess if it is there or something like that.
Right. So as you started off with that, biosimilars versus biologicals. Will you really start with the biosimilar or add on later?
It depends upon, no, actually, if you ask me, my patient's data who is on biosimilar, because adalimumab only we have a biosimilar in India. So we always start with that only. But in infliximab, I usually start with the original molecule and then switch over to biosimilars. But I have patients on biosimilars also. In general, I have found almost equal results and I did not find any. But in this case, what I would have done little differently is that, if there is evidence of infection and if there is the fistula is wet, is draining, continue with antibiotics.
Okay.
And as Dr. Vineet has told, the persistence of fistula is decided not by fistula alone, but also by the inflammation in the disease, Crohn's disease activity occurring in the rectum. Unless you tackle that, this is not going to recover. So just attending only on the fistula is not sufficient enough. And putting CTON is actually, studies have shown that when there is a complex fistula, putting CTON for drainage and antibiotic and then biologics, that will actually enhance us, and early removal of CTON is possible with these patients also. So biosimilar, I think there is no problem because doing nothing is rather than doing nothing, it's better doing something. And it just studies have shown that it's doing well.
Right. So in 2021,
just want to comment on the duration of antibiotics. I think it should go beyond
4 weeks.
You can go right up to 12 weeks.
Yeah, 12 weeks, 8 to 12. And CTON should not be going on for a year or something, again for 3 months or something like that.
Okay. So in 2021, he had COVID-19 category A. He recovered from that, but the bowel got a hit. He started developing loose stools, 5 to 8 loose stools per day with blood and mucus. Again, at this time, he was evaluated with colonoscopy. It showed similar findings, nothing different. So at this time, it was decided to start him on infliximab. He was started at the usual induction dose, and then he was on maintenance 400 milligrams. So just going a little, deviating a little, every patient, the first thing they ask you is what I can eat, what I should not eat, what I should avoid. Quick points about nutrition to the patient. What will you advise? Is there anything? Most of the patients stay off milk. They stay off so many things.
Actually, this has been in a gray area most of the times with IBD. I think even in our ISG task force, I think Dr. Vineet was also one of the things, and we just don't recommend for any mild Crohn's disease any particular diet.
Exactly.
And we don't advise them not to stop milk unless they have a very severe lactose intolerance. There are a lot of diets which have been really discussed, and there is no single society which really recommends a diet. But you have a very aggressive phenotype with small bowel involvement, say enteroenteric fistula. Probably at that point of time, in pediatric Crohn's, it has been found that exclusive enteral nutrition would help. But in adults, again, you could probably give it till patient will be able to tolerate that better because he's got a severe disease. There have been quite a few this in disguise, like is there a role for exclusive enteral nutrition or partial enteral nutrition? Both seem to have had some effect in a severe disease. Till we are able to, once he is able to start feeding himself, I think there's no particular dietary advice to these patients. Then there was a thing, what should we give a low FODMAP diet? But if you think that diarrhea is more in the, is not pathological or more in the mornings, probably that could help, but there is no single criteria, single society guidance to say that you need to give this.
Right.
There has been something on what we called as Crohn's diet, elimination diet, but nothing is really in vogue. I think if patient has got a severe small bowel illness, is malnourished, he may be able to tolerate enteral nutrition. If he's not able to tolerate enteral nutrition, put in an NJ tube and do it.
Okay.
Once he's able to take it, we could almost allow him whatever he wants.
Right. So the problems continued for both the patient as well as for the treating physician. He was on treatment. He developed a flu-like illness. He could not take the medicine for some time. And then the loose stools continued 6 to 8 episodes, no change in spite of the medications. So what would Dr. Matthew Philip do now? Do you go for escalation of the dose? Do you add an immunosuppressant, or you just give it like eating that 5-star ad? No, just do nothing. Wait and give some time.
Wait and watch may not help. But what I suggest is that when a patient is not responding to the biologics you are using, you need to see that is there a reason for that.
Okay.
One is that whether whether the adherence to therapy, because mostly infliximab it is right because they come for infusion. Second is he getting the right dose as per his weight? Third is how is his albumin? How is his nutrition status?
Okay.
All this. And did you give any combination of immunomodulators with this one? All these matters really decide. And if you have done it right way and the patient is also okay, I would go for a therapeutic drug monitoring.
Okay.
Because you have to after 3 doses, if the patient is otherwise okay, albumin everything is fine, he has not responded, then you have to seriously think out whether he is a primary failure or not. I may even wait for a little more, but otherwise I would actually go for a therapeutic drug monitoring.
Okay. So at this point, you would like to go for a monitoring and then
how many doses you have given now? Only 3.
3 doses, and
then there is no role for therapeutic drug monitoring at that time.
At that point of time, yeah.
But
probably it was too early. But however, the treating physician had added prednisolone over the top of infliximab.
I will disagree on that.
I'm just coming to that. The questions are in there. And he was continued the same for 3 months, and the infliximab was a standard dose. So was there any rationale in this, Dr. Somasundaram Bharat? But even I could not take it, but just to put it across.
To start with, before escalation of infliximab, we always get the trough level of the infliximab and also look for any infliximab antibodies.
Yeah.
Because if the antibody level is pretty high, very unlikely that the escalation of the dosage alone is going to make much of a difference.
So, but adding prednisolone to infliximab, there is no rationale for that, no, sir?
The second thing, I am getting a bit hesitant about prednisolone because with the kind of history I see here, the dependency may come up in future. So I think at this time, I would consider switching to a different group of medication altogether. Anti-integrin will be a consideration.
Okay. We'll come to that anyway. Dr.
I think in this patient, instead of adding steroids, probably you could have added azathioprine as an immunomodulator at that point of time.
Okay.
But regarding the infliximab level, that antibody and infliximab levels, antibody testings, if the patients are not really responding to treatment at one point of time, you can check for the infliximab.
Yes.
There's a difference because the disease is very heterogeneous. If we are not able to fix that time, supposing for a fistulizing disease, they say that at least you should have a trough level of nearly 10.1 milligrams before you can really respond. But probably for a colonic disease, it may be between 4 and 8. That's what we think. So if he's not really responding, we could probably test and find out whether and also check the adherence of the treatment for this patient.
Okay. So the trough levels were done. It was low, but the antibody levels were not done, however. And so it was decided to increase the double the dose of infliximab as per the protocol. So I think all of you know about this. This is the highest rail bridge in the world. It's constructed in Chenab, across the Chenab River. So why I brought this here is sometimes you have to get across difficult situations. No, you have to go out of the way to make things easier. So the part 2 of his journey was like he was continued having recurrent fistula, started on biologicals, still having troubles with the biologicals.
And since you talked about the double bridge earlier, so there should have been a double bridge here with methotrexate.
Correct, sir. So the patient in 2022 continued to have symptoms. Infliximab he stopped on his own because he said he felt he was not responding to it. Most of the patients do that because even without, one is cost and second is the response. So Dr. Somasundaram, do you change the biological? I think you said you will go into the other one. So I'll take it at this point. So you started on adalimumab, subcutaneous 160 milligrams, and then followed by 80 milligrams, the usual dosage, with methotrexate directly this time. And then he was on maintenance. His bleeding stopped, but mucus diarrhea persisted. Again, the patient decided to stop methotrexate on his own, and software engineer seeing the Google and let's stop this. The stool frequency remained the same. Quality of life was very poor. And somehow they got the adalimumab levels done. It was marginal. And the dose of adalimumab was increased at this point of time. Again, no response. Budesonide was added. At this point, no response yet. So again, the trouble for the patient, every possible combination has been tried for him. Adalimumab has been added. Methotrexate has been added to it. Still, he continues to be having any problems. So what's the way ahead? Do you go for the newer agents which you are talking, Dr. Vineet Ahuja?
One is, as we discussed before, ustekinumab would be better,
yes,
compared to vedolizumab. And secondly is that in this patient you need to add, as Dr. Matthew Philip also alluded to, serum albumin levels are very strong predictors of whether biologics are going to work or not. So you need to, this is the kind of patient where you would like to put the patient on enteral nutrition, exclusive enteral nutrition for 4 to 8 weeks, and that would potentiate the effect of biologics. So if you give the patient either in the sense that the chances of adalimumab acting whereas it is less, because this patient had a primary non-response to infliximab. If there's a primary non-response to one anti-TNF, the second anti-TNF may not act. If there's a secondary loss of response, then the second anti-TNF would act.
Okay.
So here it would be simple straight answer would be ustekinumab and add enteral nutrition for 8 weeks.
Right.
Curcumin, no, not at all. For it's too light a drug for this.
Any immunomodulator for adalimumab?
Ustekinumab, you don't need an immunomodulator.
Yeah. So it's not like infliximab. Okay. So you want to add?
No, nothing. I think I just want to stress upon nutrition, because now almost if this patient is with me, I would have definitely started the patient on peptamin or some sort of nutrition, because that really helps the patient.
Okay.
And the elimination of certain diet. And actually, even if you are not giving exclusive enteral nutrition, at least, partial enteral nutrition with these type of things really help. And I generally keep them for 2 weeks, no other thing, only exclusive enteral nutrition, not with the tubes, orally itself. Sometimes they find it difficult to tolerate, then I change to other preparations like Ensure, etc. But this I found to be good. Another thing is that once azathioprine has found to be problematic, then I think we should have thought about adding another immunomodulator like methotrexate, which I have found in some situations it really helps. But it is not a very commonly used drug for me, but I have tried in certain situations, found to be good.
Right.
Did we wait enough on this patient really, the duration of infliximab? I think he was stopping himself in many of the patients. The one important thing is he could have waited for some time, and then important thing is an immunomodulator.
Yes, sir.
And to a thing, when we give azathioprine for not this patient, anything, I think we should really go to that particular therapeutic dosage and give it. Many of them start at 25, 50 and stop it. I think unless we monitor and get them to 1.5 to 2, we don't really get that response.
Okay.
And it takes about 3 months for azathioprine or any of these things to act.
Yes. So I think this was discussed in the previous one. So I think this is the final slide. We are running short of time. So how will you manage the cost issues? No, most of the patient run on short of money and they come to us. So how are you going to manage it?
If the patient can come to Apollo Chennai, then don't tell me that the patient cannot afford it. And if the patient comes to Lisi Hospital, my mission hospital, I agree that that is possible. But I tell you, that's why I told you when planning treatment and prerequisite, the financial considerations are very, very important, very strong.
Yeah.
So what I do, I have also very similar patients, they are very poor. This patient, if the patient would have had response, he would have continued. Then that's why I told you, you should have looked for what are the reasons why he's not responsive.
Right.
I cannot even tell it is primary non-response because actually the biological levels are, the biological serum levels are actually low. So
Yes.
only if there is no definite data by which we can say primary non-response, what is the value that I don't think anybody has looked at. But generally, if the values are okay and if the patient do not respond, then I agree that it's a primary non-response. And there is no point in changing out to adalimumab at this point of time.
Okay.
Improve the nutrition and then start one with methotrexate. But cost is a major major issue. And I think, that is where the society, Indian Society of Gastroenterology and all should talk to make guidelines and talk to the government and the agencies that these drugs should be given at a lower price or through some. These are all very important. The tax should be reduced. Somehow, it's actually the burden of IBD is increasing, and
Right.
it affects the younger population. So the people who are going to be the future, they are actually brought down or they become bad and because of physical and mental issues. I think
Right.
we should act, and I am very serious about this with the help of Ahuja.
Sure.
He's in the center. I think we can do something.
You're in the powerhouse now, sir.
And this is the kind of patient which can go in for phase 3 clinical trials, like Dr. Gauch already showed you that case.
I think one question youth is, when do you stop the biologicals?
Yeah.
And I think
You want
there's many of the patients
Have not worked.
have not worked. So if it's working, how long they ask? Rather than again go by Dr. Viz's paper that if you are able to control the disease for at least for a 2-year therapy and predict they're in remission for a year, probably we could just de-escalate and put them on a immunomodulator and see.
Yeah.
But there's no stopping rule in either in US or in
Exactly.
Europe,
So we don't know
which they keep because all the highly insurance.
we can't land yet.
And I think again, Vinith and Govinda says that only 2% of our patients get insurance. We try to talk to the insurance and see, because some of the fistulizing disease, they don't respond even after 3 years, or they become all right only after 3 years.
Right. Okay. So I think we have just one more case.
And last is that if really patient cannot afford, then diverting allostomy.
I think that's the last comment. I think, if the patient cannot afford, then do a diverting allostomy.
Ileostomy at the last.
There-
I think we'll go for the next. This I kept because there was a talk in between. So just like Arnab Goswami, I wanted you to wait. We'll go to the next presentation. There were 2 30-minute presentations.
Only on one slide. One slide and this.
Show your jokes only.
There were 2 30-minute presentations. 15 minutes will finish. 15 minutes. Okay, I think sir wants to go.
Thank you very much. Thanks a lot for the wonderful presentation. As usual, everybody's awake. Thank you, doctor. Usually patients come and see the doctors not only to treat their disease, but also to feel good about themselves. And the sense of humor is too good. Thank you again. And now it's lunch break, and I request within 30 minutes, 30 minutes to be back so that we can start the next session. It'll be tackling the complex scenarios. I request all of you to be back in 30 minutes, 30. Thank you.
Thank you so much.
Dear delegates, thank you very much. I'm sure we had a good break. Another 5 minutes. We'll be starting our next session, tackling the complex situation. So we'll be having the next situation happening, whereby in another 5 minutes, we have all of you here. Thank you very much. For the time being. Thank you very much. And as we said, we are going to start with 2 more sessions now, and session 4 starts now, and it's about tackling complex scenarios. The chairpersons will be Dr. M.S. Revati. Can we have you here, ma'am? Dr. M.S. Revati. She is the professor and HOD for the Department of Gastroenterology from Government Stanley Medical College and Hospital. We warmly welcome you to please go on the stage. I invite now Dr. Kani Sheikh Muhammad. He is the professor of hepatology from Sri Ramchandra Institute of Health, Education and Research. And the third person who will be going on the stage will be Dr. Aditya Shah. Sir, can we have you on the stage? He is the consultant of gastroenterology, Apollo Specialty Hospital, Tenampet. The forum is yours. Thank you.
Good afternoon, everyone. We welcome you all for the post-lunch session. And warmly welcome Dr. Mark Donnelly, consultant gastroenterologist from University of Sheffield, to talk on the management of acute severe ulcerative colitis, do's and don'ts. Welcome, Dr. Mark Donnelly.
Thank you very much. And thank you to Dr. Palaswamy and our good friend Basu for inviting us back. I was struck by this morning's talks that I remember as a research fellow a few years ago now, 1995, in Nottingham, with a guy Chris Hawkey. And that famous gastroenterology front cover, I should explain for the young people, no internet, no mobile phones. We read paper journals made of paper, like a proper magazine. And the front cover of gastroenterology showed a Crohn's perianum area and then a healed picture. I don't know, the older guys may remember that. But this morning it struck me how far we've come from that day in 95, infliximab for perianal Crohn's, to those talks this morning about all these molecules I've never heard of. So yeah, fantastic. So I've been asked to talk by Basu about acute severe colitis do's and don'ts. And I would say that these are things I haven't done and things I have done in my career in gastroenterology. And I got it wrong more than once. I've had to put this slide up because some of us are very proud of being only the second WEO Centre of Excellence in endoscopy after St Mark's in the UK. So I was asked to put that up. So acute severe colitis. I think we forget that acute severe colitis is and was a very serious problem. And it still affects quite a lot of patients. Maybe 1 in 5 patients get acute severe ulcerative colitis. And we've managed to get mortality rates down, but we still have persistently high colectomy rates. Around a third of patients end up having a colectomy with acute severe colitis. And then more recently, we've seen biologicals used earlier and with great effect to prevent colectomy as well as saving lives. So we don't believe in reinventing the wheel. The more mature members may recognize these two guys, Sidney Truelove and Lawrence Witts, who were both in Oxford together in the 50s. And they produced the first ever study proving that steroids save lives in acute severe UC. And just the line at the bottom there, it says that the mortality rate for acute severe UC before that study was published was around 25–30%. So 1/3 of patients who came with acute severe UC died. Is that better? 1/3 died. Okay. Now, that one study published in the BMJ in 55 reduced that mortality rate from around 1/3 to less than 10%. And I think that Vinay said in the first talk this morning, second talk this morning, time hazes me, that the impact of studies was greater in the 50s and 60s now. Well, that was one study that changed our practice and changed lives. Truelove and Witts, of course, gave us the Truelove and Witts criteria. And you'll all know this, these criteria, I'm sure, based on number of motions per day with visible blood and at least one of a high temperature, tachycardia, anemia, or raised DSR. And we still use Truelove and Witts today, mostly. So the first do is, do use Truelove and Witts to diagnose acute severe UC. There are other scoring systems around, and I'm sure if you're keen and dedicated and lots of time, you can use the more complex ones. But the ones that we still use in the UK mainly are Truelove and Witts. So that's the first do, use Truelove and Witts or another criteria to actually label people as having acute severe ulcerative colitis. The second do is to start IV high-dose steroids promptly together with prophylaxis. And in fact, although the first study was published in 55 by Truelove and Witts, the Oxford regimen, as it was then called, only came out really in the mid-early 70s. And that is high-dose IV steroids for 5 to 7 days with an early colectomy for non-responders. And that brought the mortality rate down from those 1/3 of patients to, vanishingly small, less than 2% of patients were dying with acute severe UC. We shouldn't underestimate, however, that acute severe UC is a life-threatening complication of ulcerative colitis that kills patients. The next do is do closely monitor, reassess frequently, daily CRP, hemoglobin, albumin, plain films, and involve the surgeon's stoma care early. So what I don't want to do is spring a surgeon and a stoma nurse on a patient who's been ill for 7 days, 9 days, is going downhill rapidly, feeling very terrible. We bring this big man in with his big metal knife and we say, right, this man's going to take your bowel out. I think it's really, really good practice to involve them on day 1 or day 2. And we've got some fantastic surgeons we work with. I remember one guy, particularly Paul Skinner, colleague of ours, he'll come in and say, I'm just touching base with you. Nice to meet you. You won't see me again, but if you do need me, I'll be back in about a week's time. And just to preempt that whole discussion about surgery and stoma early on, don't leave it till they're really, needing it. They're acutely unwell. Do it very early. So that's the third do. The fourth do is to do an early unprepared flexi-siggy. We'd prefer that within 24 hours, maximum 48 hours. You're not doing that really to prove or disprove the diagnosis. These patients have UC, but you're doing it to help you exclude complications of the UC, like infection with C. diff or CMV. And also you can get an endoscopic idea of how bad things are. So we never like deep, serpiginous, snake-like ulcers in acute severe UC. They're a bad sign. So it gives you a view of the mucosa, but it gives you a chance to exclude concomitant infection. Really important to do that. There's more Oxford links now, I'm afraid. So just a bit about scoring systems, predicting non-response. So Simon Travis is the main author of the Travis score, but Derek Jewell was his mentor and professor at Oxford. And in fact, whenever I see Derek's picture, it always slightly unnerves me because years of giving presentation at the BSG and Derek Jewell in the audience standing up to ask a question is absolutely horrifying. So I'm slightly nervous just here looking at him now. The really interesting thing about Simon Travis' study and the whole Travis criteria, that was a retrospective case series of 48 patients. So it wasn't an RCT, it wasn't a meta-analysis, it was 48 patients that Oxford looked back on and said, if you have acute severe UC, what identifies if you do badly? And that's what Travis criteria based on. So the Travis criteria, as you know, are on day 3, has the patient still having 8 stools a day, is a CRP more than 45? If they have that on day 3, they've got a high chance of colectomy. There are other scores, but I've got to say, again, I spoke to my younger colleagues before I came out here from the UK, because I don't do IBD anymore. But I spoke to them, I said, are you still using Travis? They said, oh yeah, still using Travis. What about the Scottish ones or Lindgren? And they're too complicated for the juniors to understand. We just use Travis and it's easy. So do use Travis. Here's the first don't ignore the data. So if the CRP is more than 45 or is more than 8 stools a day on day 3 of high dose IV steroids, there's a high chance of non-response. You need to do something. I think it's always tempting to say they're looking better, they're feeling a bit better, they say they're feeling better. Ignore how they feel and how they look. Go on what the data's saying. Have they still got torrential diarrhea? Is the CRP still going up or hasn't come down? You need to change something. What do you do on day 3? Well, I think there are a number of options really. So I think infliximab is definitely favored among the UK. Cyclosporin had its day, but cyclosporin seems to have faded from the scene really in terms of acute severe UC. We're using infliximab now on day 3. Obviously, in this country particularly, you need TB screening. We do TB screening in the UK as well. There's questions around infliximab dosing. What's the regime? Do you go for a high dose early on and then take it down quickly? What are long-term safety data like? And of course, the new molecules around that I can't pronounce, but the new molecules may take over infliximab, but right now it is day 3 non-responders infliximab. And I've got another don't for you. Despite infliximab and all these fantastic things, the final don't is don't delay colectomy. So I worked for someone once who said to me, they're better off going home without a colon than going home in a coffin, which is dramatic stuff, but it's absolutely true. The mortality rate for colectomy, if the acute severe UC is non-perforated, is vanishingly small. If they perforate, that mortality rate goes up to 30%. So it's really important not to delay colectomy. If they need a colectomy, have the colectomy done. So to summarize, acute severe UC do's and don'ts. Do diagnose early, use 211 WITS. Do start high dose IV steroids and thromboprophylaxis urgently. Do monitor closely with the early involvement of surgeons, stomotherapists, etc. Do an early unprepped flex SIGI, exclude CMV and C. diff. 2 don'ts. Don't ignore the data. So the patients, if the scoring system says they're going the wrong way, they're going the wrong way. It doesn't matter how well they feel, how well they look, they're going the wrong way. And then finally, don't delay colectomy. If they're not responding on day 3, infliximab, if not responding on day 7, colectomy. And I think I'm the first person to be well within 15 minutes. Thank you. Sit down.
Thank you very much, sir, for your nice lucid presentation. Still, as we have time, we can take some questions now.
Thank you very much, Dr. Mark Donnelly, for giving clear, crisp details on do's and don'ts. And now we go for the panel discussion. And thank you, chairpersons, Dr. Revati, Dr. Kani Sheikh Mohammed, and Dr. Adisha Shah. You can take your respective seats on the, yes, thank you so much. Thank you. We have our moderator, Dr. Ravi. We request your kind presence on the stage, sir, to moderate this session, and the panelists, Dr. Santosh Anand, can we have you on stage, please? Followed by Dr. M. Bharat Kumar, Dr. S. Arul Prakash, Dr. R. Vinod Kumar, Dr. N. Tirumurthy. I request all your kind presence on the stage, please. Thank you.
Good afternoon, everybody. I must confess, this is the first time I'm on a stage for an IBD. So I should thank Basumani for giving such wonderful first time life experience. Okay, he has given me two cases to discuss. Some of them IBD complication. So I have five knowledgeable panelists to assist me in this. So the first case is perianal Crohn's disease, whether a medical treatment, ceton, or surgery. This is a 32-year-old lady investigated for diarrhea, anemia, loss of weight, history of Crohn's disease on treatment, more than 5 years. What treatment? Mesalamine, SR 4.8 gram per day and probiotic. And now she developed a pain in the perineal region. So I'm going to ask the first question to Bharat. Is mesocol enough for Crohn's disease? However mild it is.
So since the lecture since morning, even our audiovisual man will be able to say mesocol is not going to be enough. So the patient is on Crohn's disease, having treatment for Crohn's disease on a very suboptimal treatment regime, and she seems to be developing some perianal complication. So mesocol is just not enough. So we are going to think about evaluating her more, and then think about stepping up the treatment to something.
So until this time, it was not Basumani's patient. You wouldn't have treated this patient with mesocol. So there are several anal and perineal conditions associated with Crohn's disease. So Dr. Tirumurthy, please tell me some of the.
As we all know, this is a Crohn's disease, a chronic inflammatory disease, affects from oral cavity to anus. The perianal involvement is associated, higher prevalence associated with the longer the duration of disease and the severe the Crohn's disease severity, and it is a distal colonic involvement. In these kind of patients, they are prone for perianal disease. And the longer the duration, again, it is up to 5 to 40% of the patients will develop perianal disease. As we are seeing the screen, the patients can have anything, perianal fistula, abscess or fissures, ulcer or stricture or stenosis.
Thank you. And assessment was done. These are the report which are given to me. And patient had on examination gluteal region tenderness and CBC renal function test left were normal. CRP was 13. But fecal calprotectin was very high. Sigmoidoscopy was done and showed this floret picture, deep ulcers in the sigmoid colon. And biopsy was typical for Crohn's disease, including presence of granuloma. How do we investigate further, Dr. Vinod?
Since the patient has perianal symptoms and gluteal tenderness, probably it's better to do some sort of imaging. I prefer to do an MRI rather than CT. If there is a fistula, MRI pelvis will give us a detailed explanation about the fistula. Whereas we see in the screen, digital examination is not routinely done because of pain. MRI, CT, it's not sensitive for diagnosing perianal fistula. It's between MRI and UUS. Definitely UVA examination anesthesia can be done, and fistulous opening can be found out, but it's between basically MRI and UUS. The problem is like UUS is not routinely available, and the expertise should be needed for UUS, but whereas MRI pelvis is a better option.
So, Dr. Arul, do you do US?
If it is the first time we are imaging the patient, we should go for a CT as well to know where else the disease is involved, like in small bowel. Otherwise, as Dr. Vinod said, MRI will give more information about the fistula.
I have access to US, but even when there is a patient, I usually don't offer US because our knowledge so far hasn't gained in US examination. If there is an abscess, I have done a few drainages, but for diagnostic purpose, I haven't done a US. So this is the MR imaging, fistula, active fistulous tract.
leading posteriorly into two tracts, ending in a large abscess on either side of ischioanal fossa and in gluteal region. So small introduction. At least in 5% of patient, perianal fistula is the presenting symptom for Crohn's disease. And 1/3 of patients had already had a perianal surgery before the diagnosis of Crohn's. Lifetime, 1 in 3 patients will have symptoms and complication. And it can lead to social isolation, urgency because of urgency, frequency, stool incontinence, skin issues, pain, soiling, sleep disturbance, sexual dysfunction, and sepsis. The goals of treatment are short-term and long-term. Short-term is drainage of abscess, relief of symptom. Long-term is resolution of drainage, fistula closure, improved quality of life, avoidance of proctocolectomy, and avoidance of permanent ostomy. Dr. Santosh, how do we go about it? Tell us about some relevant anatomy, fistula classification, and relevance.
Perianal fistulas, by and large, there are so many classifications, but what we follow commonly is Sparks classification as it is depicted in the pictures. So it can be simple fistulas and complex fistulas. Simple fistulas has single external opening with a single internal opening with a straightforward tract. If this fistula tract has got secondary tracts or it is associated with an abscess or stricture, or it's a complicated one, like one of these classifications, then it becomes complex fistulas. To elaborate the types of fistulas, we have the most simplest one is the superficial fistula, where it doesn't cross any sphincter complex per se. It has an external opening, it has an internal opening. So if we see all of these classifications, most of them end up in anal sinus, where the anal gland ends, except for the most complex fistula, which is the extrasphincteric fistula, which is otherwise a pelvic fistula, pelvic abscess, which is leading into that. So the other common fistulas include intersphincteric ones, where the external opening, single and the single internal opening, it goes between the internal and the external sphincter. So transsphincteric fistula crosses both external and internal sphincter, and the suprasphincteric one, though it opens into the anal gland region or the anal sinus region, it can extend in the intersphincteric space to the level of till levator ani muscle.
Thank you, Arun. I want to have a small word about this internal and external. Generally, long time, I thought internal means it is internal, far away from anal canal is internal sphincter. It is not like that. Internal is close to the lumen, which is an extension of circular muscle fiber of the rectum. The external is away from the anal canal. It is not inside and outside. So how do you manage, Dr. Arun, immune modulator, biological, antibiotic? What do we do that? She has a fistula and an abscess.
So when this is a complex patient who has an abscess and fistula, so whenever we encounter such problems, so first we have to drain the abscess to get rid of the infection and to control the inflammation. The idea is to treat the infection and reduce the inflammation. Hence, it has to be drained in a feasible way. It should be individualized, and the patient should be started on biologicals as early as possible in combination with immunomodulators. It's acceptable. Yes, antibiotics based on the cultures, we have to continue. Antibiotics plus these immunomodulators are found to be helpful in good number of patients. The modality of drainage, which may be surgical or EUS, as Dr. Ravi suggested, whichever is feasible, we have to drain it. And in case if it requires a set-on, we have to apply that. So the idea is get rid of the infection, starting on biologicals or immunomodulator without treating the infection, it's going to be dismal. And there is no role of steroid in this situation.
Actually, the abscess should be drained first, and it might take a variable period of time, sometime even months before a patient is suitable enough to start on biological. So incision and drainage of bilateral ischioanal abscess with loose set-on placement done. For the medical gastros, Dr. Santosh, what is a ceton and how does it work?
Ceton is actually either it can be a elastic tube or sometimes we use a thread silk suture also, sir. So what happens is it passes through the external opening, comes out through the internal opening, through the anal canal or anus, it comes outside, which is tied loosely on the perineal skin. So it is of different types. Like it can be a loose ceton or it can be cutting ceton. The latter is rarely used these days. The purpose is to keep the tract open so that the abscess or the fistula drains completely and it avoids closure of the tract prematurely. If it closes prematurely, then it can lead to recurrent abscesses or so. And this is preferred when there is a significant amount of sphincter complex which is present distal to the fistula. In such case, if we do a major surgery or a fistulotomy, then the patient may end up with incontinence. That is prevented by using ceton.
So, thank you. How do we take care of the ceton? So if you leave it like that, sometime it gets occluded, you know. They say you need to move the ceton patient themselves in and out, and they should be careful that the tied end, if it goes inside, then it blocks.
It should not move inside, sir. And we should not over clean the region also. And at the same time, if we develop any kind of significant pain not getting controlled with routine analgesics, there is a bleeding significantly. And again, pus discharge, it is better to consult a surgeon again.
So they should report if there is an increased swelling, pain, difficulty in sitting again. And if the ceton has fallen, they need to, the cutting ceton is ceton tightened every 2 to 3 weeks as tolerated. It is painful for the initial 2 days when it is tied out. But then with analgesics, it can be managed. And in January 2021, patient underwent a fistulotomy following examination and anesthesia and ceton removal and started on infliximab. Already we have discussed that biological should be started as early as possible, but not before control of abscess and infection.
Yes, sir.
Tell us more about biological. What biological? Is there any preference of biological?
Biologicals are basically medicines which modify immunomodulators. Since morning we have been listening. But then when do we start a biological on a person who is presenting with perineal Crohn's? After eliminating the complete infection, as Dr. Arul has mentioned, we should make sure that the infection is cleared off and the abscess is drained well. It is prudent to start them on biologicals of perineal Crohn's because the remission rate is pretty high with the usage of biologicals. For now, the ideal one to begin with is infliximab. And we have the best evidence for infliximab for now for fistulizing Crohn's. And adalimumab for ease of administration and availability and cost for biosimilars, they can also be used now. But what are the precautions we do take in the Indian subcontinent? We are always concerned about tuberculosis. We should make sure that we rule out any latent infection in the form of TB or any chronic viral hepatitis like chronic hepatitis B or C, which needs to be ruled out before we start them on any biologicals. Ruling out latent tuberculosis, we do have these 3 modalities. One, we check we do a HRCT chest, or we do a Manto or a quantiferon TB. I would prefer to start them with HRCT chest. With regards to NAT testing for hepatitis B and C, it's economical in our place, and we do a nucleic acid testing for hepatitis B and C before we start them on biologicals. So those are the precautions I would like to take before we start them on biologicals. Infliximab is ideal. Adalimumab is also used. We make sure the patient is not having any latent TB or any subclinical viral hepatitis.
So patient had 3 doses of infliximab, developed infective diarrhea, stool routine showed pus cell, sample were negative for cryptosporidium, and again endoscopy showed very deep ulcer, but patient is negative for CME, but showed severe crypt destruction. Arul, do you involve ID person now, or Actually, routinely nowadays, before starting adalimumab, I send them to ID. I don't know what they do. They investigate them, they prescribe vaccinations, and finally it ends up very expensive. But then I routinely send them for an ID specialist. Do you do that? And when?
So ID person, one reason is, as you said, to check their vaccination status and get vaccinated before starting biologicals. And in such situation where you have severe ulcers and they don't show an improvement, you have to suspect superadded infection like CMV. In case if we suspect CMV infection, probably we can take biopsies, do blood PCR, do antibody testing, CMV, IgM in blood, and look for histopathological features of cytomegalovirus infection. In case if you have a convincing evidence of more than 2 positivity, then you can think about starting on ganciclovir. Probably at that point of time, we can involve ID person to treat.
Okay, this patient was treated with ciprofloxacin metronidazole and patient improved subsequently. But again, after 6 months, patient developed a recurrent fistula in ano with post discharge. This time, patient underwent partial laying open of fistula, Citan reinsertion, excision of hypertrophic perianal tissue. So, what are the options, Tirumurthy, now? So, this patient is again, we can even try once again complete treatment, but
it appears it is poorly responding to the whatever biological therapy and other thing, and still patient persists to have a fistula and pus discharge. Here we can approach in 2 ways. The fistulas are persisting, but if has no symptoms, then in that case we can continue with the biological with immunomodulators and we can observe. But in this case, a patient is having fistula, persistent fistula with pus discharge, so it is symptomatic. Then we have to think of either a resection techniques or non-resection one. Resection is as like temporary diverting stoma and proctocolectomy and permanent stoma. But this patient, a young patient, we have to discuss with the patient or the various options, because even keeping a stoma, whether it is a temporary or permanent, it is going to be a lot of social and other issues are going to be there. So we have to discuss with the patient between the resection and non-resection techniques. Non-resection, like that ligation of intersphincteric fistulous tract and some stem cell therapy, all those things are there. But out of resection and non-resection technique, the resection techniques are proven more than the non-resection, like stem cell therapy or ligation techniques.
so thank you. But I have a few patients who have complex fistulas and very frequent soiling, a lot of sexual dysfunction. So we advise them temporary ostomy, and both the young guys, now they don't want to go back. They are happy with the ostomy, the comfort they enjoy with ostomy. So maybe ostomy is not a bad one. So there are some non-resection procedures, anal plug and mucosal advancement flap and ligation of the fistula tract. Have you done, Santosh?
So this lift procedure we do even for non-Crohn's complex fistulas. So what we do is we excise the external portion from the perianal skin till the level of the sphincters, particularly the intersphincteric tract. There we ligate so that we disconnect the communication between the anus and the outside. The results of this are very good if it is done meticulously, properly found, and when the fistulous tract is matured. This, along with biological agents, usually gives more than 70-75% of resolution. So this is a very good procedure, sir. Other procedure is WAF, in which the external portion is removed. Through a video endoscope, we go find all small branches and either cauterize the branch, something like curettage, so that all the branches are taken care of.
So thank you. So all along, medical gastroenterologists have been bystanders in management of fistulas. the first thing, at least I do, is refer the patient to surgeon. Now, after seeing morning videos, I think we can try putting a seat on. It looks simple. Frustrating for providers to effectively treat, and because antibiotic and immunomodulators have limited efficacy, biologics are the best medical option. Surgery has a high rate of recurrence for most patients, with ever-present risk of stomas, incontinence, and poor wound healing. So, perineal fistulas require a multidisciplinary approach involving gastroenterologist. Maybe in the future, just like colorectal surgeon, some of us might become a colorectal physicians, fully surviving on colon and rectum, anus, advanced imaging radiologist. Maybe we don't use wound care nurses as often in Western world. Maybe we should look at this part of a care. Next case presentation. So we'll move on to the next case, which is structuring Crohn's disease. Again, 18-year-old male, abdominal pain 20 days, vomiting 4 days, bloating, diagnosed of Crohn's disease 8 years back. So he had all the setting, 10 years post-diagnosis. He has a high risk of developing complications. CRP was 6.8, hemoglobin 9.7, but the albumin was very low. CT showed distal iliac thickening with a collection in right iliac fossa. Improved clinically with conservative treatment. MRI showed a similar picture. Dr. Santosh, do you want to operate now?
Actually, the imaging shows not much dilatation caused by the stricture. So whenever there is a collection inside without significant obstruction, particularly in an inflammatory cause, we wish to drain the abscess first, preferably percutaneous approach. With the background of very low hemoglobin, very low albumin, so any surgery, particularly in inflammatory background, has got a very high risk of leak and further fistula formation. So we try mostly conservative management. Only if it is florid obstruction or florid peritonitis, then we wish to operate.
What will you do? He will advise percutaneous drainage or conservatively manage.
Drainage can be done separately.
So this patient probably did not have an access for percutaneous drainage, and surgery was deferred because of poor general condition. But then with treatment, his abscess subsided. Bharat, what is it? How did we go about this? Subsided with antibiotic treatment.
Yeah.
So now he is only the stricture.
Yeah. This is a Crohn's disease patient who is presenting with an intra-abdominal abscess following a stricture. The principle goes, we need to drain any collection anywhere, whether it's an infected collection, non-infected collection. Infected collection, preferably, it has to drain with the coverage of antibiotics. It looks like an infected coverage. I mean, ideal is to drain, preferably percutaneous drainage or endoscopic drainage if feasible, and then give a good antibiotic cover and wait for the person to improve. If the patient is not making a good improvement, then you ideally re-image and see. If it is things are getting worsened, then you have to assess for any surgical drainage. If the patient is getting on the improving trend, continue antibiotics, wait for at least 4 to 6 weeks, and then re-image. And if the patient is healed quite well, then we can think about starting on biologicals. If the patient has not made the progress as we expect, even after percutaneous drainage, we should still contemplate thinking about a surgical drainage with antibiotic cover. So after a surgical drainage, once again, we re-image after 4 to 6 weeks, make sure the assessment is quite clear. Then we think about starting on biologicals. So first, the source of sepsis needs to be cleared quite well. Before we think about starting on any successful Crohn's disease management in the form of an immunomodulation.
So thank you. The patient become better with antibiotic, but again readmitted a month later with the same complaint. But this time, patient was started on adalimumab. Obviously, I understand the abscess was not there. Surgery was deferred because of poor general condition as well as unwillingness of patient to undergo surgery. Azathioprine was started after 2 weeks. We know what are the type of strictures, what are the areas of stricture in IBD, what are the endoscopic options?
So the strictures in Crohn's can be a primary stricture or an anastomotic stricture. Again, primary stricture can be an inflammatory stricture or a fibrotic stricture. It can be differentiated by an MRI. Endoscopic options. The slide, sir. The second, no, sorry. Back, sir. No, back. Back, sir. Okay. So the typical, area of common area of stricture formation is terminal ileum, which is more common in Crohn's patients. And endoscopic options, there are various options available. One is better understood is endoscopic balloon dilatation, and endoscopic stricturotomy can also be done with stricturoplasty. And the last is SIMS placement. Coming to one by one, regarding this endoscopic balloon dilatation, first we all should know the length of the stricture. It's indicated when the stricture is less than 5 centimeter in length, and the opposite lumen is straight, it's not curved. We can safely do an endoscopic balloon dilatation. If we already found a stricture on imaging, it's better to go with a pediatric colonoscope rather than a conventional colonoscope, so that you can easily negotiate the stricture and you can see the distal areas more clearly. There are some prerequisites before a balloon dilatation. Like if the you should dilate by 1 to 2 millimeter more of the stricture's lumen. For example, the stricture's lumen is around 10 millimeter. You should start dilating 11 and 12 and keep it for 30 to 60 seconds and then gradually dilate more. You should not dilate more than 20 millimeter. Always use carbon dioxide insufflation. And last but not the least, always have a surgical team behind next to you, because the perforations are more common. If the patient is on steroids, the chance of perforation is more. And second thing is like if the stricture is in the mid small bowel, now we have this motorized enteroscope, we can do balloon dilatation. And we also should know that pre-stenotic dilatation, if there is pre-stenotic dilatation, it's better to go for a surgery. If there are multiple strictures in the nearby areas, better to go for surgery. The other options are endoscopic sphincterotomy, where we do a needle incision, either
we will go a little bit later, slowly, I think. So he has told several options: de novo structure, inflammatory, fibrotic. MR and MR can help to a certain extent to differentiating between inflammatory, but most of the time these strictures are a combination of both inflammatory and fibrotic. If there is signs and symptoms of obstruction, maybe fibrotic element is more. You said endoscopic balloon dilatation first. Why do we do a balloon dilatation? For symptom relief and to postpone surgery. Many of these patients are clinically not okay and surgically suboptimal. So if you can get relief and make them eat and nutritionally make them better, it is good. And also, if you dilate, you can either examine the proximal and distal bowel for lesion. Only if you evaluate, you can do that. How do you evaluate, Dr. Trimurthy?
This for evaluation of stricture, the purposes, one is what is the mode of treatment we have to select, that depends on the stricture evaluation. For example, the length of the stricture. If it is more than 5 centimeter, then it is better to go for surgery. And there is a pre-stenotic dilatation and number of strictures. All these things we have to differentiate so that we can select for whether we have to go for endoscopic therapy or the surgical therapy. For that, we have to go for imaging like MR enterography or a CT enterography. MR enterography has a little advantage over CT because it can relatively we can differentiate whether it is an inflammatory stricture or it's a fibrotic stricture. So if you have a both this thing combined, if we can do that will be better. Based on that, we can differentiate the type of length of stricture, and accordingly we can decide the treatment.
Yeah, but not only the length of stricture and the anatomy and everything, there is one more background disease. Sometimes these patients have recurrent strictures. And if suppose the patient is a stricturing phenotype, he will develop a stricture later on in other places also. Many of them, if you do surgery, they will end up with the short bowel syndrome. So there will be always some patients who have a longer stricture, but then you can't afford to do a resection further because they won't have enough bowel left. So sometimes these are all complex situations where you may be doing a balloon dilatation even with a longer stricture. So MR and CT will delineate the location, extent of stricture, to a certain extent diameter of the lumen, concurrent inflammation and presence of collection. But barium also has a role, particularly in pouch-related strictures. CT and MR has a poor sensitivity in those situations. Barium still has a big role. It also localizes the stricture and the length. It can find out sinus tract and fistulous tract. So, what is I read, it looked to me very interesting, so I put this slide for.
So
sign, it's a long
string sign of Cantor, markedly long segment. It's a positive contrast finding, a radiological finding usually seen with barium or with positive contrast. A thread like the small bowel segment, long segment looks like a thread like stricture. And there are various mechanisms proposed. It's usually due to an inflammatory edema or an ulceration resulting in a spasm. Or this can happen because of strictures or fibrotic strictures as well. In olden days, perhaps when they used an antispasmodic, if there is a variable diameter, then they took it as a reason of that it could be an inflammatory spasm, which is causing that sign rather than a fibrotic stricture. So that's the significance of string sign of Cantor. So using if it is due to spasm related with inflammation, using an antispasmodic like glucagon will cause a variation in the diameter. Whereas if it is a fibrotic stricture, it doesn't change.
So, Dr. Arun, Dr. Vinod started about scope. I mean, what scope? So actually, if you use a pediatric scope, maybe it's easier to go through a small lumen. You meant pediatric upper GI endoscope? Pediatric colonoscope. So many places won't have pediatric colonoscope. Upper pediatric scope won't be useful because the working channel is very narrow. So pediatric colonoscope, it can be used at the top and bottom. It is more flexible and it has a working channel which will accommodate. But what about the other scopes? Your
Enteroscopes.
Your endoscope, spiral endoscope.
Enteroscope has a diameter which can accommodate a balloon, guide wire, and all gadgets which we can use in a colonoscope. So I think it's all where it's located. If it's in the terminal ileum, yes, colonoscope. As you said, using a thinner scope, always there will be excess looping and reaching that portion will be a problem. So enteroscope, we can reach, if it is a single stricture, we can reach that part. And if it is a single short stricture, straight stricture without any adjacent collection, we can try to dilate. As already said, it's like you can dilate up to 18 maximum. 25 is maximum what they claim, but whenever they dilate more than 20, there is a risk of perforation. So we have to be using the dilatation very judiciously to avoid complications.
Thank you. Sometimes they will have a very distal strictures in proximal distal jejunum. Maybe you have to use some of these single balloon, double balloon to reach that place. So the size of balloon, if you have you need to assess the stricture initially. What is the size of the lumen at the index time. So generally, you shouldn't dilate more than 4 to 5 millimeter than the index side. Then if you want to get to a 18 millimeter, you need to come back again after
Repeated
2-3 months. Not at the initial attempt, we shouldn't dilate a 3 millimeter stricture into 18 millimeter. It will result in perforation. So standard is 18 millimeter. Anything above the risk of perforation is very high. The Pirama, you want to say something? Mike. To the panelists, not to me.
No, that's the diameter to which we dilate. Should it depend? I mean, why should we go up to 18? What is so important about the 18? I mean, if it is in the right, suppose it's an anastomotic stricture or in the right or ileocecal region, most of the effluent is going to be liquid. So do we really need to dilate to 18? I can understand.
So studies have shown if you dilate to 18, the recurrence of stricture and subsequent need for surgery or repeat dilatations are less. If you are not able to reach that size, so those patients will require more frequent symptoms and requiring repeated dilatation. So 18 is a standard dilatation to which that is what is published.
Okay,
they always try to reach to that side. If you reach to high level, then the risk of perforation is high. It's usually 3% complications.
If it's in the left colon, we expect more solid stools. If it's in the right colon, it's going to be more liquid effluent. So should we really dilate to that is my question.
I think I would agree that right colon also you should dilate till 18 millimeters. Ileocecal, particularly the deformities at time in tuberculosis or in Crohn's disease at the ileocecal valve. So there the recurrence chances are higher if you don't dilate it up to 18 millimeter. Small bowel, obviously, when you're dilating with the motorized enteroscope, then you cannot go up to 18 millimeters at repeat.
So do you go above 18 millimeters? Huh? Do you go above 18 any time, 20, 22 millimeters?
No, we haven't gone above 18.
So
we stop at 18 because it suffices the purpose most of the times.
So when do you, Dr. Trimurthy, when do you refer to surgery? If how many attempts at balloon dilatation one can try?
If the patient is frequently becoming symptomatic, even in spite of dilatations, or a patient presents with some obstructive features or penetrating features, then we have to send the patient for surgeries.
Okay, patient was asymptomatic for the next 4 months. A relapse of symptom again after some time. Laparoscopic limited hemicolectomy. So, Dr. Santosh, how do we follow up post-operatively?
So if you see for immediate post-operative period, these patients will be nutritionally compromised. So for some time, they may require perioperative partial or total parenteral nutrition in addition to enteral nutrition when their bowel function restores. In the long term, again, we will see for any recurrent strictures in those regions, which will be followed endoscopically or through any imaging. What can be given in the perioperative period if they were on long-term steroids, that has to be given at a dose to check for the stress. Thiopurines can be continued, but immunomodulators, yes, definitely they have negative outcome of the chances of negative outcome of surgery in the form of leak is higher, so that has to be monitored closely.
Arul, so ulcerative colitis, it generally doesn't recur except pouchitis if they have symptom. But Crohn's, do we not need to see them after 6 months to look for ulcers at anastomotic site?
Definitely, so there has to be a close follow-up, and after surgery, particularly for Crohn's, we should be more aggressive on treating them because the chance of recurrence is high. So we have to, go for immunomodulators or biological as early as possible to prevent recurrence.
So I thank you, everybody. I think there is 5 more minutes. If there is any discussion, suggestion, Dr. LVK. Anybody?
So I have one this thing. As far as the colonic stricture, especially left-sided colonic stricture is concerned, is it the literature says we have to rule out malignancy before going for dilatation? So,
Yes.
as compared to the small bowel.
There are a few things we need to do. One is to look whether there is a sinus tract penetrating disease and what is the length of stricture. If it is longer, then it will be ineffective. The other one is malignancy. We need to rule out it's even though it is less common compared to ulcerative colitis, but it does happen. So we need to rule out. Otherwise, if you do a dilatation, still it will be effective, and then you are postponing diagnosis and allowing these tumors to spread. Dr. Loganathan, sir, Dr. Palaniswamy. Basu. Anything? Mahadevan. Do you dilate Mahadevan strictures? My experience is very limited. Generally, the kind of complex disease, multiple strictures, I don't, if I see them, I send them to people who are experienced in IBD. So,
You heard the lecture in the morning on interventional IBD.
First,
I think probably all of us should start doing it now.
stricture, yeah. At least perianal fistula, we can try putting in a sit-on.
Sir,
Surgeons will be angry with it.
So it's a question to Dr. Vineet. In post-operative period, how early you want to start on biological, sir? Like there will always be a question with the surgeons that there may be leaks and problems with.
You can start within 4 weeks if the requirement is, depends upon what the patient was, what was the situation of the patient before. If the patient, let's say, had a enteric fistula, was operated, has a very high disease burden and was operated, so the course is going to be very aggressive. So you can start within 4 weeks.
Along with immunomodulators.
So you can start with biologicals and add immunomodulators later on. And what we do generally for most postoperative is start antibiotics for 2-3 months, then start azathioprine, then if required, they go on to biologics. But in a patient who has had a very aggressive disease course earlier with the chance of recurrence are very high, there within 4 weeks, you can start biologics.
So if it is a disease which is limited to a small area, the physician and the surgeon and patient tend to think maybe surgery is the only option, only needed treatment. We may not get a recurrence, and many times the treatment is avoided.
So for that, there's a Rutgers classification that is postoperatively you have to do a colonoscopy at 3 to 6 months, best is around 6 months. So at the anastomotic site, there are aphthous ulcers which are few less than 5, then you can just treat with 5 ASs and all. If the aphthous ulcers are more or circumferential ulcers and strictures, which is known as Rutgers classification, I3, 4, or 5, then in that cases, you have to move on to higher end immunosuppressive therapy. So you can just periodically evaluate with just fecal calprotectin or colonoscopy, and based on the Rutgers score, you can decide whether to give any therapy or not. But in 80% of 80 to 90% of them would have a recurrence ultimately.
So
but comes back with recurrent obstruction. I sometimes feel that probably a limited ileocecal resection followed by immunomodulator. Azathioprine, most of them may not require biologicals for a long time. In fact, they prefer, financially also it's much easier for them to undergo one procedure and then. So it's been seen that if the burden of the disease comes down, you can probably maintain them just on azathioprine to prevent recurrence.
So I thank all the panelists. Thank you, Basumani, for giving this talk.
Thanks a lot, Dr. Ravi, and all the panelists who've come. Thank you very much. We come to the last session of the day, session 5. Before we go to that, I have an important announcement. For those who are supposed to sign, have you done it? They wanted to know the CME, the continuous medical evaluation. And please do get your participation certificate. kindly do not forget, please sign and get the participation certificate. And high tea will be served around 4 after the end of the session. So I request all of you to be here to do the networking, and personal one-on-one discussion can also happen. So I request all of you to please remain. And we come to the last session, session 5, and the topic will be on the late complications. The chairpersons will be Dr. Ema Vijay Lakshmi. Can I have you on the stage, please? She's the professor for the Department of Gastroenterology from Sri Balaji Medical College. Invite Dr. A. Sangameshwaran. He is the consultant gastroenterologist for Hindustan Hospital, Coimbatore. And we have the third panelist, Dr. N. Arun. He's the consultant gastroenterologist for Apollo Main Hospital. They'll be taking over the forum now. Thank you very much.
Good afternoon. At the outset, on behalf of my co-chairpersons, I would like to thank the organizing committee for this opportunity. As mentioned, today our last topic is IBD, neoplasia in IBD, dysplasia and neoplasia in IBD. And all of us are aware that ulcerative colitis patients or Crohn's disease patients are more prone to have colorectal malignancies, which is higher than the general population. And today we had an exhaustive discussion from morning regarding the newer molecules. And obviously the medical management has improved in IBD patients. And we have powerful colonoscopies also to detect dysplasia. So to talk on dysplasia and IBD, I invite Dr. Taufik to share his experiences with us.
Thank you very much. After this, we'll be having the panel discussion. We'll have a moderator, Dr. P. Perumanayagam, and the panelists. I'll introduce the names of the people who will be doing it. So this session is about the late complications. They said in the beginning, early the treatment, the better. Now we come to the end of the session, what happens in the late complications? So we are just doing a little bit of work on the video recorded one. So kindly bear with us.
Also, the increased risk for thorns and also compared to the general population. And I think these were within cardiovascular. Increased risk for thorns and also compared to the general population. And I think these were within cardiovascular recovery. Thorns disease, the risk is the same. Some of the Crohn's disease infection in colon, we should treat this inflammation and then focus on dysplasia. We do know that there are risk for lung cancer too. So what about the risk factors that will increase the risk of colorectal cancers in colitis or in first colitis? So the non-modifiable factors are also the modifiable factors. The non-modifiable factors which we can modify is the duration of the disease, the extent of the disease perhaps, and also we have family sclerosing, cholangitis, days increase, or the pregnancy increases, or you have family history of colon cancer, or you have an inflammatory cause. The thing that we can see in modify and perhaps also intervene and make a change is try and inflamed epithelium to reducing to dysplasia and to cancer. And how do we actually do this? For this, we need to identify and see if they do have dysplasia. You stratify them into lows, intermediates, and highs. So usually that we can determine how quickly we need to be surveilled. That to be say 3 years, that to be 5 disease, and that's based on the extent of the disease, how much disease they have. So that's the other family history factors. So the presence of families who has been cholangitis and family history. So how can we do quality surveillance? Quality surveillance, ideally have a high definition skill. So you should have some endoscopy, i.e. you can use an endoscopy. So you can put some dye, such as using carmine into the closer. So because we need to identify these dysplastic areas, and actually as a trained these are hands-on training and these sort of trainings we have. So how would you go to such what's called this target biopsy or random biopsies when you study target and lots of random biopsy that. What is difficult to know what you're looking for? If not the random biopsies, which will be biopsies every 10 centimeters. Unfortunately, this means something on 32 samples that needs to be taken, and your team is a very sport. Also, so it's just using targeted biopsy. You just focus using that spray, you actually will less pure biopsies to actually take these dysplastic lesions. Those areas where availability of sort of running high definition scopes. So the high definition scope can do that's a yes still. High definition scope is a standard definition scope. You do know that you can actually put up dysplastic lesions quite well. So you say that it's high definition enough also from the galaxy to also provide endoscopy. This was a study which was published by recently a couple of years ago, as well as trial, which did show that having just high definition scope is enough, and that would just be enough. We would probably not be this is a percentage study. It was done by some diagnostics. So you've seen the classification, also seeing descriptors, the classification of the other is unrelated or sessile, which if you see as usual. The natural that is slightly completely flat or is in excess. You also want to know if there was an opposite, passive or absent, and you can see the borders clearly. So this is important when you describe a lesion. Why do we do this? Because we want to have the lesion that you see now, the dysplastic lesion is within the involved area of colitis, or is it not in the area of colitis? The reason why we do is we want to colectomy as much as we can, as much as like the surgeons. It's important that we can do colectomy and find these lesions endoscopically So you want to see whether this lesion is on this part of you or not. So it's a big slide, but just simply summarize for you. It basically says that if we do have a visible dysplastic agent in IBD, you have three questions to make. First, you want to consider an EMR or ESC. You want to consider collectory, or you actually think and discuss with the patient. So it's not three things that you want to know. Is thing having also only however, if there's one of those you want to just me straight away. However, we can talk just see. How do you discuss this? I mean, for this. If you put on in London, and it's quite useful that you can actually stratify the patient and have a specialization. So I'm just going to say this dietary hormones, which is useful, and you can see my this is how the diet is and the capsule cell and the car is sprayed, and you choose the right sprayed throughout the colon because you can speed up here and you can see the really collapse lesion. That's calcium, but some templates also helps you to know the bowel so it's very clearly seen here. So the question of what you do with this, you see it. Just one biopsy and send it to an expert who will have a look and also take this polygraph by resection. What will be important is you biopsy the surrounding area to look to see if there are any for the kind of opportunity to talk today. I will talk here and I'm happy to take any questions. Thank you.
Thank you, Dr. Tawfiq. Are you able to hear us? Okay. I think the session is now open. Discussion.
Thank you very much, Chairpersons, Dr. Hema, Vijay Lakshmi, Dr. A. Sangameshwaran, Dr. N. Arun, for your valuable time. Really appreciate it. Thank you. Now we go for the last session in this session 5, which is the panel discussion. So we invite Dr. P. Paramanayagam to be the moderator. We have some claps coming. So very, very wanted person, I think. Doctor, the forum is yours. And now I call the panelists, Dr. Purselvi Rajan, Dr. M. Preeti, Dr. B. Mahadevan, Dr. K.J. Raghunath, Dr. Joseph Jensing Babu. I request all of you to kindly take your seat on the panel. Thank you.
Good evening. Good evening to all. I think we're coming towards the end of this long day of discussions. I think this is the last session that we will start with. I think I'm joined by 5 eminent panelists here, 4 gastroenterologists and a surgeon, 1 surgeon to help us through the discussion. So we'll start off. The first case for the day is about colonic stricture in IBD. And this has been discussed in the previous case scenario. So again, the question comes whether it's benign or malignant. So we'll start off with the case scenario, then discuss the pros and cons and how to go about doing it. And this is the case for preparation of this case have been held by Dr. Priyansh, who is a registrar at Apollo Hospital. So he's a 27-year-old young man who had been diagnosed with ulcerative colitis about 10 years ago at his hometown in Bengal. Treatment details are not very clear. We don't have much of his baseline details available to us, but he has been treated with salsipyrin and prednisolone. He has been on irregular treatment, has had multiple episodes of flares for which he has been treated, but has never been compliant with treatment. He discontinued his treatment 4 years back. Right now, he's presented now with loose stools mixed with blood and mucus, Bristol 6/7 scale for the last 2 years or so, and has a significant weight loss, about 10 kgs. No abdominal pain or fever. On examination, he's pale. Abdomen is soft, non-tender. No sinuses, no fistulas that we see. His lab shows anemia, hemoglobin of 8, WBC and platelets on normal. CRP not too raised, just about normal, 5 milligrams per deciliter, which is little unusual. He undergoes a colonoscopy. The plan is to see if there's any active disease, what are we dealing with. Interestingly, when the scope is passed up to 40 centimeters, when the rectum and sigmoid shows a lot of ulceration and inflammation, UCI is of 5. But at 40 centimeters from the anal verge, there is a circumferential liminal narrowing with ulceration in the proximal sigmoid. Multiple biopsies are taken, but then standard scope could not be passed beyond. So it was changed over to an endoscope, but still this stricture could not be traversed. So he undergoes a CT abdomen to assess what's happening proximally. So here we do see that there is a tight narrowing stricture here with mild upstream dilatation and some nodes around in the mesentery as well. So CT says is an acute on chronic ulcerative colitis with backwash ileitis changes and a short segment, moderate to severe stricture at the distal descending colon with a few nodes. So the question to the panelists is like, first, again, one, it was recently discussed, is it a benign stricture or is it a malignant stricture? I would request Dr. Purchelvi to tell us about what proportion of chronic strictures are malignant in the setting of IBD. Well, is it most often, is it benign or is it malignant? What would be your thoughts?
Various studies have shown, various RCTs, retrospective studies have shown different data of the colonic strictures in IBD turning malignant. Mostly the range of colonic strictures during the follow-up turning malignant is around 3.5% at the end of 10 years and up to 5% at the end of 20 years follow.
So predominantly, I think majority has still been in a small proportion, maybe about 5 to 10% to could be harboring.
Colitis at the time of diagnosis. And with this proximal diagnosis, especially proximal colonic stricture in a background of long-standing IBD. That is as an index stricture in a background of a long-standing IBD. These would be warning signs to look out for malignancy in this therapy.
There are some pointers that can help us. But the question is, how do we go about evaluating?
I mean, just now we had a talk about detecting dysplasias and IBD, but do advanced endoscopic imaging methods help differentiate between malignant or benign colonic strictures and IBD? Dr. Mahababan? Thanks.
So, pertaining to the stricture is concerned, I don't think any tools to identify that's a benign or malignant. You need to take biopsies as many as possible. Still, you are not very sure whether you are dealing with a malignant or a benign strictures. So, I mean, there are no endoscopic tool per se to identify this benign or malignant based on endoscopy.
And I mean, anything in the audience, anybody want to add anything, their experience? Is there anything else? Is there any endoscopic pointers, anything that will help us have an idea as to whether it could be benign or malignant, short of a biopsy? Vascularity. So more vascular, you feel it's likely to be malignant.
Or tuber vessels.
Adenomas. Okay. Sorry? Exactly. That's what I'm going to
make a difference.
So that's what I mean. It could only be pointers, but if the biopsy comes back as non-malignant, let us say it's benign stricture, if it comes back, are we happy that it is only benign? Are we reasonably sure that it is not malignant? How could that be? Anybody can have that question answer.
A negative biopsy does not rule out malignancy. And I don't think, I mean, so many papers and so many studies have shown that really there is no endoscopic tool per se. Diagnostic criteria should include imaging, again, which may not be conclusive, but may all be additive to give you a leaning either towards benign or malignant, but negativity definitely does not rule out malignancy. In fact, resected specimens for features of obstruction have shown malignancy, which only goes to say that endoscopy and biopsy is not the gold standard to rule out malignancy.
So, I mean, in the morning we did hear about a lot of endoscopic options for strictures. So, can I mean, whatever possible options that we had some balloon dilatations. We heard about stricturoplasties being done where you cut open and then place some clips to keep it patent. So, can endoscopic therapy be considered in such a setting at all, or is it only going to be surgery? Possibly.
Retrospective studies and the outcome has been studied to be up to the success rate was up to 30% and the follow-up of 40 months. So the dilatation, endoscopic volume dilatation can be performed for a native or anastomotic stricture up to 4 to 5 centimeters, and graded sequential dilatation, balloon dilatation is done up to 18 to 20 millimeters. But EPD is not recommended when there is an associated access or any access to the stricture, access or fistulas, and when any abscess or fistulas are there adjacent to the strictures, EPD is generally not recommended, but it is not contraindicated if there is any inflammation or a superficial ulceration. And in the morning, we have heard a lot about stricturoplasty and stricturotomy. So this can be recommended.
So, I mean, if you're able to balloon dilate and if you're able to pass a stricture, I mean, what is the advantage of doing it at all? Like, I mean, does it add to the evaluation?
The idea is actually like we are dealing a case of an ulcerative colitis. It's in Crohn's disease, it's a transmural. We know that it's obviously stricture is a common phenomenon, but any strictures in ulcerative colitis should be viewed very cautiously. And it's not so common we come across the strictures in a very late stage. And whether it depends on whether scope is possible or not possible and the length of the stricture. And moreover, before any procedure, it need to be discussed with the MDD team. Actually, it will be discussed with the surgeon. Not straight away, just because patient with us, we should not go and dilate the patient. So you need to discuss with the surgeons as well as the radiologists. Even in fact, discuss with the patient relatives and what is the idea of doing a dilatation and what is the advantage of it. One is if you dilate, you can go and examine proximal lesion. If always there is a synchronous disease can be there. That is a one problem. Repeated dilatation, patient may need to go for dilatation and screening. So when viewing this thing, whether patient can be taken up for surgery or not. So prior hand dilatation, you need to discuss and then you need to decide.
Sure. So to the question to surgeon here, will endoscopic biopsy result modify your surgical plan? Suppose a patient ends up with you with a stricture, it's about the proximal descending colon. Would you offer, surgery straight away? Do you wait for the biopsy report or do you go straight to surgery?
No, if the patient is having a tight stricture, which we are not passing, patient is 27 years old, got severe colitis, I just think, this is going to be surgery one time or the other. Whatever you do. This is my understanding of whatever other therapeutic options that are there in medical tree. I just find that they eventually come. So I just discuss with them, whether they are willing to go through this or consider definitive surgical thing. And if it is surgery, you always assume that the structural lesion that you are dealing with is malignant. There's no point in thinking that it is not malignant and operating and then find that you've not done the nodal clearance. And it's easier to do surgery, at the mesopolic root level rather than keeping to the. So you have lesser vessels to deal with. I think it's a simpler operation considering that it's.
So it'll be like an oncological surgery is what you prefer. But in this gentleman, suppose I'd say this 27-year-old is a poorly controlled ulcerative colitis, presents with stricture. What would be the surgery that we offer? It's a proctocolectomy or is it just a segmental resection that?
I would think, ulcerative colitis, I really don't know whether he had pancolitis, but even otherwise, I would probably counsel him to consider total colectomy.
With a pouch?
Again, a pouch, first of all, I know that there is a stigma with the stoma. The patients are probably terribly concerned about the stoma. I'm not entirely sure whether the medical community also looks at it like that. The ileostomy, if they really wanted continent, can be done, but it comes with its own problems. Trying to construct a continent ileostomy is technically possible, but comes with significant, additional surgical stress to the patient, sometimes fails and all that. So once you counsel them, well, I personally think most of them would opt for a end ileostomy, and especially in this case, the rectum was involved. So I think ideal is to do a proper colectomy and give them an end ileostomy once and for all.
Right. So what is the house feel? What options are there? Like, do you have any difference of opinion? Yes, please, sir. Mike is there.
He is a young patient with a stricture in the left colon. My option would be to do a total colectomy, ileostomy, and a mucus fistula. Observe him for 12 months. If there is no recurrence, then do a complete proctectomy and give a pouch.
So two-stage procedure. Those things. Okay.
I have one comment. Actually, yes. Always we think the stricture is always suggestive of malignancy, but it may not be true. Because this one of the literature which is published very recently that stricture is always not a de novo or a sign of malignancy.
Yeah. That's not even had it. Like only 10% are actually malignant in the setting of IBD also.
So whether the patient is symptomatic, age into consideration, and whether they are responding to biological, there are many other factors which decide that to go with the surgery or just to watch and do surveillance.
But if short of surgery, do we have good medical options when the patient is already strictured?
So if it's symptomatic, definitely you need to go for surgery. Symptomatic strictures which are not dilatable, can't enable to dilate and pass a smoke. So definitely you need to do a surgery.
Suppose we end up on doing endoscopic therapy, how do we follow it up? Like what will be our protocol to follow these patients? Suppose he's not ready for surgery. Let us say, suppose the patient is not right away ready for a surgery and you opt for endoscopic balloon dilatation or endoscopic therapy. So what would be the follow-up that you would suggest?
Actually, in fact, most of the data is for Crohn's disease. In fact, there are no clear guidelines like how often you need to after dilatation, how often you have to go and screen. It depends on the, most of the patients with pancolitis, definitely when there is no dysplasia is there, and you need to every 2 to 3 years. Depends on the underlying pathology.
But so This patient, coming back to this patient, his biopsy from the sigmoid stricture had shown a poorly differentiated adenocarcinoma with sigmoid cell features in a background of severe chronic active colitis with mucosal ulceration and granulation tissue. MDT discussion was done, and finally surgery was offered, followed by adjuvant chemo. Total proctocolectomy with ileal J pouch was constructed with ileoanal anastomosis and the diverting loop ileostomy. Sigmoid colon, on intra, we found a sigmoid colon stricture for about 8 to 10 centimeters length without any local infiltration, no peritoneal serosal deposits or solid organ deposits or ascites. So histopathology came back as T3 lesion with N2 nodes, sigmoid cell carcinoma, in the background of chronic ulcerative colitis. So he's doing well, and I think he's undergoing his chemo right now. So coming back to the risk of again the colorectal cancer and IBD, we have heard that we generally believe that colorectal cancers are much less common in India, compared to West. Dr. Joseph, what your comments in general, in a general population, the risk of colon polyps or malignancy is less. But does it translate in a similar way to patients with IBD in India?
CRC, IBD, it is more younger in onset, usually around 40 years, whereas in sporadic, it is 60 years and above. And it is more in the IBD CRC is more on the right side of the colon, and more metachronous, more synchronous lesion is seen. And prognosis is poor, and there is high mortality rate, high obstructive symptoms in the IBD CRC.
So the outcomes are much poorer when you have a CRC in the background of IBD. And does it differ in India? Are we at a lesser risk? Are we at more risk compared to the West? What is being
lesser risk compared to West?
But I think of late, I think from a group from Delhi, particularly Dr. Ahuja, Vineet Ahuja's group has shown that the risk is almost equal nowadays. Recent reports say that on follow-up over the next 2 to 3 decades, it seems to match whatever data is coming up from the West. So even though the risk of sporadic colorectal cancer in the general population is less in India, when patients develop an IBD and when we're following on patients who develop colorectal cancers in the background of IBD, I think we run the same risk as it is in the West, what has been reported in the literature. Yes, please.
I think on CMC, data that was published in 2005, the incidence of malignancy in colorectal, IBD, the background of IBD is low.
Correct.
Compared to the.
So it's like earlier studies, but now the current one, what they have published in like 3 years back, has been coming from.
Probably the cumulative incidence after the second or third decade probably
seems to go up.
So it's going up because of the long duration of illness.
Again, the duration of the disease seems to matter, and I think we run the same risk as in the West once the duration of the disease is pretty long. So what are the risk factors for developing CRC, colorectal cancers in the background of IBD? I think Dr. Tawfiq had discussed about this, so I can just go through this. Next.
Pancolitis, or in Crohn's, if there is at least more than 30 to 50% colonic involvement, moderate to severe endoscopic and histological active inflammation sustained over time, history of primary sclerosing cholangitis, family history of colorectal cancers in first degree relatives at age less than 50 years, and also any presence of stricture or dysplasia. They all fall into high risk and have to be screened every 1 year.
So when do we start screening patients with IBD? When does the risk really increase? We saw that by the second or third decade, it is as bad, but when should we be concerned about looking for colorectal cancers or dysplastic lesions?
Generally 8 to 10 years of all IBDs. And if you have look at the pancolitis, at least 8 years you have to start screening. Or left-sided colitis, that is 12 to 15 years. This is what guidelines says. And depends on the high risk factor, high risk or average risk or intermediate risk or low risk. So based on that, the screening modality varies. The high risk, you need to do it every year. And if it is intermediate, every 3 years, then the low risk, that may be every 5 years.
Enough. So I think these are basically whatever is being exposed or being told in the West. Probably we don't have individual data from India, but I think we are just following whatever is being explained in the West. Is there any role of any chemo prevention for cholera? Has been proven role for chemo prevention when we know that, there are so many areas where we see, like in hepatitis and liver disease, where we see that once you control the inflammation, possibly the risk of cancers come down. But has it proven or has it translated in IBD? What has been the discussion? Joseph.
CRC and IBD follows that inflammation dysplasia pathway.
So there is anecdotal reports that if there is good control of inflammation, there is a reduction. But this inflammatory, we can give mesalamine, immunomodulators and biologicals have been tried in various studies, but there is it's only a conflicting data. And other things like which doesn't reduce inflammation like UDCA and folic is also being tried, but there is no guidelines. There is no proper guidelines for these drugs.
That's right. So, so many drugs are being tried. I mean, anti-TNFs are all, but I think right now we don't have enough data to say that they prevent colorectal cancers. They're very good at controlling inflammation, but whether the risk of colorectal malignancies come down is not very clear. So to summarize this case, I mean, we've looked at what are the management issues in colonic strictures. I think it's complex, about 10% or less than 10% could be malignant. So always there is a worry that we may be missing out on malignancy, particularly in colonic strictures complicating IBD. Surgery as a standalone therapy has been there for a long time, but there are certain niche areas where you can think of endoscopic options also, but this has to come after a good multidisciplinary team which reviews it in consultation with the patient. And here, IBD-related colorectal cancer is likely to be as common in India as in the West. And surveillance colonoscopy should ideally begin after about 8 to 10 years of diagnosis. And the surveillance interval varies according to the high-risk features or whether they fall into the moderate or the low-risk features. And at present, unfortunately, we don't have any proven chemoprevention strategies for IBD-related colorectal cancers. If there are any questions or anything that the House would want to ask before we move to the second case, any other points that they would like to discuss? Sorry. Mike, please.
How frequently will be going for the dilatation, sir? In case of stricture?
How frequently do the dilatation?
Once in 4 weeks or 8 weeks, or what is the period interval will be taking?
They are not symptomatic, they can take them between once. If they become symptomatic,
As early as possible. But will it also change depending on the activity of the disease surrounding it? If there's an active IBD, we also treat the disease per se and then try and see if they require one. Yes, sir. Okay.
This patient has got ulcerative colitis, which is predominantly a mucosal illness. If you see a stricture at any point in UC, do you think we should strongly suspect malignancy rather than?
That's what the data is. That's about 5 to 10%.
But we don't see these strictures in UC.
I agree. But again, the data says that only about 5 to 10% are actually malignant. The rest are still benign. So, I mean, yes, sir, please. Yes, we should consider malignancy.
sometimes these UCs, at least a small numbers, they subsequently, they become a Crohn's phenotype. So it need not remain like UC for like some of them are indeterminate. Even UC patient after surgery, you do a bowel surgery, they may develop features of Crohn's disease. Then they can develop a stricture.
Sure. So,
just a question for the panel in the room generally. We've noted today that you use CT quite a lot to assess strictures, inflammation, etc. And in the UK, certainly, the only place we'd use CT really was to look for collections or abscesses. We tend to go straight for an MRI rather than CT on the basis that I guess it shows inflammation versus fibrosis better. Is that about availability of the test, or is there some other reason you do CTs a lot first? Why CT before MRI?
So, like the availability is one, and I think it's more about being much more used to seeing CTs than MR. I think that is possibly the reason.
Physicians, we don't see MR
of MR
as well. We at least interpret something out of CT, but MRI is
I think
like US sometime when we started US.
I think surgeons are also much more comfortable with more often with CTs. Exactly.
I have a odd question. There was some questioning about how frequently would you be considering dilatation. After how many dilatations would you consider surgery?
Specific guideline. So it all depends on what the patient wants.
It is said about, as PT has said, 30 to 40% of the restricted strictures
can have
dysplasia.
True.
You have to consider resection only as the choice.
It is easier if it is ulcerative colitis. It is more difficult if it is chronic.
This. Or in the rectum, when it was excised, they found those low strictures were harboring actually dysplasia, about 30 to 40%.
Dysplasia will be there even in places where there is no picture.
You may have a low grade dysplasia and you may have symptoms, high dysplasia, the other side of the colon. That's why you take 40 number of biopsies actually.
So the issue here, I think, is UC is easier in the sense that you do not see multiple strictures. And as everyone agrees, it's a mucosal disease. The problem does not actually occur in UC. The worrisome fact is that malignancy is as common as in Crohn's, as you would otherwise maybe think differently. The challenge lies in Crohn's disease with a stricture. Then comes the problem, is it fibrotic? Is it inflammatory? Do you resect or do you look all out for malignancy? I think the challenge lies more in Crohn's disease. I don't know. Ulcerative colitis, yes, we rarely see strictures. And actually, I could not find a comparison of the incidence of strictures in UC vis-a-vis Crohn's disease to actually tell you how many of them end up with strictures throughout the course of disease. While stricturing in Crohn's is accepted. So this case, perhaps the problem was not in diagnosis, but also to, I think, teaching points, what I think is the necessity to maximize therapy, the necessity for patient compliance in therapy, and the necessity for regular surveillance, especially this is a young fellow who's had UC at the age of 17. So even the index physician should be aware of the fact that he is more at a risk for eventual malignancy compared to somebody in the third or fourth decade. I think those were also learning points.
Sure.
Dr. Profik mentioned about green endoscopy. If you do 40, 70 biopsies, you will have so many bottles of plastic bottle to dispose. And
But what is the cost of saving a life? I mean, one has to balance both.
and also you exploit the pathologist to look at so many biopsies, you know.
It's their job. So coming to the second case.
Sorry. Last question,
Sure.
if you'd allow. See, this little guy was diagnosed at 15 or 16 with severe ulcerative colitis. At 27, he's got signet cell adenocarcinoma, which is T3. Now, the next question is, should you even consider colectomy much early? Even before you look for dysplasia and all this?
No,
I mean, that's the only thing which would have actually saved him. I'm not entirely sure, constructing a pouch, giving him an ileostomy, all that is going to really matter to him now.
The problem is if you have been properly followed up properly, if you have taken these medicines, I think 9 out of 10 times they don't end up getting to a T3 malignancy. Probably would have identified much earlier.
You yourself just now said that, giving all these medicines does not prevent malignancy.
Doesn't prevent malignancy, but you will be able to control the follow-up when you will be able to identify them early. That is the whole idea.
Surgery is not completely safe. There will be always some 100 patients. If you do surgery, they will develop complication. Some of them might die.
Then do the surgery with least complication, which is an ileostomy.
No.
Okay. Next case, something more to discuss.
5 is that.
So we'll have something more to discuss.
The important thing about an IBD in a young is to follow them up properly and ensure a mucosal healing.
Yeah.
I think that is what most of them will lack. In fact, I see some of them using steroids by themselves, and there's also the fault with physicians who take. If you can achieve a mucosal healing and get the targeted therapy, I think you don't prevent malignancy, but at the same time, you can probably reduce the incidence of malignancy.
Sure.
Do agree if it's an ulcerative colitis with a stricture, we are always worried.
Right. Let's move to the second clinical scenario. Here's a broader spectrum. A 72-year-old gentleman who has been diagnosed as ulcerative colitis, pancolitis in 1998. Now we are looking at in 2021 somewhere. Had a flare when we've been reasonably well controlled from 98 to 2010. Had a flare in 2010. That time we had you can review the records which shows that colonoscopy showed some scattered ulcers in the rectum with loss of vascular pattern and erythematous mucosa and the entire colon. And a pedunculated polyp was noted in the transverse colon, for which a snap polypectomy was done, which came back as some granulation tissue type polyp. These are the records that he carries with him. Again, he undergoes a screening colonoscopy in 2013. He was well at that time, but rectum and sigmoid still shows some patchy inflammation, small ulcers with loss of vascular pattern. The histopath comes back as some cryst-destructive patchy chronic colitis. There are no polyps noted at this time. He's continued on a maintenance therapy with salsapyrin alone. And from till 2018. For about 20 years, he's been pretty regular with his medicines. But from 2018 on, he stopped his medicines, and in between COVID came and he stopped getting, he stopped, I mean, he didn't even go back to his physician. His comorbids are, he's had a bronchial asthma for which he's well controlled on inhalers. He's undergone a left hip replacement about 6 years back. So this time around, he presents with the flare, with the blood mixed in stools and mucus in stools for the last 3 weeks, 6/7 Bristol scale. It's well in the BMI of 14.9 kg per meter square, no pallor or pleural edema. His abdomen is normal, no significant findings. Hemoglobin is reasonably good, 11. CRP is raised. And there was a sigmoidoscopy that shows loss of vascular pattern with few erosions and friability, contiguously involving the rectum and the sigmoid, and a few small 3 to 5 millimeter sessile polyps over the distal rectum, as you see there, and the biopsies are done. And histopathology, it comes back as a mild to moderate chronic colitis with focal activity and gland distortion. The rectal polyps comes back as superficial fragments of villus adenoma with low-grade to focal high-grade dysplasia. So sigmoidoscopy was just done because we thought it was an active disease. So an intercolon was not done at that point in time. So coming back, I mean, we just now heard a talk by Dr. Tawfiq about the current accepted terminology. Can we go through that again for the benefit? Please, Dr. Mahadevan or Dr. Purselvi, anybody? Take it.
The terminology to describe dysplasia are either polypoid, non-polypoid, or invisible dysplasia. In polypoid, it can be sessile or pedunculated, and non-polypoid, it can be flat, flat elevated, or flat depressed. And invisible dysplasia not seen by the endoscopist within presently or in the previously inflamed mucosa. In addition to this Paris classification, we also report the lesion size, morphology, border clarity, ulceration, location, if within the area of the colitis, and completeness of resection, if any special technique is used to visualize the lesion.
So, I mean, there are some of the terminologies that are used like
KLM, that is dysplasia associated lesion or mass, and adenoma dysplasia are no longer used.
The Paris classification. So, I mean, we heard him talk, but I think there's a little bit. I think Dr. Marvin can guide us. What recommendation for screening with a white light endoscopy for the biopsy protocol that you would want to follow? This kind of.
Ideally, the recommended is high definition colonoscope, that is recommended. In addition to that, if you have a facility for NBI or dye-based endoscopy, is preferable. And the most important thing is a targeted biopsy is the preferred options. And there are situations where there is an inflammation or a tubular colon or some, PSC. There are specific situations you can take random biopsies at every 10 centimeter, 4 quadrant biopsies can be done. Exceptional. Most of the situation you need to take a targeted biopsy wherever there is any, abnormal visible lesions.
Yeah, but I think we just now heard that if you do a white light endoscopy, I think apart from biopsying the suspicious lesions, I think it probably is worthwhile taking targeted biopsies in each segment when we do just a plain white light endoscopy. But is there any better role? I mean, Dr. Preeti can answer that. Is there a role for this chromoendoscopy or an NBI in detecting dysplasias?
If you look at comparisons with the high definition white light versus say chromoendoscopy or NBI, the detection of dysplasia or its after effects is somewhat similar. Rather, one does not offer a significantly higher benefit over the other. However, if the initial endoscopy has been white light and you biopsy normal looking areas which show evidence of dysplasia, this has to be then followed up either by a dedicated NBI or by a good chromoendoscopy during withdrawal. More important than all this is to perform even a good white light high definition endoscopy, careful surveillance. That is more important than taking random biopsies. So a careful surveillance over the entire colon during withdrawal is important. So if you actually, at the end of the day, both are similar in terms of yield, but this would supplement, especially when you found areas of dysplasia. One other place where NBI or chromoendoscopy may be useful is when there is extensive polyposis in the colon, whether it's pseudo or inflammatory polyps. You want to see whether there is polyps other than these two. There, a bizarre vascular morphology, or polyps in the absence of adjacent ulceration of inflammation, where there's an index of suspicion of malignancy. Here, NBI might aid to delineate a better vascular aberration or morphology in those areas.
Right. One of the common problems that we face is, like particularly in ulcerative colitis or Crohn's, is that quite a few patients have pseudopolyps. So is there a way of differentiating one from another? Yeah, I understand that when you say when you use a chromoendoscopy or a narrowband, you are able to pick up additional subtle polyps which we don't see on white light. But whatever you see, when you see large pseudopolyps, which we think is pseudopolyp, is there a way of telling one from another endoscopically? Or do we go about resecting everything? Well, what should be done?
Definitely not. Resection en masse or large-scale resection is, or even biopsy is actually not recommended. It's not a viable option. Pseudopolyps or inflammatory polyps. Pseudopolyps per se are normal mucosa. It's the inflammatory polyps or other polyps that cause confusion. NBI is important as an adjunct, but also it depends on where pseudopolyps are found. If they are found in between areas of ulceration, and they look more glistening, more frond-like or villiform, likelier to be. These are all only endoscopically suggestive criteria to say they may be pseudo vis-a-vis inflammatory pseudopolyps. If you find isolated polyps or lateral spreading polyps, polyps with bizarre shapes in the absence of active inflammation in surrounding areas, these might, push the endoscopist to look out for malignancy in these areas. Then decide on polypectomy vis-a-vis resection.
Anybody else has anything more to add or? No, yes, sir, please. So, Mike is there.
Just going back to that biopsy that was taken on the rectosigmoid sessile polyp. Anytime you see a sessile polyp where there is consideration for EMR, then or at a later time, it is not a good thing to take biopsies, because you're going to create fibrosis, and that's going to be pretty difficult later to do a proper endoscopic resection.
So, I mean, what would be the way forward, and what do you do in your practice? Just
it has to be an endoscopic resection.
On the same setting, or you call back sometime later?
Call back sometime later, or if you don't do it, you just send it to the person who is doing it at a later time. But that person will have the disadvantage of fibrosis doing the procedure if you have taken biopsies.
I mean, how significant is this? I mean, with the EMR and with these ESDs, I mean, I do understand that there is a risk, but if, I mean, does it, I understand that if it can be completely en masse, it can be removed, it is good. But if it shows an invasive cancer, like then you see a dysplasia here, so the decision goes in favor of surgery.
It may not be the case.
Yes. So, I mean, that's why the question is, we have targeted, then we have this question of this routine random biopsies that you take in segments everywhere, even though not even in suspicious areas. The recommendation still now, when you do a surveillance colonoscopy, is to take biopsies at certain areas. So why is that?
No, rest of the areas are fine, but if you see a sessile polyp, that has to be completely resected. And then if you are capable of doing it there and then, that's fine. If not, if you're going to do it at a later time, you or somebody else, don't take biopsies.
Not to take biopsies. Does everyone agree with that, or is there any difference of opinion that you would have to?
In fact, ulcerative colitis will have a lot of inflammation or submucosal fibrosis already, which is very existing in this particular case. Is it going to make a difference? Because I mean, here there is, without inflammation, you can able to identify, I mean, characterize the lesion. Already inflammation and scarring, and already the entire morphology will be changed. You cannot completely identify only with I mean, high definition colonoscope alone. This is my humble opinion.
But macroscopically, what we have seen as a sessile lesion, that has to come out completely.
Completely. Okay. So, and this gentleman, what we did was we treated him, since it was an active disease, he gets treated for his flare. That's a repeat colonoscopy done about 3 months later. Again, a question to the floor. In Barrett's and other places where we find an active inflammation, we repeat the scopies after we treat them for reflex, after a good course of PPI and all that. And that sometimes seems to downgrade the high grade to low grade, or probably we assess as better. But does it hold good for IBD also? Like when you have to take a call on business things. Well, this man is 75, but in general, what I say is, do we repeat Or do we take a call on the dysplasia when there's an active inflammation? Or should we consider, or when do we classify it as high grade, low grade, or should we take it only when it is quiescent?
So it is quite unpredictable to reach the same same place, and we can't have measurements. 30 centimeters. So next time also we reach the same place.
If it is a visible lesion, if it is a visible lesion like this, segment.
Second time what you see may not be the same.
Yes, please.
We, first of all, completely agree with our friend from North Dakota. I think unless you can resect a polyp completely, don't even start. Don't biopsy it, don't partial resect it. But the second thing we use quite a lot is tattoos. So if we're not sure whether it'll come off, we don't biopsy, take photos, put some tattoos in, then the guy with more time or better skills will come back and take the polyp off. And the last thing to say about that whole situation is that we tend to bring them back if the consent process changes. So if they're given consent for colonoscopy, but this is a lesion with a high risk of bleeding or perforation, we won't do it on the day. We'll bring them back with a new consent process next time.
But if we find a polyp when there is an active inflammation, we don't do anything at that point in time, right? Or what we do?
I mean, if it's resectable, we can do it. I'll do it.
Have you ever considered doing this endoscopic resection with the laparoscopic control?
Yeah, we do those occasionally. So the difficult ones at high risk, we'll take to theatre and do with a surgeon ready to go in the laparoscope if and when we make a mess.
Right. Okay. So the gentleman still showed some amount of activity. The rectal polyp, now the report comes back as low-grade dysplasia. So how do we manage patients with, again, comes back to the visible lesion with dysplasia? So Dr. Joseph, what would be the current guidelines, whatever is there is on the
if the visible lesion is less than 2 centimeters in size and it's resectable, there is no features of any malignancy, go for endoscopic snap polypectomy and then surveillance. If there is a high-grade dysplasia, every 3 to 6 months, we have to do screening colonoscopy. And if the lesion is more than 1 centimeter and low-grade dysplasia every 12 months, and then if it is less than 1 centimeter and low-grade dysplasia every 2 years. And the lesion is, if it is more than 2 centimeter complex lesion and laterally spreading lesion and incomplete resection after several attempts and local resection, endoscopic resection, we have to discuss with the surgical team and or we can go with the endoscopic resection or submucosal dissection and intensive follow-up should be done. And every 3 to 6 months, the screening follow-up colonoscopy done. If the polyp size is more than large polyp, unresectable, invasive cancer on histology, we have to hand it over to the surgeon.
So, I mean, this is the last point that I can. If it is an invasive cancer on histology, should we, even have, does it mean, possibly, I think that is what you were thinking. We had a talk in the morning where they said that superficial biopsies sometimes may give only a low-grade dysplasia. Sometimes when you do an en-bloc resection, as has been discussed, possibly you find some invasive malignancy, deeper down in the specimen. So I think that's the point that is being made. So again, if it is a uniform, it's in this patient, probably we just found one area where it showed some polypoid lesions. Suppose it was multiple polypoid lesions in multiple segments of the colon. Is it surgery or is it endoscopic therapy?
Multifocal, high-grade dysplasia is always better go for surgery.
For a surgery. Right. So it will go. And this gentleman had a CT abdomen done that shows just diffuse subtle wall thickening. It's 2 small polyps, no other signs of invasion, and has a snap polypectomy done. It comes back as low-grade dysplasia. Again, surgeon's take on this. How often do we keep doing surveillance colonoscopies? When do you think of upfront surgery in ulcerative colitis vis-a-vis Crohn's?
Now, when you don't have a strong suspicion of malignancy and the patient is not symptomatic and all that.
Like high-grade dysplasias, multifocal.
High-grade dysplasias, multifocal, with generally, I would think you just have to discuss with the patient if they are willing to, go through periodic scopies and we're not looking at any, significant tumor load and, we're not thinking that it's going to be advanced and all that in the near future, then I think if they're willing to have the scopies, then yeah, especially when you say it's Crohn's. I'm scared of operating on patients with Crohn's. Like, if it's ulcerative colitis, I feel a little bit more comfortable that, it's done. Crohn's, I just feel that they would be coming back to you if
Yeah.
you've done a conservative resection, especially.
So I think finally it boils down to about having an open chat with the patient and then taking it further. I think before I close, I think, is there any other thing that the house would want to discuss? Yes.
Expert gastroenterologist. What's the criteria to define expert gastroenterologist?
Some high center which has a high volume. I think. Mike, please. So the question is, how do you define expert endoscopist? How do you define an expert pathologist? So I mean, I think
method, or we can go for
what was the more experience, the panelists here?
So they're using for various criteria, for 28. What is your opinion? Twice can all this, all the rational, what is the criteria to define all those steps?
Actually, spray-based method is time-consuming, definitely, and NBA will be a very less time-consuming. You can switch on and off. That is more easy and convenient.
That has been shown that, yes, sir, please. So, Mike.
Very much. Do you augment the bowel preparation prior to dye spray? We always find that dye spray, if the bowel preparation is good, it works well, yes, and is good at identifying focal lesions. But if the bowel preparation is poor in any way at all, it just becomes a mess. And then we revert to random quadrantic biopsies. Is it the same here? Do you have dedicated lists for screening these patients as well? It's something that has been encouraged, and I think should be encouraged.
No, we don't actually. Okay. So I think we had a good discussion. I mean, when this patient tells us more about we learned a little bit about the new technologies for describing dysplasia, the role of white light endoscopy, how to biopsy when we do that, and how to biopsy if we use a chroma endoscopy or a video chroma endoscopy. And for endoscopic examinations, as has been discussed, has been brought up, if it is less than 2 centimeters, if it is endoscopically resectable, better to resect rather than biopsy. If not doing it at the same time, better to tattoo and come back later, because if the location is unfavorable, huge, then probably you should consider sending across to a surgeon. And if it's invisible dysplasia, as has been discussed now, refer to a higher center or you use a chroma endoscopy. And if it shows high grade or multifocal, I think surgery is the way out. So at the end, I think we need to have a good surgical team to support you, a pathologist and a gastroenterologist, and more importantly, an open talk with the patient to see what can best be done for the patient. And the dedicated list. Thank you so much. Thank all the panelists. Thank all the panelists as well. Thank you.
Thank you, Dr. Pirnagam, and thanks a lot, panelists, for your valuable time. And we come to the end of the session. This conclave on IBD, inflammatory bowel disease, is endorsed by Society of Gastrointestinal Endoscopy India, Indian Society of Gastroenterology Tamil Nadu chapter. A closing note will be high tea is being served. Please do the networking. And before that, a closing note by Doctor will be giving us the closing note. Thank you very much.
So I think you'll all agree that you had a wonderful day, a lot of learning. So I think I should probably congratulate the team who planned the meeting. I would like to hand over the mic to Dr. Basumani. He will be just thanking everybody.
It's all your idea, sir. My thanks should begin with you, with your mentorship, guidance, and maybe a good task master is. So Anand is here. Anand, stand up. Karthik, and Seshu, Prama, and the whole team. No, so the excellent support from postgraduates, Prayansh, and not to mention the world-class speakers from UK, USA, and from North India and South India, and all the national and the local faculty speakers, but mostly the delegation. Without your participation, this would have fallen flat. So you stayed and supported till the end, and the pharma industry, the hotel ambience, and the compere, everybody supported and made this success. Thank you, one and all, and Santosh, media, and everybody. I thank one and all for making this event a very memorable and enjoyable one. Thank you. Please join for the high tea. Yeah.
Thank you. As I said, this has been organized by Tamil Nadu Gastroenterologist Trust and Apollo Hospitals, touching lives. Thank you very much for this beautiful day. Thank you.